Mic testing? No. Can you increase? Yes, yes, please. Thanks. Can you increase the volume for this, please? Thank you. Can I request everyone to please be seated? It's time for us to start the seminar. May I request everyone who's outside to please come inside the hall. Can I also request everyone to put your cell phones on silent or switch it off, whatever is convenient for you. Thank you, Dr. Srivastava, for that very important point. Hello. Can I please request everyone outside to please come inside the hall? We'll be starting the seminar now. Kindly be seated, and please take a seat. Can we please close the doors? Thank you. May I start then? Are we good to start? Okay, all right. Good morning, everyone. I am Shruti Diwan, the anchor for today's seminar on Expanding Breast Cancer Care for India Women, second edition. And it gives me immense pleasure to welcome you all on behalf of the Week Connect, supported by LIC and Fortis. Breast cancer is the most common female cancer worldwide, representing nearly a quarter of all cancers, and in India, now a leading cause of cancer in women. A woman loses her life to breast cancer every 8 minutes in India. In 2020, more than 2 lakh women in India were estimated to have been diagnosed with breast cancer, resulting in more than 90,000 deaths. That's alarming. Late diagnosis, lack of awareness, unavailability of medical facilities, not to forget the patriarchal setup, the taboo associated, the urbane mindset, are just some of the challenges that is faced by our country at every level. The Week, India's largest circulated weekly English news magazine, organizes seminars and feature series focusing on issues that India and the world face, be it sustainability, change, ideas, innovation, through the Week Connect. Today's seminar, organized by the Week Connect, gives us the opportunity to debate, deliberate, and understand the various aspects of breast cancer care. To start the inaugural session, I invite Mr. Prasannan, resident editor, The Week. So please come out on stage, yes. Mr. Rajiv Sadanandan, former Health Secretary, Government of Kerala. Mr. Vishal Chauhan, Joint Secretary, Ministry of Health. Dr. Anurag Srivastava, Director of Surgical Disciplines and Chief of Breast and Endocrine Services, NIMS Jaipur. And Mr. Ramesh, Event Editor, The Week Connect. Yes, please. The cell phones on the silent, please. Okay. Yes, please. To start the seminar, I request Mr. Prasannan to give a welcome address. Mr. R. Prasannan is the resident editor of The Week, New Delhi. His expertise lies in defense and foreign affairs, and he is an ardent follower of history. He has been with The Week for over 40 years since its launch in 1982. Over to you, sir.
Good morning, everybody, and welcome to the week's seminar on spreading breast cancer awareness. This, as Ms. Shruti told you, this is the second edition of this program. It's rarely that we repeat the theme of a seminar, but then the theme that we have got today is one of growing concern in our country. According to a study by Globocon 2020, every 4 minutes, a woman is diagnosed with breast cancer in India. It's a fact worth repeating, every 4 minutes. If this statistic were true of men, I think there would have been more attention and more urgency in tackling this. That speaks enough about the gender bias that half of humanity, and that includes me, bear in their minds, knowingly or unknowingly. The study estimates that in India, breast cancer accounted for 13.5% of all cancers. Current data show that 1 in every 22 women develop breast cancer. By 2030, more women in India will die of breast cancer than any other cancer. Breast cancer in India is different from that in the West. In India, breast cancer hits the younger women. It takes a toll on the lives of women when they are at their prime, when they have most living to do. But there is good news. Research shows that early detection helps save lives. But as women grapple to balance home and work in our patriarchal society, often without support, they put themselves last until it is too late. That's why we are stressing on expanding awareness, which is the theme of this seminar. As you are aware, The Week is the largest circulated English news magazine in India. We have pioneered health reportage among news magazines. Every year we do an extensive and exhaustive survey to rank the best hospitals in the country. The Week also brings out a supplement every fortnight on health. So it's incumbent on us not to just write about the war on cancer, but to lead the way in spreading awareness to fight this cancer disease. We have in this room some of the brightest minds who are grappling with the problem. We will soon have the Honorable Minister of State, Independent Charge for Science and Technology, Government of India, Sri Jitendra Singh here. He has a busy schedule and he has yet accepted our invitation. He is busy in Parliament, 11 o'clock onwards, so after that he said he will come over here. He'll be here around 12:15, and I'm extending an anticipatory welcome now itself to the Honorable Minister. I also welcome our lead speakers, Mr. Rajiv Sadanandan, former Health Secretary of Kerala, Mr. Vishal Chauhan, Joint Secretary, Ministry of Health and Family Welfare, Mr. Professor Anurag Srivastava, Director, National Institute of Medical Science and Research, Jaipur, Professor Chintamani, in charge, Department of Breast and Endocrine, Vardhaman Mahavir Medical College and Safdarjung Hospital. Dr. Ravi Maharotra, Director, Indian Cancer Genomic Atlas. Dr. Vinod Raina, Chairman of Oncosciences Fortis Gurgaon. Professor V. Sinu, Senior Professor, Department of Surgical Discipline, AIIMS. Dr. C.B. Dhanraj, Dean, Patanjali Ayurveda College, Haridwar. Dr. Bhavana Sirohi, Director, Medical Oncology, Balco Medical Center, Nava Raipur, and several other eminent experts who are here. I welcome them all, as also our anchor for the session, Ms. Shruti Devan. I also welcome all other delegates and our invitees who have come here so early in the morning to learn and contribute to the discussions that's going to be spread over the whole day. A warm welcome also to the senior officials from the Life Insurance Corporation of India, who are our biggest supporters, and also from Fortis, who have come, also one of the leading hospital groups in this country, who have come forward to sponsor the seminar today. Thank you.
Thank you, sir. Now we have lighting the lamp ceremony. I request everyone to please gather around the lamp and join in the ceremony. Please, sir. Beautiful, with that lighting of the lamps and diyas around, we light the hope to spread awareness around the dreaded disease which we are all aware of. Thank you, everyone. May I now request Dr. Srivastava to give an introductory keynote. However, I will give a little introduction before you start that. Dr. Anurag Srivastava served as a faculty of surgery at AIIMS, New Delhi for over 30 years. Currently, he's the Director of Surgical Disciplines and in charge of breast services at NIMS, Jaipur. In his tenure, he has worked for various projects, be it initiating National Cancer Screening Program, through National Health Mission, Ministry of Health, or developing training modules for doctors and healthcare workers, or actively engaging in screening training at National Institute of Cancer Prevention and Research. A true philanthropist at heart, he looks at his work as a way to serve, especially the mothers and sisters of the nation. Dr. Srivastava, please.
Thank you, Shruti ji. Sisters and brothers, it fills my heart with joy unspeakable to initiate and talk about this breast seminar on the king of melodies. Let us start with a positive note. This is Shri Shyam Sundar Srivastava, my father's elder brother. This Vasant Panchami, he celebrated his centenary. So we went there. He lives in Lucknow. Is it all permitted to speak a bit of Hindi and English mixed? So हमने उनसे पूछा कि आपकी शतायु होने का रहस्य क्या है, बताइए. Fasting, he said, immediately shouted, fasting. He did a lot of fasting. Every year, there's a month of Malmas. पूरे एक महीने सिर्फ दूध and फल. And every Monday, Tuesday, he used to take only fruits and vegetables. So, and very low salt intake. And then, of course, sattvic lifestyle and yoga, pranayam for 2 hours. From there, we come to this young girl. इसमें दिख रहा है? हाँ, okay. This young girl called Khushi just finished her school at age 20. She had a very large tumor filling the entire breast. The PET scan revealed that the entire body was riddled with innumerable tumor deposits. We lost her in just 6 months, in spite of all the treatment that we know of in AIIMS or anywhere in the world. This is young girl Khushbu, Marang's same young girl. Again, we lost her in just 1 year time. So, ladies and gentlemen, we asked the question, why Khushi lost her Khushi and Khushbu ki Khushbu kyun mit gayi at the prime of her lives. WHO and Globocan have projected that by year 2035, we will have a real pandemic of cancer in general and breast cancer in particular. कोरोना का पैंडेमिक तो आता और चला जाता है, सबको वैक्सीन लग गई, शायद उससे सुरक्षित भी रहें आप. लेकिन ये जो पैंडेमिक होगा, इससे बचना बहुत मुश्किल होगा. तो we have to work on war footing basis now. We have to act now if we want to control the progressive uprise of these curves. Both incidence as well as mortality of cancer, both genders, ladies and gentlemen, will be enormous. And our health system perhaps will not be able to tackle it if we don't act now. And therefore, I thank the week and the entire team for taking this very important, very pertinent question. So what is the key to perfect health? Why Mr. Srivastava lived for 100 years and is still living? Yukta har viharasya yukta cheshtasya karmashu yukta sapnava bodhasya yogo bhavati dukhaha. It is taught to us in Bhagavad Gita, chapter 6, that if your ahar, that is diet, nutrition, is appropriate, modest, vihar, that is lifestyle, early to rise and early to bed, makes a woman and also a man healthy, wealthy and wise. So that was the teaching of our ancestors. We have forgotten that. And of course, you have to have this modest way of living, not only while in awake hours, but also while asleep. Then and then only the yoga will protect you from all illnesses and all sorrows. That is the teaching, and we have forgotten that. So Albert Einstein said that it's important not to stop asking questions. So today we ask the question about this problem. We have to sense the problem and find some solutions which are pertinent to India or Asia, India-centric issues. And then we have to disseminate that useful knowledge across the societies. So, ladies and gentlemen, wise men and women with profound knowledge and wide erudition from the field of medicine, science, and society have gathered here to ponder over the objectives of why this king of melody is striking our young sisters and brothers. And number two, what can be done today to tackle this problem and what can be done in the future to prevent this. Thank you.
Thank you, Dr. Srivastava. I now invite Mr. Sadanandan to give an opening keynote. Mr. Rajiv Sadanandan is the CEO of Health System Transformation Platform, a think tank on health policy and systems in New Delhi. He has worked as Health Secretary of Kerala State, CEO of Rashtriya Swasthya Bima Yojana, a commissioner on the Lancet Global Health Commission, been a member of technical committees set up by UNAIDS and WHO, in addition to holding many other positions in state and central government. As a health secretary, he had overseen the preparation of Kerala's cancer control strategy, developed the guidelines of the Kerala Cancer Grid, and for common cancers during the COVID-19 pandemic. He served as advisor to the Chief Minister of Kerala on management of COVID and is a member of the Technical Advisory Panel of the Pandemic Fund. Please, sir.
Thank you. First of all, let me congratulate to the week for having organized a discussion like this. I think the reason for that has come in Dr. Srivastava's presentation, and we'll keep coming through every presentation, every talk that's going to happen here today. Let me also thank you for inviting me to participate in this and listen to some of the best people who work in this area. Let me initially make a caveat. What I'm going to say is informed by my having been the Health Secretary of Kerala for about 11 years, wrestled with this problem in the problem of cancer in general in Kerala, and also now in my new role, seeing the way it is happening in other states. And a lot of the technical stuff that I'm going to talk about is informed by a function that I performed for about 2 years as the external editor of the global report, WHO Global Report on Cancer. Most of this information is taken from there. So when I was invited to this, I called up a breast cancer expert and told her, look, I've been asked to speak on management of breast cancer. She screamed, what do you know about management of breast cancer? I said, nothing. There are experts here who will talk about that. But the question I'm raising is, what is the extent to which India's health system is equipped to handle the tsunami of breast cancer that is about to strike us? She screamed again and said, it is not equipped to handle. I said, exactly that's exactly what we're going to talk about. And we are happy that Mr. Vishal Chauhan, the Joint Secretary in charge of non-communicable diseases, which also involves the cancer control, is present with us today to share his experience and his knowledge of the policy dimension that the government of India is pursuing. Now, this is the basic structure that I will pursue. Now, this slide actually is not necessary because here I'm talking to preaching to the converted. It is the most prevalent cancer in India, correct me if I'm wrong. And going by international trends and the changes in the determinants of health that is happening in India today, the numbers will go up, not only go up, it will go up exponentially. The other advantage is that most of the prevention measures that we need are what we share with other NCDs, not only with other cancers, but also with other NCDs. So there's a lot of, the advantage of working on breast cancer prevention goes beyond cancers, beyond breast cancer, beyond cancers, and to reach the whole of the health system. Unlike many other cancers, what tempts a health economist, which is what I'm trained as, is the cost effectiveness of this. If we can pick up the cancer at stage 1 and 2, the cure rates are a mouth-watering 98% and 93%. Unfortunately, this is a sad thing that we saw when we were preparing the Kerala Cancer Control Strategy. Unfortunately, most of breast cancers are picked up in stage 3 and 4. This has been intriguing me, and I think I'll deal with that right now. If you take a state like Kerala, we overconsume healthcare, which means that the moment a person has a symptom, that person will contact a clinician. If after that, you are picking up cancer at stage 3 and 4, I think there's some problem on the clinical side, on the side of the providers. That is when we looked at what could be the reason. And what we realized was that the diagnosis of cancer does not figure as a different in the differential diagnosis of most of the clinicians, even when the situation is warranted. And the reason we found was that it does not figure in the curriculum, in the MBBS curriculum of our state. And as someone told me, it won't come in the NEET, it won't come in the examination, so we don't study. So we were so worried by it that we made it mandatory for all the house surgeons to do a 1-week attachment with a cancer center so that cancer is normalized. They start suspecting cancer as part of their differential diagnosis. I hope that works. The other reason is that, I mean, as you will hear as we go today, viable diagnosis and treatment options are available and they're cost effective, and if properly organized, and this is a challenge, this is a issue that I'll leave for discussion. If properly organized, they can be provided in almost all parts of the country, though the way we do it is going to be different. I'll skip the slide. Now, this is something that the cancer epidemiologists here could possibly enlighten us. When we compare the incidence of cancer in India with the incidence of cancer elsewhere, this data seems to suggest that the incidence happens earlier than in other countries. It'll be a topic that will be good to hear the experts on later. The risk factors, again, are well known. There are some that we can control, and then obesity, exercise, and the only one that is specific to the cancer, I mean, the two that are specific to breast cancer are hormone replacement therapy and breastfeeding. And there are other risk factors that we can't control. The importance of these risk factors is that this forms part of the targeting, which I recommend later, should form part of our strategy. As I mentioned before, this has got spin-offs for NCDs, but many of these interventions cannot be done by the health sector. What we realize when we are looking at urban health is that to make a city healthy, there are other interventions we need to do, which includes regulation of tobacco and alcohol consumption, availability of fruits and vegetables, which is much less available than what we think it is, the need for physical activity, which means redesigning our urban spaces. The other big resource I think we are foregoing in the interest of creating awareness is the availability of rural women self-help groups that are now, I find, all across the country. Wherever you go, there's a vibrant women's self-help group. And why aren't we taking this issue to them to say, look, this is something that you should be aware of? And this is the next is a topic that I'll continue throughout my statement. The necessary condition for reducing this the weight of breast cancer is not your tertiary cancer centers, not your quaternary cancer centers. It is a strong primary health care. Unless we are able to ensure that our ASHA workers, our ANMs, our primary care doctors are able to create awareness about breast cancer, and unless the clinical unless people access treatments, I believe it will be difficult to make a dent on cancer in the state. Now, sorry, in the country. Now, this is well known. The early treatment of breast cancer is good, and the idea is to detect cancer early. There are two approaches that are possible. One is population screening, and the other one is an early diagnosis of invasive cancer in people with symptoms and signs of disease. Now, this again is something in which I hope we'll have a discussion. Which is better? That is, as a strategy, no. Ideally, if you're able to screen everybody for cancer, that'll be the best thing to do. But given our situation, which is better? Please look at this diagram. On the left side are the population screening, in which to detect 2 cases, we have to screen the rest of the population. On the other side is the possibility of an early diagnosis. I would submit that in states with weak health systems, early diagnosis is a more feasible option than population screening. I know it's controversial, and I'm doing it deliberately so that we have a discussion around this. Why? One, the amount of resources required for entire population screening is considerably higher. And remember, the time spent on one activity has opportunity cost for the rest of the health system. The second thing is that the average time lag before benefit from cancer screening can be seen is quite large, whereas early diagnosis, the result is immediate. When you look at UK, which is one of the best population screening systems available, 90% of the breast cancer in UK was detected outside the screening program, mostly by primary care physicians. And I think there's a learning for us there. The other problem is that, and the big problem we have is quality assurance. If it is done without quality assurance, it could cause harm, including false positives and false negatives and overdiagnosis. Now, if you want to judge whether our breast cancer screening is effective, the only measure that is valid is what is the extent to which we are able to reduce the mortality, and that's going to take a long time coming. Now, if you are to, what are the conditions we need to create for early diagnosis? One, people have to present. Two, clinicians have to be capable of diagnosis. And as you know, screening without treatment is unethical, so the treatment option should be available. So I think what we need to work on all the three. We need to create awareness, and in many places I've seen that people don't trust the formal health system. We need to create that trust through some of the mechanisms that we can discuss later. The problem that I have seen even in my state with screening is the histopathological and the imaging support that is needed for confirmation of cancer, breast cancer, is not available even at the district level. Now, what the options are available, telepathology, teleradiology, they're available, but we need to recognize that when you're asking people to diagnose, unless we are able to give them support, it's not effective. And then and in many places, the affordable treatment may not be available. I'll skip this. Yeah, these are what we need to do, and then we could take it up during the discussion. Now, the numbers again could differ, but by 2040, WHO estimates 2.61 lakh persons will be living with breast cancer in India, and the amount of, and I believe this is an underestimation, the amount, the facilities that are needed to treat this are huge and is just not available today. And scaling up cancer treatment, I can assure you, as someone who has tried to do it, takes a lot of time. Training people, building the facilities takes a lot of time, and unless we recognize this as a problem and start working on this, I think we'll be heavily underprepared for what happens with. And remember, Indian states differ from each other, and each state, I submit, will have to create a way of what is the best way of providing cancer treatment. And the big issue we have seen in cancer treatment is the quality of cancer treatment, which is it's extremely worrying. I'll leave it at that. And then the need for supportive care, nutrition, infection control, and so on, and also the other appurtenance of cancer care like palliative care, survivorship care, etc., which again is best provided through the primary care system, but currently I think it's not available. Again, I think a feasible cancer care strategy for policymakers would be to organize it incrementally. I would recommend a hierarchy of hospitals to provide the treatment care. We always had the temptation to go in for the state-of-the-art when older technologies and drugs might be cost-effective and still be effective. We need multidisciplinary teams. So, which means that it'll be futile to think any level below the subdivisional hospital, because we'll need surgeons, we'll need physicians, we'll need radiodiagnosis people at least. Forget about radiotherapy at this moment. So my recommendation would be to locate this in a subdivisional hospital, and the facility for imaging and pathological support should be available at least at the state level with at least at the district level with transportation facility for the samples. No state in India has the required number of cancer specialists. So while we might be concerned about the need for specialist care, we have to get reconciled to the fact that general physicians, surgeons, and pathologists may have to be trained on how to manage these cases, at least for the imaginable future. So teleradiology, again, will have to be made available. Now, I would submit that starting a cancer treatment without a multidisciplinary treatment plan is not appropriate. And because the specialties are not available and we can't do multidisciplinary tumor boards in all the hospitals where treatment were to happen, I think we should go in for the virtual tumor boards of the future, which is present today and something we have got used to during the COVID pandemic. I won't go through this because I believe we have people talking about supportive care, survivorship, and rehabilitation, palliative care coming up later. A huge need and heavily underprovided. and I think we need to have a discussion on how we can make the life of our cancer patients more bearable by providing these services. So I leave it at that by saying that this is not only for breast cancer. For every cancer, we need a strategy that covers at least these aspects, which is information, then the HR, the diagnostic and therapeutic infrastructure, drugs, and making part of the essential medicines list, organizing cancer care, and finally, how can be normalized and integrated into the general health services. And finally, the topic I have not touched, because it's a huge topic by itself, the cost of cancer diagnosis and treatment is currently being paid for mostly out of pocket, absolutely unsustainable. So the other question is that how will cancer care be paid for? I think I've generated enough questions to last about 3-4 workshops for the week coming up. Thank you very much for listening to me. Thank you.
Thank you, sir. I now request Mr. Chauhan to give an opening speech. Mr. Vishal Chauhan is an IAS officer of 1998 batch, currently working as Joint Secretary in Ministry of Health and Family Welfare, looking after Policy Division and NCD Division in National Health Mission. Prior to this, he has also been Secretary Agriculture, Managing Director of State Bank of Sikkim, Secretary Health and Medical Education, Secretary Energy, amongst many other. He is an electrical engineer from IIT Roorkee who holds postgraduate diploma in industrial engineering. He has also done Masters of Science in Public Policy and Management from King's College, London. Mr. Vishal Chauhan has wide experience in area of energy and power, finance, health and agriculture. Over to you, sir.
Mr. R. Prasanna, a resident editor for the week. Shri Rajiv Sadananda, sir, former Health Secretary, Government of Kerala. Dr. Anurag Shrivastava, Director of Surgical Discipline, NI MSR, Jaipur, and all the distinguished, eminent people sitting in this hall. First of all, my biodata was telling a lot of things like energy, power, all these things, but I must confess that for the last 5-6 years, I am doing only health. So I have tried to acquire some of the policy-related issues as far as the health is concerned. Now, first of all, I'm very, very thankful to the week for inviting me for this event. This is a very important, agenda or issue before all of us. As per the ICMR study, there has been an epidemiological shift as far as the disease pattern is concerned. In 1990s, more of the people were dying because of the communicable diseases or because of the reproductive child health issues, and only 30% of the people were dying because of the non-communicable diseases. What has happened is that we have really traveled so much as far as the reproductive child health is concerned. The infant mortality rate or maternal mortality rate has drastically come down. And our decline has been much better than global decline, and we are very close to the SDGs. As far as the communicable diseases are concerned, there also we have made a significant, achievements have been made. Now, less people are dying of malaria, etc. And this year we are going to eliminate Kala Azar. There has been drastic decline in the cases of malaria, etc. So what is the new challenges coming up before the health system, and it is a question for all of us, is the non-communicable diseases. Now this is the first, the foremost reason for people are dying because of the non-communicable diseases are the cardiovascular diseases, second in cancer. Now this is very, very, and this issue has been troubling all of us, everybody is putting their head into this, how to, tackle this problem. At the policy level, I must tell you that health ministry, now overall awareness for the health, especially after pandemic, overall consciousness for the health has increased. Now Health Ministry is getting about 25% of the parliament questions are coming only in the Health Ministry. Out of that, we are getting about 10 parliament questions, both in Lok Sabha and Rajya Sabha, about the health every week. So that is a level of awareness about, that is the level of, policy level thinking going on. And also, recently Parliamentary Committee on Health discussed in detail, and they visited various cancer institutes all over the country, how to make cancer affordable and accessible to the people. Now, as far as the Government of India policy is concerned, we have always been saying and believing that preventive and the promotive health is very, very important. And what Dr. Srivastava said, in fact, he summarized everything in one shloka, and I have taken a picture of it. And this is very, very useful because unless we change in our lifestyle or the way we are living, that this non-communicable diseases, we are not going to resolve this problem. So what comes is the promotive health and the preventive health. What is the promotive health? WHO says that no amount of alcohol is safe. So tobacco is the biggest cause of the oral cancer. It's the biggest risk factor. Alcohol, obesity, all these things which Dr. Sadananda sir also explained, that we have to make changes in our lifestyle. So what the new revolution, which is, this is a silent revolution, I say, is that country is now having 1,60,000 health and wellness centers. So these health and wellness centers earlier, which were only looking about the reproductive and child health and little bit of communicable diseases, are majorly into, they are headed by a trained nurse or a Ayurveda doctor. And these they are, now doing lot of screening. They are talking about lot of health and wellness activities. So we have about 190 crore beneficiaries of the health and wellness centers, health and wellness activities. So there is a yoga prescribed at least 10 days in a month, either cycling or Zumba or yoga, some physical activities are recommended. Similarly, for what we eat is also very important. There have been several evidences are there that people who take millet are doing much better as far as the diabetes is concerned. So what we eat and how we behave is very, very important. So this is one aspect of it. The preventive aspect of this, as Sadananda sir was also saying, more than 60%, 80% cases are reporting at the late stage, where chances of survival are very, very less. So we have a screening program, and as per the report sent by the states, about 16 crore people have been screened for the breast cancer, 10 crore people have been screened for the cervical cancer. But there is a challenge here that we still need to strengthen the continuum of the care mechanism. People are screened, but it is not taken to a logical conclusion. So that is a big challenge before us. So what we have done is that, as sir was saying, that we have to go for the confirmatory diagnostic test. So in our guideline, we have made changes. We are ensuring that every district should have a mammography machine. Every district will have a district integrated public health lab, so that all these confirmatory tests, whether related to cancer or other diseases, we should be able to do it at the district level. Nobody should go to the higher level or a medical college level outside the district. So that has been an attempt. Now we are also, if we talk of the treatment part of it, unfortunately, WHO says that there has to be one radiotherapy machine for 10 lakh of population. So by that standard, India should have about 1,300 or 1,400 radiotherapy machines. We have only 650 radiotherapy machines in the country. So south of Vindhyas, the numbers is satisfactory. At least we have one machine for 10 lakh population. North of Vindhyas, there is a challenge that there is a shortage of the radiotherapy equipments. So people need surgery also, people need radiotherapy also, people need chemotherapy also. So unless this combination is there, So we are supporting from the ministry, and we are offering many public-private models also, so that more and more radiotherapy machines, etc., can be installed. So the gap is huge. I will not name the states, but I can name the states also in Uttar Pradesh, Bihar, Jharkhand, Chhattisgarh, West Bengal, Odisha. The gap is huge. So, and especially in southern states also, if Telangana has 15-20 radiotherapy machines, most of it is getting concentrated in the Hyderabad, in the urban centers or in the capital. So we need to set up more cancer infrastructure. The good part is that number of medical colleges, the number of UG and PG seats have doubled in the last 7-8 years. So now we have trained manpower in the country. We have doubled the UG seats, doubled the PG seats. And along with that, we have to also talk about the repurposing of the manpower. We cannot have enough oncologists in the country. We cannot have enough radiologists in the country. So we have to train the existing surgeons. We have to train the existing manpower, those who can perform these surgery, etc. And also the challenge before us is about chemotherapy. Dr. Pandarkar is sitting here. He has been working in this area for so many years. The idea is that we should have chemotherapy in every district. People should not go for chemotherapy, cover long distances. So there is a model that at the district headquarters, under the guidance of a trained specialist, chemotherapy can be administered by the medical officers at the district level only. So people save a lot of money and travel time. So this is also area where we are going on. Now we have been more liberal in providing tertiary care equipments at the district hospital under the National Health Mission. Because earlier National Health Mission, we used to talk about only primary health care, only sub-centers, and only the primary health centers. Now we are giving lot of funds to the district hospital. Now in Tamil Nadu, every district hospital has a radiotherapy machine. So any state coming to us to strengthen the district hospitals with tertiary care equipments like mammography, like radiotherapy machines, we are supporting these states. So a lot of work is going on, but we need to do more, and we need to orient more our primary healthcare workers. One model where Sadananda sir was also saying that the screening is done, but it does not reaches to the logical conclusion, is that one model is, I always quote at various forums, is in Bihar, in Muzaffarpur, where the Tata Memorial Hospital is there. The hospital is at beginning stage, but what they have done is, in consultation in coordination with the state health agencies, the tertiary hospital is part of the screening process. So they have trained the doctors, they have trained the nurses. So any case picked up during the screening process is taken faster to a tertiary care hospital. So I always urge all the tertiary care hospitals also that they have to get involved in the screening process, which is done at the primary care level, so that doctors are trained in doing better screening, and after screening, if there are suspicious cases, the quick action can be taken on these issues. So I'm very eagerly waiting for the whole day, deliberation. This will be very, very useful for us. Whatever each and every suggestion giver here in this forum, I was requesting Shri Prasannanji to, if I get the proceedings of the whole deliberation, then this will act as an input for tweaking our policies to, if we need to introduce something more, if we need to do something less, that will be very, very useful. And once again, thank you very much, Week, for inviting me for this discussion. Thank you very much.
Thank you, Mr. Chauhan. May I request Mr. R. Raj Mohan, Chief General Manager, Malayalam Manorama Group, to please come up on stage and hand over the certificates to our honorable speakers. So they're right here. Do we want to do it there in the lack of space?
I'll start from here.
It's okay. You can give.
No, no, it's okay.
Thank you, Mr. Rajmohan, and thank you, speakers, for this wonderful insight. Now we move on to our first session of the day. It's on, yeah, please. It's on ABC of breast cancer, India and global trends. I invite Dr. Vinod Raina, Chairman, Onco Sciences, Fortis Gurgaon, and Professor V. Seenu, Senior Professor, Department of Surgical Disciplines, AIIMS, New Delhi, to please come up on stage and have a discussion. I'll just do the little bit of introduction about you and then. Dr. Raina is one of India's foremost medical oncologists with more than 40 years of experience. A renowned powerhouse of knowledge and expertise, Dr. Raina was at All India Institute of Medical Sciences, New Delhi, as professor and head of medical oncology. He was the principal investigator of around 50 projects while at AIIMS for 24 years. His special mastery is in breast, lung, gastrointestinal, urological, gynecological cancers, lymphomas, and myelomas. He has performed approximately 400 bone marrow cell transplants for various cancers personally. Professor S. Veenu is a senior professor, Department of Surgical Disciplines, All India Institute of Medical Science, New Delhi, with special interest in breast cancer and breast oncoplastic surgery. Over to you, Professor and Doctor.
Very good morning to all of you. At the outset, I thank Professor Anurag Srivastav, the Week Connect, to having given us the opportunity to start the deliberations for today's programs. So, taking forwards from what has been discussed in the inauguration, for us to plan as to what should be done for any problem, it is important to know what is the magnitude of the problem. So, we start off with the global and India trends in breast cancer. I have made a very small presentation in form of questions and little bit of data, and Professor Vinod Raina, who is our teacher, like I know Dr. Raina since more than 35 years, and we were residents when he was our faculty. So, sir, to start off, what is the incidence of breast cancer globally and in India?
Good morning. I'm pleased to be here. I'm sure we'll cover various aspects of breast cancer. Referring to the talks in the morning, I have slightly contrarian views which will appear in my answer to his questions. I don't agree with the projections that have been made. You see, the basic problem in all cancers is the aging population. As the population gets older and older, all cancers will increase, including breast cancer. So it's not a specific problem to breast cancer that there is an increase. Regarding the incidence that Dr. Seenu has asked, is the incidence, if you follow the Indian Cancer Registry data, in Delhi, it's about 41, 42 patients per 100,000 population per year, new cases. Every year, per 100,000 population, nearly 42, 43 new patients will be diagnosed as breast cancer. In Bombay, it is more or less the same, 43, 44. But in some other parts of the country, it is slightly less. And in rural parts of the country, it is much less, which cannot be explained by the data. I think basically the problem is the capture of the data in the rural population, where the incidence has been shown to be less than 10, which is unbelievable. So that is the data about India, and the incidence is rising by about 2% per year of breast cancer. If you look at North America, the incidence of breast cancer is nearly 120 patients per 100,000 population per year. You'll be alarmed at this. In India, it is 40. In US and North America, it is nearly 120. Why is that so? The difference cannot be so much. It is so because they have adopted screening programs. Screening programs pick up very early breast cancer patients, whereas it reflects that there is an increased incidence of breast cancer. But since most of the patients are picked up at an early stage, stage 1, stage 2, you have heard in the morning that the survival of stage 1 and stage 2 is 90%. It doesn't result in deaths. So there's a big question mark as to whether screening programs have really saved lives. They have certainly increased and shown the increase in the incidence of breast cancer, but there is still a lot of controversy as to whether they are successful. Whether screening programs should be applied to India, the incidence is not that great, but in next maybe 20, 30 years, we may have to do that. So that is the brief answer to your question.
बहुत-बहुत धन्यवाद सर। अगर आप ये देखे हैं तो ये स्लाइड्स नहीं आ रहे हैं सो ये स्लाइड्स जब देखते हैं तो आप देख सकते हैं कि आज के दिन में जो ग्लोबोकैन एक वॉलंटरी ऑर्गेनाइजेशन है जो पूरा दुनिया का कैंसर की इंसिडेंस को हमें बताती है, तो देख सकते हैं कि आज के दिन ब्रेस्ट कैंसर लंग कैंसर को भी सरपास कर दिया है एंड ब्रेस्ट कैंसर कॉन्स्टिट्यूट्स अबाउट 11.7% ऑफ द टोटल कैंसर्स विच डॉक्टर रैना कह रहे थे। अब दूसरी बात जो डॉक्टर रैना ने बताया कि ये बड़ी अच्छी बात है कि जब आप इंसिडेंस देखोगे तो हिंदुस्तान में इंसिडेंस तो डेफिनेटली बढ़ रहा है। ये जैसे यहाँ देख सकते हैं कि इंडिया का इंसिडेंस आप ये साउथ सेंट्रल एशिया का लेके देख सकते हैं, इंसिडेंस बढ़ रहा है, बट आज के दिन भी हमारा इंसिडेंस 3 से 4 गुना अमेरिका से कम है। ठीक है, सो ये जो डॉक्टर रैना कह रहे थे कि स्क्रीनिंग की वजह से ये है या पॉपुलेशन का डिफरेंस है, ये बताना बहुत मुश्किल है, बट आप देख सकते हैं कि इंडिया में इंसिडेंस बढ़ रही है, बट अभी भी 3 से 4 गुना अमेरिका से कम है। और ये अगर इंडिया का लेके देखें तो जो डॉक्टर रैना बता रहे थे, मैं वो दोबारा दोहराऊंगा कि इंसिडेंस पूरा हिंदुस्तान में एक ही नहीं है। जो शहरों में जो सबसे बड़े शहर हैं जैसे दिल्ली वगैरह है, वहाँ पे ज़्यादा है, और ये जो कैंसर रजिस्ट्री जो गाँव की कैंसर रजिस्ट्री एक बारशी वगैरह है, वहाँ पे 10 या 12 पर 100,000 पॉपुलेशन है। ये डिफरेंस काफ़ी है। ये डिफरेंस क्यों है बताना बहुत बहुत मुश्किल है, बट कुछ रीज़न बता सकते हैं कि इसके वजह से। सर आप हमें बता सकते हैं आज के दिन की ब्रेस्ट कैंसर कैसे पता लगता है हिंदुस्तान में? लाइक nowadays they don't use the words called as developing and developed country, they use the word called as a transitioned and transitioning countries. Hindustan, our India will come in transitioning countries. So आप बता सकते हैं सर कि अमेरिका में कैसे ब्रेस्ट कैंसर कॉमनली डिटेक्ट किया जाता है? यू कैन टेक दिस।
ये बहुत ही हिंदी में भी, क्योंकि हिंदी में सवाल पूछा जा रहा है, मैं भी हिंदी में जवाब दूंगा।
नहीं, वो दैट्स व्हाट दे सेड, यू कैन स्पीक बोथ लैंग्वेजेस।
ओके, देखिए द कॉमनेस्ट डिटेक्शन जो इंडिया में है दैट इज अ ब्रेस्ट लंप, एंड समटाइम्स देयर इज अल्सरेशन, ब्लीडिंग और निपल डिस्चार्ज। दिस इज द कॉमनेस्ट प्रेजेंटेशन। And since other diseases like tuberculosis have a competing clause, villages वगैरह में, distant areas में, this symptom is ignored. भाई ठीक है, कोई infection होगा या TB होगा। So for a long time, the problem is not addressed. Patient should go for a biopsy or at least to be examined by a doctor. That doesn't happen. So घर में ही बैठते हैं, they hope that it is not cancer, or they are not even aware that this is cancer. So the problem festers for nearly 6 months, 9 months, 1 year, till the lump becomes very large, it starts fungating and ulcerating. Then it causes pain in the axilla. Then the patient rushes to the hospital or to the doctor. So the biggest problem is the late diagnosis after onset of symptoms. This is the biggest problem. But in cities, that is changing now. In cities, women are going for personal examination every year after the age of 40 years. This picks up a lot of cases of early breast cancer. You see, the key is not screening. Screening has failed. Key is early diagnosis, because as you have seen, the outcome of treatment in early diagnosis is much better than in late stages. So that is the key. And in cities, the transition is happening to a Western style or Western type of breast cancer as compared to rural areas in India, which still we see traditional large fungating lumps.
So what Dr. Raina is telling us is that in India, the problem is not screen detection, the problem is the late presentation. And as has been elucidated by Dr. Raina, like America में 90% ब्रेस्ट कैंसर स्क्रीन डिटेक्टेड होते हैं, मतलब कि मैमोग्राम किए या अल्ट्रासाउंड किए और उसमें पकड़ लिए, लेकिन हिंदुस्तान में आज के दिन भी ऑलमोस्ट 90% पेशेंट्स गिल्टी के साथ आते हैं और वो गिल्टी भी बड़ी गिल्टी होती है. तो ये फ़र्क है. तो इसकी जो रिफ्लेक्शन आप आउटकम्स में देखते हो उसकी वजह से ये है. Sir, like again, continuing the same thing, what is the stage of the breast cancer when patient presents in day-to-day practice in India?
Oh, no doubt, the advanced stage as compared to the West, they present mostly in stage 3, stage 4. But that is changing in cities in India. We are now seeing women who go for screening after the age of 45 or so, and many new cancers are picked up at a very early stage. In fact, we have difficulty in many cases to actually isolate where the lesion is, because it has been picked up by ultrasound or mammography. The problem with screening is that below the age of 45 or 50, the breast is quite glandular, and mammogram is not very useful. You have to rely on ultrasound or clinical examination. Whereas if you crossed 50, 55, the glandness of the breast reduces, so mammograms are very useful. But screening mammograms is a different issue as compared to mammogram when the patient has symptoms. So there's a difference between the two mammograms. So no doubt patients present at a more advanced stage as compared to the West or North America.
जी, इसके बारे में डिस्कशन नेक्स्ट सेशन में और ज़्यादा होगा कि इंडियन पेशेंट्स यंगर होते हैं तो हमें क्या दिक्कत होती है अगर हमें ब्रेस्ट कैंसर इनमें डिटेक्ट करने के लिए. तो आज के दिन में हमारी प्रॉब्लम है कि हमारे पेशेंट्स बहुत एडवांस स्टेज में प्रेजेंट करते हैं, और ये आपको हमारे नेशनल कैंसर रजिस्ट्री है, इंडिया की नेशनल कैंसर रजिस्ट्री, इसके आंकड़े भी यही कहते हैं कि भाई हमारे यहाँ आज के दिन में लोको रीजनल, मतलब ट्यूमर जब बगल में फैल जाती है तब डिटेक्ट करने वाला ट्यूमर ज़्यादा होता है. लगभग 57% पेशेंट्स प्रेजेंट विथ लोको रीजनल डिसीज एज कम्पेयर टू वेस्ट वेयर more than 80% present with disease which is limited only to the breast. So that is the crux of the problem. Okay, so this question I think I'll ask Professor Anurag Srivastava. Sir, you can also pitch in. What percentage of patients need mastectomy in India today? And have you experienced any increase in the number of breast conservations now?
Question. So in general, I'll say that about half the patients require mastectomy or want a mastectomy. Sometimes tumor may be small, but the lady and the family members, relatives will insist कि नहीं भाई मेरी बुआ को हुआ था, उनका किसी सर्जन डॉक्टर ने गांठ सिर्फ निकाला था, 2 साल में फैल गया और चली गई, इसलिए मुझे तो पूरा स्तर निकलवाना है. So sometimes even if the science tells us that you can preserve or conserve the organ of femininity and beauty, even then the social opinion forces them to go for mastectomy. So that is another very interesting phenomenon. This doesn't probably happen in America or Europe, but so this in a general half. But good news is that, as Dr. Raina stressed, that in big cities many ladies are becoming aware of breast health, and they are going for regular screening mammography and examination by experts, and we are detecting in situ cancer, DCIS, non-spreading cancer, which is the earliest stage. It is not cancer, it is a pre-cancer. उसके कैंसर होने की प्रथम चरण है वो, अभी फैला नहीं है वो. तो उसमें we can certainly preserve the organ of beauty and do.
Thank you, sir.
Thank you. So the picture is changing.
ये सोचने वाली बात है कि आज के दिन भी हमारे यहाँ ज़्यादातर पेशेंट्स मैस्टेक्टमी प्रिफर करते हैं, जैसे सर ने बताया कि भाई वो सोशल रीज़न हो या फैमिली रीज़न हो, या हमारे यहाँ की एटीट्यूड पेशेंट की ये होती है कि जब भी पेशेंट आता है वो बोलते हैं कि ऐसे ऑपरेशन करो जिससे मुझे दोबारा कैंसर ना हो. तो ये एटीट्यूड चेंज करने के लिए अगेन वही चीज़ होती है कि आप कैंसर को जल्दी पकड़े, छोटा कैंसर रहे, ज़्यादा पेशेंट्स में आप ब्रेस्ट कंजर्वेशन करें, ताकि जब भी पेशेंट आता है ना, पेशेंट आपसे ज़्यादा दूसरे पेशेंट्स पे जो ट्रीटमेंट किए हैं उनका राय भी लेना चाहते हैं. तो अगर ज़्यादा पेशेंट्स में अगर ब्रेस्ट कंजर्व करते हैं तो इन टर्न हमारा ब्रेस्ट कंजर्वेशन रेट बढ़ सकता है. सर, what do you think are the survival rates for breast cancer in India? And is it different vis-a-vis the West? And have you seen any improvement in the last 30 years in our survival rates?
Well, it is difficult to give you exact data because there is no comparison of survival of breast cancer, direct comparison between breast cancer in India and North America.
Can you repeat it?
What I'm saying is it is difficult to give a exact comparative figure as to whether cervical cancer in India is different from that in the West. But जो हम clinical practice में देखते हैं, it certainly is inferior because patients present in more advanced stage. If you present in stage 3, stage 4, naturally the outcomes are different as compared to screen detected breast cancer where survival is nearly 95% over a period of 30 years. So India में survival तो है worse, but that is again changing in the metropolitan areas where the detection is occurring early and patients are getting the state-of-the-art treatment that is available in North America. Let me tell you that. There is a total transformation of cancer care in cities in India, which is percolating down to second-tier cities also. Now coming to the other myth that India में breast cancer younger age पे होता है, ज़रूर होता है, but that's a reflection of the age distribution in the population, not because the breast cancer is occurring at an early stage. जो genetic breast cancer है, which is transmitted from the mother to the child, happens only in about 5 to 6% cases. In the rest of the cases of breast cancer, we don't know the cause, but it's directly correlated with aging. As you get older and older, your risk of breast cancer increases. लेकिन जो myth है कि जो दिखाया गया है सुबह, I don't disagree with what has been shown, but that's a bit of a dramatization. That जो young patients में, young girls में breast cancer is still a very rare disease. We hardly see any patients of new breast cancer below the age of 35. It does occur, but in उन cases में there is a genetic predisposition like BRCA mutation वगैरह. So ऐसा panic नहीं है. Breast cancer incidence is gradually increasing by 2% per year, which is happening mainly because of the aging process.
थैंक यू सर. सो मतलब ये ज़रूरी हमें मतलब पता होना चाहिए कि आज के दिन में ब्रेस्ट कैंसर की सर्वाइवल रेट इंडिया में इम्प्रूव हो रही है, और इसका कारण है कि जैसे ज़्यादातर बड़े शहरों में ट्यूमर को जल्दी डिटेक्ट कर रहे हैं, एंड हमारे यहाँ जो हिंदुस्तान में आज के दिन में मेट्रोपोलिस में जो ट्रीटमेंट अवेलेबल है उसकी स्टैंडर्ड आप अमेरिका या यूरोप या कोई भी कंट्री लोगे बाहर के तो उससे कंपेरेबल है हमारे ट्रीटमेंट फैसिलिटीज़ इन बिग गवर्नमेंट इंस्टीट्यूशंस एंड इन मोस्ट ऑफ द corporate hospitals. So there is improvement in survival, but unfortunately since majority of the patients present with large tumors, our survival rates are not better. अभी ये जो स्लाइड है ना, ये बड़ी इंपॉर्टेंट स्लाइड है. इसमें जब आप देखोगे तो जो लेफ्ट साइड के ग्राफ है उसमें इंसिडेंस ऑफ ब्रेस्ट कैंसर दिया गया है, एंड द राइट साइड के ग्राफ में दिया गया है कि द मोर्टेलिटी. आप देखो कि ब्रेस्ट कैंसर की इंसिडेंस उतना ज़्यादा नहीं है, बट मोर्टेलिटी रेट काफ़ी ज़्यादा है. एंड स्पेशली अगर आप कंट्री वाइज देखें तो आपको इधर पता लगता है कि अगर आप ऑस्ट्रेलिया न्यूजीलैंड में लोगे तो 95 पर 100,000 पॉपुलेशन में ब्रेस्ट कैंसर होता है, उसमें सिर्फ 12% पेशेंट्स में डेथ हो जाती है। लेकिन आप साउथ सेंट्रल एशिया जो इंडिया का रिफ्लेक्शन देखते हैं तो हमारे यहाँ 26.2 पर 100,000 है, बट हमारी मॉर्टेलिटी रेट 13.1% है। वहाँ पे 93% है और 12% है, हमारा इंसिडेंस 26% है, लेकिन हमारी मॉर्टेलिटी रेट ज़्यादा है। एंड इसकी वजह भी अगेन जब आप डिस्कस करते हो वापस उसी पे आता है कि हमारा कैंसर काफ़ी एडवांस स्टेज में पाया जाता है आज के दिन में। What challenges do you face when treating breast cancer, sir, and what can we do further to improve the survival rates?
I think the biggest challenge is what has been discussed since morning is late diagnosis, advanced stage of disease, more difficult to control, the outcomes are worse. And that is also changing gradually. Uska to bahut kuch kar nahi sakte except to increase the awareness in the population, have programs like this, have programs on TV, make the rural women, the challenge is the rural women, you know, the ladies or the women in cities know a lot about breast cancer, they are aware of it, and as soon as they have a lump in the breast or abnormality, they go to a doctor immediately. The problem is in the distant rural areas. Now, what can be done to improve the survival rates? That's the second question. The improvement in survival rates will depend on at what stage you detected breast cancer. Again, if you detect it at stage 1, your job is automatically done. The outcomes will be much better. But if you detect at stage 4, the average survival in stage 4 is, 3 to 5 years, if it is gone to viscera. The third is that major advances have happened in breast cancer in the last 30 years, not so much in terms of chemotherapy, but in understanding the biology of breast cancer. There are monoclonal antibodies, there are targeted therapies, the biology of the breast cancer is better understood. So overall in the world, the survival of breast cancer has uniformly improved where the availability of the healthcare is there. So that's my...
Thank you. So the challenge which every person who is involved in management of breast cancer, the challenge जो फेस करते हैं वो है कि भाई पेशेंट लेट स्टेज में आपके पास पहुंचता है तो पेशेंट की ट्रीटमेंट ज़्यादा हो जाती है, पेशेंट्स को मैस्टेक्टमी करना पड़ता है। तो इसकी जवाब एक ही है कि अगर आप कैंसर को जल्दी पकड़ लिए ताकि पेशेंट अर्ली स्टेज में प्रेजेंट करे तो आप ब्रेस्ट कंजर्व भी कर सकते हैं, ट्रीटमेंट भी कम कर सकते हैं, उससे कॉम्प्लिकेशन भी कम होंगे और हमारा आउटकम्स बेटर होंगे। तो घूम फिर के फिर सब चीज़ वहीं पे आता है कि भाई आप ब्रेस्ट कैंसर को जल्दी पकड़ो। So we conclude this session. So on behalf of Dr. Raina and me, we say that आज के दिन में ब्रेस्ट कैंसर इंसिडेंस इंडिया में 2 to 3 fold इंक्रीज हो रहा है, बट अभी भी वो कम से कम 4 गुना कम है एज कम्पेयर टू यूरोप और अमेरिका। बट ये सोचने वाली बात है और इसके ऊपर हमें ज़्यादा डिस्कशन करना चाहिए। आज के दिन में हमारा मॉर्टेलिटी अभी भी दो हमारा इंसिडेंस उनसे कम है, हमारा मॉर्टेलिटी रेट उनसे बहुत बहुत ज़्यादा है। एंड इसके वजह एक ही है कि ब्रेस्ट कैंसर देरी से आ जाता है। तो इसका जवाब एक ही है कि एफर्ट एट अर्ली डिस्ट्रैक्शन not only helps in saving life but also breasts. So thank you very much. Yeah, any questions anybody has? Because we are left with 5 minutes. Yeah, okay.
Doctor, I'll ask you to stay on stage for the certificate. So I request Atul Arora, General Manager Marketing The Week, to hand over the certificate of appreciation to Dr. Raina and Professor Vicino. Right here. Certificates, yeah. Thank you. Thank you so much, Doctor and Professor, for that beautiful discussion. Okay. He can start. All right. With that, we move on to our next discussion, which is a panel discussion. The topic is breast cancer prevention, how to reduce the risk. Breast cancer prevention tools include risk-associated lifestyle modification programs, chemo prevention medications for select high-risk women who have received appropriate texting and counseling. To understand this further, I request our panelists to please come up on stage and join us. May I request Dr. C.B. Dhanraj, Dean, PG Studies, Patanjali Ayurveda College, Haridwar. Dr. Sanjay Kumar Jain, President, the Association of Surgeons of India. Dr. Ravi Mehrotra, Director, Indian Cancer Genomic Atlas and founder of the Center for Health, Innovation and Policy, CHIP Foundation. Dr. Bhavna Sirohi, Director, Medical Oncology, Balco Medical Center, Raipur. Professor Chintamani, in charge, Department of Breast and Endocrine at Vardhaman Mahavir Medical College, Safdarjung Hospital, New Delhi. So please, Dr. Dhanraj, you can join us on stage. We have Dr. Sanjay Jain. We'll have Dr. Sanjay Jain and Dr. Bhavna Sirohi joining us virtually through online. And the session, I would request Dr. Sanjay Jain to start the session. And just before that, I'll do a little introduction of our esteemed speakers. Dr. C.B. Dhanraj is Dean of PG Studies at Patanjali Ayurveda College with over 27 years of teaching experience and many research publications under his belt. He has worked with Government of Telangana as a professor of Ayurmedicine and is recipient of several awards. International Academic Excellence Award by University of Wolverhampton being one of many. He has worked across the globe in various countries like Uganda, Sierra Leone, Ethiopia, England, to name a few. Dr. Sanjay Jain is Professor of Surgery at Gandhi Medical College, Bhopal, and Consultant Surgeon at Hamidia Hospital, Bhopal. He is also the current President of the Association of Surgeons of India, Vice President, SARC Surgical Care Society, and President of Organized Medicine. He's a general surgeon with interest in surgery for the breast cancer and other diseases. Professor Ravi Mehrotra is one of the directors of the India Cancer Genome Atlas and founder of the Center of Health, Innovation and Policy. He holds adjunct professorships at the Emory, Brunel, and York universities. Earlier, he has been the CEO of the ICMR, ICRC, and also directed the ICMR, National Institute of Cancer Prevention and Research, as well as the WHO SCTC Global Hub on Smokeless Tobacco. In addition to Armed Forces Medical College, he has trained at the Royal College of Pathology, London. Dr. Bhavna Sirohi is the Medical Director at Balco Medical Center, Raipur, and a breast medical oncologist. She has more than 2 decades of experience as an oncologist in UK and India. Having qualified as an oncologist from Tata Memorial Centre, Mumbai, she further completed her training at Royal Marsden NHS Foundation Trust, UK. She has published more than 150 papers in national and international journals and has lectured worldwide. She has been involved in varied capacities to create cancer awareness in India, be it through cancer screening camps, initial setting up of cancer centers, or creating protocols and procedures for safe care for patients. She is deeply involved with charities like CanSupport and has even set up a charity named New India Cancer Charity Initiative. Professor Chintamani is the Chief of Breast and Endocrine Unit, former head, Department of Surgery at VMMC. He has been a fellow of all the 4 Royal Colleges of UK and American College of Surgeons. Known for his teaching and operating skills, he is actively involved in the teaching and training of undergraduates, postgraduates, and postdoctoral students. Professor Chintamani holds various titles and designations under his belt. just to name a few. Governor and President, American College of Surgeons, India chapter. President, ASEAN Society of Mastology. International Surgical Advisor, the Royal College of Surgeons, Edinburgh, UK. Board of Directors, Indian Cancer Genome Atlas. He has written 12 books on surgery and oncology and has 200 scientific publications. So I request Professor Chintamani to kindly moderate this session for us. And sir, I've been told Dr. Sanjay would be the first one to go for his.
No talks. Can you open my slide, please? I've given it on pen drive. Has you loaded it?
Yeah, that's yours.
It's a panel, so we'll stick to the panel.
Okay.
Right, okay, there you are. Sorry. Good morning, ladies and gentlemen. Thank you for that kind introduction. So now that we know each other well, we had some wonderful talks in the morning, and I think by now we are all primed into thinking about how do you prevent something which is curable if you fetch it early. So I'll start with the good news that breast cancer is curable if you find it early. And I have some very distinguished people to teach us as to how you prevent it from happening. And if you can prevent it from happening, we all know this old proverbial thinking, prevention is better than cure. Now, is there something you can do, fix easily, that can prevent cancer is what we look at. We look at certain aspects that are new, and we are all learning in that sphere. And then we have some very, very special people joining us today, both Dr. Dhanraj and Dr. Anurag Varshney from Patanjali Institute. And I've been to that institute and their lab. The kind of work they're doing is phenomenal. It can match the best in the world. So they will teach us about some lifestyle changes that can make a difference. Of course, Professor Ravi Mehrotra needs no introduction. This is his field of specialization. So personally, I'll be sharing my ignorance. They'll be sharing their information. I'm delighted to have Dr. Sanjay Jain, who is a dear friend and president of ASI, Association of Surgeons of India, and Dr. Bhavna Siroi joining us virtually. I hope I can see them and they can see us. Maybe you can say with a loud yes, Dr. Sanjay?
Yes, good morning everybody. I think can you hear me, sir?
Very clearly, loud and clear, Lima Charlie. How about you, Dr. Bhavna?
Good morning, everyone. Lovely to
very
see
good.
you, Dr. Chintamani.
Wonderful. So, can I have the slide? I mean, it's just to initiate some kind of a discussion. There's nothing much written on the wall. So, the prevention tools, as was introduced in the theme of the topic, basically would be risk-associated lifestyle modifications. It sounds complicated, but it is very simple. It's how you change and how do you live your life that can decide how you get it. I remember when I was training, breast cancer was not that common in this part of the world. And when you read Sushruta Samhita, which is probably one of the best treatises on surgery in this part of the world, or also Charak, there's no mention of breast cancer, very, very minimal mention of some other cancers. So naturally, they were eating well and they were living better. So there's something that has happened here which we need to talk about, and that's what we'll try and do. Then there is some technical thing that you can do, that is taking some drugs to prevent cancer from happening. But I'm sure this is more of a very confined area or select group of people where it will matter. Usually in moderate to high risk women. Who are these women? We'll discuss. And of course, I have that little space there, preventive surgery, that is in high risk women. You can do preventive surgeries in the form of mastectomies or oophorectomies. It's like if you don't have the organ, you won't have the cancer. But now the flip side is you can't get all the organs out so that you don't get cancer. So that this is the extreme of thinking, but this is one way of looking at it. So these are the three broad headings under which we'll try to keep our talk. So first of all, what is the risk factor? I'm just giving a brief background for the benefit of all. Risk factor is anything that increases person's chance of developing cancer. So risk factor here is pertaining to cancer that we are talking. There are risk factors in life anyway. If you're living, you will have the risks. So will the risk of breast cancer be.
Although they often influence the development of cancer, most do not directly cause cancer. So it's not that if you don't have, if you've been a vegetarian, never smoked in life, you lived a pious, absolutely clean, righteous life, you will not get cancer. The answer is no, we don't know. So the profound truth here is IDK, I don't know. But by and large, a good quality of life, the right kind of eating can make a difference. There are some with several risk factors and also with a strong family history may never get cancer. It's not necessary that you'll get it. And mind you, only 10% are hereditary cancer. So don't start blaming it on genes as yet. There are aspects of how you look at it, but we should be clear on that aspect also. Is it all in our genes? The answer is, as I said, no. Most cancers are sporadic, which would mean, for the benefit of all the audience, ये सब genes में नहीं चलता है कि ज़रूरी है कि किसी को घर में तो हुआ नहीं. अक्सर the patient comes and says, nobody in my family ever got cancer and I have got it. Now, there's no point scaring the hell out of this patient that your daughter is also going to get it. Just keep a watch. You may get it. So it's that limited numbers. I think I'll skip that. These are the genes. We have heard them already. BRCA1, BRCA2, PALB2. Most of these are tumor suppressor genes. Remember, everybody sitting in this room has some cancer or the other. Please don't mind my saying it, but it won't show up in your lifetime. The reason being, you have some tumor suppressor genes. They suppress your cancer from happening. Now, this tumor suppressor gene may undergo a mutation as a part of a hereditary process or an environmental process. Which one is more effective? We don't know. If you go back to your theory of evolution, one was a mutation theory also. So we don't really know where it will happen. Suddenly, it will happen over a period of time. These are the factors, so we'll discuss one by one. So let's, I would request Dr. Anurag Varshney and Dr. Anurag Srivastava to kindly be there to augment the floor discussion so that they can all chip in. So I'll start with you, Professor Ravi, with the age. It's well known that as the age advances, the breast cancer risk increases, although the same is not true. In this part of the world, we find two peaks of breast cancer, one in 40s, the other in 60s, unlike in the West. And yes, we are getting very young patients who have got breast cancer, and it's not rare now. I mean, we get a lot of them in 20s now, which was not there earlier. And the change is striking, and we need to look at it differently, and definitely there is a problem. We couldn't be sitting on a dynamite and hoping that it will not take off. Yes, Prof.
Yeah, thank you so much, Chintamani sir. It's a pleasure, of course, to be with all of you again. We've had to, most of you, at least in the hall, I've had opportunity to meet at some point or the other. So I think to begin the conversation, and it was pointed out by Professor Raina earlier, the biggest risk factor of any cancer, well, not any, but majority of, 95% of cancers is age. So with, I mean, the good news is that number of people in their senior years, and you know, senior can also be divided. In India, we normally have a retirement of 60. Other places are 65, there are 70, 75. So normally in any hall, when I say senior citizen, I always point to the oldest person. He is the youngest of them all. But reality being chronologically, we are all getting older, and that is the price you have to pay. As you rightly mentioned, as far as breast cancer is concerned, in India we have two peaks. Then normally the 45 to 50 age group approximately, and then towards the more elderly. But the first peak is the most prominent one, and most people in India do present in that area. So that is a compulsory evil, and there is not a lot you can do to prevent age-related breast cancer, because the number of cells are multiplying, and as Professor Chintamani talked about very, very clearly, in a very erudite fashion, there are certain suppressor cells जो उस ट्यूमर को रोकते हैं बनने में. वो suppressor cell अगर कम हो जाएंगे तो वो जो कैंसर है या early tumor है वो बढ़ जाता है. Thank you.
Thank you so much. Dr. Dhanraj? From the, I mean, I don't think there are any pathies, so anything that contributes to patient well-being is a therapy. So
with the permission of the chair.
Yeah, please,
yes,
please.
Yeah, just as a nominal way, I esteemed Professor Anurag Srivastava ji.
Can we have the answer,
Yeah.
sir? Let's move
And,
to the answer.
Yeah, answer the answer. And respected guests, scientists, doctors from all sides and journalists present over here. I really am addressing them all you again because the talk I'm going to give, the information I'm going to give is a little bit different from what I've been getting here. I know you're all been focused, the governments are focused, all the governments throughout the world are focused on allopathic system of medicine. But what is behind the Indian science, that is Ayurveda? Now, I only speak, not present, the perspective of age that has been told by Dr. Chintamani ji. So we see that this theme, the secrecy of Indian science, Ayurveda, says that three doshas, Vata, Pitta and Kapha. And this has been very beautifully been distributed at the different parts of the age. I'm just sticking to the age, please, because of the time factor. So the age, we see the Balyavastha as a Kapha, and middle age is a Pitta, and late age after 40 or 50, we call Vruddhapyam, etc., is Vruddhapyam is Vataja. So the cause of this big notorious disease is, we say, the vitiation of Vata. And as per the text and as per the reality, we see that this occurs more only after the age of 40. So where Vata is predominant. And details of Vata, Pitta, Kapha, I'm sure you're not aware. If the chairperson gives permission, I would like to elaborate, because this is a time for all of us to pull our socks.
So
and
we'll have it at the end.
Yes.
We'll definitely
later on, later part of it.
Yes, Dr. Sanjay Jain, please. I think you may not be visible, but you can, yeah, we can switch on. That's perfect. Your thoughts on this aspect, although actually it may look like we're beating the same drum, but let's hear everyone about, in the first round, let everybody chip in. Dr. Sanjay, can you hear me?
Yes, sir.
Your experience with the age of patients that are coming with breast cancer in your part of the world.
Yeah. First of all, good morning, everybody. Good morning, panelists and viewers. And thanks to the week for inviting me and giving this opportunity to talk to the scream of the society and talk to this very important, and this is a topic of my interest. See, when we talk of the modern medicine, we also talk of the evidence-based, and we have seen the evidence has proved that there are certain cancers which are age-related. As the age goes high, the incidence goes high. So, if you see a woman of 20 years of age, she has got 1 in 20,000 to get a cancer. If you see a woman of 80 years or 85 years, she will be having almost 12%. That means 1 in 10 or 8 chance of getting cancer. So this cancer, and another is the prostate cancer, which occurs in the male, is related to, and it is called an age-related cancer. As the age advances, the incidence definitely goes up. Although in our scenario and the Western scenario, there is a big difference, and that difference says that the average age or the mean age of presentation of carcinoma of breast in the Western world or UK is around 60 years, while in resource-limited countries or the India, the average age of presentation is 48, and this is what the evidence says.
But thank you. That's point taken, Dr. Sanjay. That's it. Dr. Bhavna, anything to chip in, to add your experience of the kind of patient you're getting? We are all aware of all cancers rising with age and, in fact, all problems. But since we're getting younger cancers, so that's why this age we are discussing. So your thoughts on it?
Thank you, Dr. Chintamani, and thank you, WEEK, for organizing this event, because it increases awareness, and the whole point is increasing awareness. So I agree with all the panelists. I'll just put in a word that I have worked in all corners of India, north, south, east, west. And my perception is that we are seeing more and more younger women in their 20s and 30s who are being diagnosed with cancer, with breast cancer. And I think that could be related to the younger population dynamics that we have in India as such, and also to the fact that The infection-related cancers are going down, the lifestyle-related cancers are coming up, and also women are becoming more aware, and they are actually going for checkups and tests as well, which is how we will change the dynamics of, stage 3, 4 to stage 0 and 1. Thank you.
Thank you. I think by and large the take home is we all understand, and it's already known, and there's no rocket science in it. Cancer incidence rises with age, but this is a peculiar phenomenon being observed not only in breast cancer, even other cancers that younger patients are getting, especially in the LMICs.
Yes.
We are looking at various aspects, and the usual concept of oncology is that the dysgenesis has started in utero, and the time it takes to show up is the aggressiveness of the disease. So younger cancers are more aggressive also. If they show up at 80, they are relatively more benign. And this is what we observed. These are the two peaks I was referring to, and this is the usual presentation, and we now know it was triple negative, and they tend to have more of the genetic predisposition, just to highlight the aspects. And these are the cell lines that we worked on. And we realized that younger patients, since we're getting more of them, this could also have something to do with the statistical goof up, that there are more young people in this country, so therefore more people get it. But at the same time, there is something which is changing, and we should be aware of it. Now, the lifestyle modifications, I think I'll start by asking Dr. Dhanraj here. Before I come to you, Prof. Dr. Dhanraj, you will have a word to say here in terms of what you think should be the lifestyle modifications. Most of us know about it. The basics we know, the kind of life, the kind of food you eat, the kind of water you drink, exercises, etc. Something special that comes from the indigenous medicine, the way we have always looked at it for centuries.
Thank you so much.
Doctor, we have time.
Hello. Okay, speaking now. Yeah, lifestyle modifications. It has been described in ancient texts how to live, what time to get up, what time to sleep, and what is the dinacharya, means what are the different types of foods you have to take. The basic thing is lifestyle modification is everybody know that we have a buffet, different 101 recipes there, and you choose whatever you want. No, one has to decide your prakriti, which is born with your, at the time of the union of your sperm and egg when you are before in the womb of your mother. And a specific prakriti is established. And that prakriti, according to that prakriti, you should really go again, opposite to your prakriti and take your diet. Suppose if you are a kapha prakriti, you have to take for vata type of recipes, and as well as if you are pitta prakriti, go for a different type of recipes. So it is absolutely, the food is tailored for every individual. That's what the text says. It is not that gulab jamun is good and good for everybody, no. So what it says is the lifestyle modification is you need to identify your genoma, that is which prakriti you belong, and according to that you have to establish your diet, your movements, your vihara. Yes.
All right, thank you. Professor Ravi.
Yeah, thank you so much. Lifestyle and the way we live, what we eat, how much we exercise is of course important. In breast cancer, as has been mentioned, appropriate exercise and weight are the two major issues which are important. We find that with increase in weight and a sedentary lifestyle causes a number of breast cancers to happen. The other issue which I will briefly talk about is the fact that many ladies today are not having enough children, in the sense much less than what they used to have, and also not breastfeeding. It has been very clear for women who breastfeed their children for at least a year, if not more, have lesser amount of breast cancer.
Thank you. Absolutely, short and sweet. And gulab jamun, as you said. No, I like that. Gulab jamun may not be good for all. I appreciate that. See, the cup and pith thing can get a little confusing with people, so they may not understand. But the take home would be simple food, as today is suggesting, and exercise. And as Prof brought it out, it can be very precise. And yes, breastfeeding, regular physical activity, 30 to 60 minutes. I've added a few, some take home so that they're useful. I'm sure you all know it. Keeping a good weight, healthy weight is important. And hormone replacement therapy, postmenopausal women, they're very, very at a high risk. whether the OCPs have a role to play. Professor Anurag Srivastav, your take on that, because this is a traditional age-old teaching. We always teach our students to take this history of OCP intake. It's a controversial topic, so I thought I'll ask you.
Thank you. See, the greatest, largest study which demonstrated the effect of oral contraceptive on increasing risk of breast cancer is called 1 million women study done in United Kingdom.
Yes.
And that demonstrated that there was about 20% increase in risk of women who have taken 10 years continuous. It's not one of,
10 years continuous?
Continuous 10 years of high dose estrogen combination pills, which are now obsolete. Most oncologists and gynecologists now know it. So therefore, if a lady comes around 40, 45, she is suffering from, post-menopausal symptoms, and if they are really worrisome, they will prescribe a lot of low estrogen or non-estrogen based
pills.
OCPs, the hormone contraceptive pills. So today, we can safely say that the current generation of oral contraceptives as well as current generation of HRT are both safe. They do not increase the risk of breast cancer. There is slight increase if you are giving estrogen based. But now we have many non-estrogen based or non-hormone based HRTs, and they can safely be prescribed.
Thank you for that.
Thank you.
So OCPs by and large are considered safe, and there are many reasons for that. One is this trial that he was referring to. The other thing is the time when you get the cancer and the time you're taking the OCPs, they don't match up. So very difficult to establish. And thirdly, the estrogen dose is reduced tremendously, so they are safe. Even the other contraceptive methods which secrete hormones are considered reasonably safe. Although HRT in the postmenopausal period is still considered a risk. There was a presentation, and I'll ask Dr. Anurag Varshney about this, on an Ayurvedic drug which is kind of compensate for the HRTs that are available. It has no risk of producing breast cancer, yet it gets the results that you're looking for. Could you elaborate on that?
Right, sir. Thank you very much indeed. I think the Ayurvedic medicine that seems to work in this area seems to have a wider safety margin, largely because they are much closer to nature. So we have looked at herbal or herbo-mineral combination called Cystogrid, which has components from
Could you speak that out more clearly, please? The drug.
Cystogrid Diamond.
Cystogrid, okay.
That's the name of the formulation that has been developed at Patanjali, where we have seen that actually it seems to have a very good response on the patients who are having breast cancers too, and with the minimal side effect that we could see.
Thank you for that. Yes, thank you. And of course, breastfeeding, they say the optimum time is 2 years. That if you breastfeed, it's very protective, but at least 1 year, it is definitely safe. Early menarche, late menopause, when the more cycles and more times for the estrogen exposure increases the risk. Obesity increases the risk for various reasons, but also for the peripheral conversion into estrogen. So all hyperestrogenic states, wherever the estrogen levels are high, would raise the risks. And when you talk about the risks, there is more to it, and something like diet comes big time, and we will hear a little bit about it from both Dr. Bhavna and Dr. Sanjay. Dr. Bhavna, if you could kindly elaborate on it. I know there are aspects of diet which we all understand are in general good for everybody, but anything specific to breast cancer that you would like to enlighten us about?
So there are a lot of studies actually which have been done on diet and breast cancer, and there is some evidence to show that vitamin D, can help breast cancer cells to grow normally, and our Indian diet and the sun is very enriched in that. There have been some papers about low GI diet. There have been papers about processed foods and sugar intakes, especially refined sugar. The recommended maximum in a day is 30 grams per day, So all of these have been implicated in making the cancer cells grow and increasing the risk of breast cancer. So I think it's very important that we follow a healthy diet which has enough of fruits, vegetables, and adequate amount of protein, carbs, and fats. The good fats, one should avoid the saturated fats. There are quite a few studies on diet and low-fat diets. decreasing or the incidence of developing breast cancer, or in women who have breast cancer, there is evidence that, you know, those ladies who followed a low-fat diet, the risk of recurrence was also lower. So I think diet has a very, very important role to play in this. If you permit me, Dr. Chintamani, I just have one thing, this ABC of prevention, you know.
Yeah,
with
please, please.
You have it easy for people to remember.
Yeah, absolutely.
It's avoid tobacco, alcohol, OCP and HRT long-term use, processed food, supplements and sugar. Be breast aware for B and breastfeed. C is for calm, compliance to your checkups and yoga. D is diet, which is again, you know, the most important component. E is exercise. And again, you already elaborated on that. And we have enough evidence to show for breast and colon cancer, the lifestyle related diseases, that exercise is so important. Something that gets your heart rate up, not just, you know, simple walking. F is for family history. I feel you should know what your family history is and follow up. If you're recommended a test by a doctor, you must follow it up. S is for sleep. There is enough evidence to show, big Spanish study, that, you know, if you have 2 hours between your last meal and sleep, or, you know, you have your meals before 9 p.m., there is a 20% reduction in breast and prostate cancer, you know, which are called shift-related cancers. And S is sweat. You know, you should sweat. You should really exercise so you sweat. You should stretch. You should also undergo screening, which I'm sure you will discuss.
Yeah, sure. Thank you so much. That's wonderful. You put it down and you can hear some people were trying to clap, but they probably thought it is prohibited. You can all clap, no issues. So that's wonderful. That's the ABC of lifestyle changes that you would look for. Thank you, Dr. Bhavna. Dr. Sanjay, anything to chip in quickly?
Chintamani sir, I think Dr. Bhavna has already outlined most of the things.
Okay,
and
thank you.
What I would
quickly.
The new generation, which they have to avoid, the unnecessary things which they are getting, a lot of fats in the food, which they are making them prone, and 2 more habits which are more of a show off rather than their necessity. When I see modern girls, is the habit of smoking and alcoholism. This is something which I would like to commend at this
Thank you so much. You brought that up. Alcohol does no good. If anybody tells you 1 drink a day is good enough, couple of them are good enough, red one is better than the white one, it's all nonsense. Alcohol does only harm. There's nothing good it does. Doesn't even do good to heart, because that was also for the drink to sell. It did nothing. It was all bunkum. No study proved it. They just botched around it. Alcohol does you no good. Smoking makes it even worse. So smoking and alcoholism is dangerous. Well, I'm sure you heard a lot of things, but there is I've visited a few websites and you can get conflicting answers. You know, coffee is good for cancer. Another one saying coffee is bad for cancer. Tomato is good for cancer. Tomato is bad for cancer. So it's very confusing. But I'm referring to this for a particular reason, because the purpose was, excuse me, to raise the awareness. Any food that has been preserved or kept in a can for too long is harmful, generally speaking. Specifically, it's almost impossible to prove it, but let's look at evidence, because except God, everybody has to produce evidence. This is generally the gut feeling of people. Like he mentioned, this used to be good, so it should be good. You know, most of the studies are observational, and they've been looking and following up the patients, hoping that they are right. There are very few randomized control trials, although you cannot have parachute trials. When you cannot do all the time, every time in a randomized control trial. This has been seen. This is a nurses' health study. It's one study which has been quoted by many, where you can see red meat, smoked and processed meat. In the northeast of India, they were very in Bhutan and other areas, they used to keep the smoked meat so that they could eat it for days together. Put in a lot of salt in it. That raised many when the incidence of cancers, especially the aerodigestive tract upper part, and many cancers were linked to diets were linked to breast cancer. Now see, women should consume no more than 1 drink a day, which is to suggest in a situation where people must take some drink. The idea is when you take 1, you end up taking 2, and when you take 2, you end up taking 4. And when you smoke, you start with smoke, then you go to grass, and then you go to further things. The best answer to the question is they are harmful. There's nothing good that alcohol does to anybody, and certainly not to the neighbor. You know what it does. The broccoli trial, and this was an interesting study, so I thought I'll share with you. Now, they say broccoli is beneficial, and it has been proven in some animal studies. Could they replicate this? Could they translate the petri dish answer to the human population? In most cases, the answer is no. They did this study, and the evidence is they used this in the mice. One set was given broccoli-rich diet, and the other one was given without it, and they were injected with the carcinogens, same dose, same time. Anurag, you can possibly take it further at your place. And they found the incidence of cancer in the broccoli group was lower. But could they replicate it in people? The answer is no. So we don't have an evidence today to say which diet is superior to the other. Generally speaking, it is a good idea to go back to what, our ancestors taught us. The food that is good for, for a human being should be eaten. Usually vegetarian diet is considered superior. Probably superior to the red meat especially, but fish is good. Red wine, here it's mentioned, in small and moderate amounts is good. Mediterranean diet, as they say it, but one is not too sure. So summing up the research, we don't have the answer. Diet is just part of the equation. So normal diet will keep you normally, you must have seen that picture, that lady smoking at 100, from the cake, which is got 100 written on it, and she's taking a fag out of it from the fire. So this was to prove that smoking also didn't cause any damage. There are so many factors, so to say one is causing it is very, very difficult. So by and large, a healthier lifestyle is going to protect you from many diseases, and especially cancer. Now, what does it show? Energy we take in, energy we spend, that is exercise. And as Dr. Bhavna was mentioning, it shouldn't be just a casual walk. It should raise your heart rate, and it should be brisk walking, but you don't need a marathon. It's not mandatory to run the hell out of yourself. You should be able to exert enough to produce, to take care of all the, it has been found that when you are usually sedentary and you're not doing activities, then certain substances rise in the system. I won't go to the details of it, which are carcinogenic. Exercise, I don't think we can emphasize more. It is very, very important, and I'll here take some, answers from Dr. Anurag in terms of the Patanjali yoga system. Because meditation and yoga have been found to be really contributing significantly. Maybe they make the person feel better, so in general he's better, and all these substances that he's secreting, like endorphins and others, they make him feel better, so cancer also is lower. Is that the reason? Yeah. Oh, did I? That's it?
That's correct, sir. Because when people do yoga, they really feel happy about themselves. And as you said, it generates all those happy hormones in them, and they start to feel that, the disease they are entering into, it would actually come out very well too. And it's also being said that the cancer cells do not thrive very well in a high oxygenated environment.
Absolutely.
So when you do a yoga, when you do pranayam, when you do bhastrika, when you do anulom vilom, you are actually pumping your body with a good amount of oxygen. And when that happens, you actually come out of the disease better. So we have a lot of patients who come there in our treatment facilities, like maybe at a given time, maybe 50 to 60 patients who are having a very mature stage of disease, and they do get treatment benefit by doing yoga routinely.
Thank you. And we all have done many studies. Everybody would have something to chip in, that in the two arms, patients put on, say, neoadjuvant chemotherapy, one with yoga and meditation, one without it, they found this did better. But in general, if you follow a good, if you're following that routine, you are a happier person in general, and happier cells do better. A cell has a memory, as we all know. As he was rightly mentioning, the cell remembers to be happy. This is something about the cell. And there is a beautiful book by Candace Persis. I think you should read about it, The Mind of a Cell. And a cell has a memory. It remembers its ancestors' memory also. So what you take as a drug, it doesn't recognize as something that it is used to knowing about. But if you take a herb, it's a food that ancestors have eaten, so it recognizes immediately. Otherwise, all drugs that we take go to liver, which is our pharmacy, and they get finally modulate it into working. So there is an advantage certainly, but I'm sure he would agree to extrapolate it into saying that it will treat cancer, I don't think would be a great idea. It is something that can prevent, and that's where we are. Or when we are treating, there is a factor for the benefit of common general population. Nutrition is important when you are treating patients, but performance status becomes more important. How well the person is spiritually, how well he feels, how happy is he. The patients do better if they're happier with, in general, with life. So this is where it can contribute. Anything?
Yeah,
Sir?
Dr. Chintamani, I wanted to add that there have been enough trials, especially when talking about yoga specifically, but other kinds of exercise as well, that the patients who, when they are on treatment, and we can talk about it in the afternoon on survivorship, but on treatment, they generally tend to do better. As you rightly said, if you have a happier cell, maybe responds better. The frame of mind is a huge difference, and maybe we can discuss it more at length, that what does mental health, how does it relate to treatment of cancer, how does it relate to quicker recovery from the treatment, especially when talking about chemotherapy and radiation. Absolutely. These are the two areas which I think there's been adequate amount of work to
absolutely.
prove.
You're absolutely right.
People have looked at interleukin, they look at various chemicals in the blood, and they found the levels to be much higher. To the best of my knowledge, that is the only proven area that we have as far as exercise and cancer treatment is concerned.
Thank you, and you're right, absolutely. Performance status is general performance with the disease and with the treatment. So they do well if they are happier in general. Even if they... Also fitter. That is what makes them fitter. You're right, absolutely. Yes, Doctor. Anything to add there, Dr. Zara? Dr. Bhavna, any comments quickly? I think your ABCD did it, but if you can...
One last thing, there is a lot of data coming out which I agree with it without presenting it, is that, not only this 30 minutes of what you suggested, brisk walking, but what is also simple to do is muscle strengthening exercises. Because you do this, but you do yoga and also maybe put in 10 minutes of muscle strengthening exercises, because that also produces different kind of dynamics in the body, and there is data coming that it prevents cancer and also helps cancer women or men to tolerate treatment better.
Thank you. Dr. Sanjay, fine, move.
Yes, I think we can move.
No, we are moving anyway. Ethnicity, this is not something you can modify. Basically, broadly for the benefit of students, modifiable and non-modifiable, you all know that. The things you can't help. You're born in a particular place geographically, and you are born to a particular group of people. So there is a little bit of information on that. We know about the Ashkenazi or Eastern European Jewish heritage is a high risk because they generally carry the BRCA1 gene mutation. It is least commonly diagnosed in the Hispanic, Asian Pacific Islanders, but their incidence, the pattern changes as they shift to US or countries where the lifestyle is different. So there is, initially the Japanese were not found to have breast cancer, it was not common. But the Japanese Americans in the second or third generation started getting it. The same was true of Indians there, and the triple negative breast cancer which we find in the African Americans, women, it could be traced right down to the parts of Africa that they came from. Lisa Newman has done a lot of work on that. So this is about the ethnicity. I think I'll skip that so that we can finish it on time. Anything to highlight there, sir? Socioeconomic factors in general?
See, at one time it was always thought that people who
the disease of the rich
have a higher risk of breast cancer. But even studies done in India from a few centers that this is not really true. Fact that there is the urban-rural divide is not that marked as it used to be. There could be one reason that they have better diagnostic facilities in the cities as compared to villages. पर अब ये देखा गया है कि शहरों में और गाँव में ज़्यादा फर्क नहीं पाया है. As a matter of fact, आपके अस्पताल में down the road, you'll see as many rural as many as urban. There's
all are the same.
No change at all. Other issue which was pointed out, ki awareness, early diagnosis, I will not take the word screening for the moment, has also helped in people coming earlier, and you yourself have talked about it. But unfortunately, that has not trickled to the rural areas so much, एंड इवन डिस्ट्रिक्ट हॉस्पिटल में अगर आप जाएंगे थोड़ा सा यहाँ से 50 मील दूर चले जाइए, जो पेशेंट आते हैं दे आर कमिंग इन अ मच मोर एडवांस स्टेज. And we can go into the reasons, what are the taboos, why people don't want to come in the early stages. किसी के बच्चे की शादी है तो किसी के लड़की का इम्तहान है वगैरह वगैरह. या the other fear is, very briefly, कि the husband may leave. And we didn't talk about male breast cancer at this point. Maybe that is the top for another time.
No, absolutely, and
because,
it's rising.
Most people do not relate breast cancer to males. It is relatively very small, but जिसको होता है उससे पूछिए आप.
I mean, anything gets rarer with the less you think about it. So you make it rarer by not thinking about it.
Absolutely.
It's 1% of all cancers, but the cancers in general are increasing. The numbers would increase.
And when you have a population of 1.4 billion plus people, you can imagine the numbers.
Absolutely, absolutely, perfect. Last two questions, and I think surgery to prevent breast cancer. I think Dr. Anurag, would you like to say something? What your views?
Yeah, very briefly. So, in women carrying very high risk of breast cancer due to inheritance of some high risk genes like BRCA1, BRCA2, PALB, and P10, P53. These genes carry a very high risk, and therefore we can perform some cancer risk reducing surgery in the form of bilateral risk reducing mastectomy, of course preserving the nipple and areola and putting an implant.
So the answer is yes, sir, thank you. So I'm trying to wind up.
And also around when they have completed the family, then around 35 to 50, we can also perform bilateral risk reducing oophorectomies, salpingo-oophorectomy, to reduce the risk of ovarian cancer. So yes, surgery in some select group of women can reduce the risk of breast cancer.
Thank you, sir. This is this was there is only one take home from here. It's not something which is recommended the drop of a hat. It needs a lot of genetic counseling before you go in for a genetic test. It's indicated in a select group with a very strong family history, triple negative breast cancers, etc., etc. But don't forget the paternal side also. It's not just the maternal side cancers. And there's a panel of cancers that you should be looking at. That's number one. And number two, it is the incidence of mastectomies is rising in US. If you would all probably if you Google it and you'll know it. And we are surprised why is it happening, because they are going more and more for one side operated. They're trying to fix the other side also, so that it's all covered in the insurance. They get a breast reconstruction done entirely as they would want it. So there are many, many dogmas, confusions, misunderstanding and myths about it. So it's not something that is recommended immediately. It's counseling, real risk, and there is a percentage of calculation of a particular degree. When you have that much of risk, you should go for the Angelina Jolie effect, as they call it. But everybody asking for it, that doesn't make a lot of sense. And it is not just the breast cancer, ovarian cancer, BRCA1, BRCA2 would cover colorectal, pancreatic, male breast cancer, as Prof mentioned, also prostatic cancer. So all these are important, or any cancer also is important. But importantly, if they get it at a younger age, because that's what I was saying in the beginning, genetics is more related to the cancer that happen early. So I'm skipping that part. And these are the high risk conditions. Lobular carcinoma in situ is not cancer anymore, it's a high risk condition. So these are situations where you may go for some options, which I'm going to quickly ask Dr. Bhavna. ADH, lobular carcinoma in situ, breast density. Women with denser breast, especially in postmenopausal period, they have a high risk of developing cancer. They need to be under constant surveillance. And you know that with the density, mammography is not a great tool, because the breast, the parenchyma looks white, and the lesion also looks white. So white on white is not a very clearly demarcated lesion. Fatty breast is blackish, the fat is black, so the lesions are seen better. So they are a group of patients where there is a risk, and something to do with the chemo prevention. Dr. Bhavna, if you could quickly wrap it up in a minute, because we have the three options: tamoxifen, raloxifene, aromatase inhibitors. Tamoxifen is usually preferred in premenopausal women. Aromatase inhibitors in postmenopausal. Tamoxifen has the risk of producing thromboembolic phenomenon and endometrial cancer, etc. Hyperplasia certainly. And aromatase inhibitor is bad for the bones, so pathological fractures, etc. Now I'll hand you over for some specific specialized answers. For raloxifene, it's considered safer. Over to you, Dr. Bhavna, quickly. I was just trying to quickly give some perspective, please.
I think you've answered it. I wrote about it actually, Angelina Jolie effect, private decision, public impact. And for these women who are high risk, who carry the gene, the BRCA gene, as you said, pharmacoprevention, I call it, because it's not chemo. Pharmacoprevention with tamoxifen, which we commonly use in India, that is also an option. And as women get older, their risk of developing breast and ovarian cancer actually goes down. So I think it's very important to assess what age the lady has come to you. If she's in her 50s, probably, giving her aromatase inhibitor, if she's postmenopausal, would actually decrease the risk quite significantly of developing breast cancer. So I think all three are great options, but in India we commonly use tamoxifen and aromatase inhibitors.
Dr. Sanjay, anything? We're just going to wind up. So maybe
yes,
the last
what
few
I would
words.
like to say just a word of caution, because definitely these are protective drugs, but they are not to be used or abused by everyone and anyone. And a qualified medical oncologist has to recommend it, looking to risk-benefit ratio, because they are not without the side effect, and they will definitely benefit, number one. Number two, what is important, that they offer about 50% of the risk reduction. So still you have the risk. So be optimistic with the results, and also cautious for happening or occurring, and report early if there is any problem. This is what I would like.
Excellent point, Dr. Sanjay. Under promise, over deliver. So don't promise them moon. Like the risk reduction surgeries, this you still get. They mention contralateral prophylactic mastectomy. It's not prophylactic, because you may get, the incidence is 3%. In fact, they usually present with advanced stage, because in US especially they mention that they go out the screening radar, so they can actually get it. Yes, Prof. You'll have
basically the last few words, if I may say so. Breast cancer is preventable to a certain extent, not all. Stay healthy, stay fit and eat healthy, and maintain a rational kind of a lifestyle. You will be chances of developing breast cancer unless they are the congenital variety, which is not more than 5 or 10%, are fairly good. And also the importance of self-examination to increase awareness and early diagnosis.
Thank you. Yes.
Last but not least, yoga and vegetarianism may help, yes.
Thank you for saying that. Yoga and vegetarianism would help. And Bhavna, my apologies. That is pharmacoprevention. So we would stick to that. It's not chemo. And basically hormonal replacement. So we can go on and on. If there is any one burning question from anyone, you can ask. I mean, I'm sorry, we are barging into the next session. Any question from anyone? Dr. Anurag, yes.
There's something related to the diet. So, the ahar plays a very important role in our life. So, 3 तरह के आहार बताए गए हैं, सात्विक, राजसी और तामसी. सात्विक का क्या प्रभाव है? आयु, सत्व, बला, रोग्य, सुख, प्रीति, विवर्धना, रस्या, स्निग्धा, स्थिरा, हृदय, आहारा, सात्विक प्रिया. तो सात्विक आहार क्या करता है? आयु को बढ़ाता है, सतोगुण को बढ़ाता है, बल यानी फिजिकल स्ट्रेंथ को बढ़ाता है, प्रीति लव अफेक्शन को बढ़ाता है, विवर्धना मीन्स एनहांसर. सो सात्विक फूड एनहांसेस longevity, strength, physical strength, love and affection among each other. If you take सात्विक भोजन, अगर राजसी भोजन लेते हैं तो क्या होता है? कट, अम्ल, लवण, अति उष्ण, तीक्ष्ण, रूक्ष, विदाहिना, आहारा, राजस, श्रेष्ठा, दुख, शोका, मय प्रदा. तो कटु कड़वा बहुत ज्यादा, अम्ल मीन एसिडिक बहुत ज्यादा, खट्टा, लवण मीन सॉल्ट, सोडियम क्लोराइड, अति उष्ण, सिजलर लाइक सिजलर, अति उष्ण मीन्स हीट. सिजलर फूड आजकल बड़े बच्चों को फैशन है, सिजलर खाएंगे. तो WHO says that salt intake more than 5 grams a day increases the risk of heart disease, blood pressure, and also some cancers. If you go to Leh Ladakh,
and I was mentioning that they keep it salt. The fish is kept salted and they preserve it in salt.
Salted tea भी लेते हैं, नमक वाली चाय भी लेते हैं, तो वहाँ पे esophageal stomach cancer बहुत ज्यादा. So salt intake, अति उष्ण, तीक्ष्ण, बहुत पंजेंट, जैसे ही आपने जल जीरा या कोई चाट मसाला कुछ खाया, एकदम पूरा आपका गला जल जाता है, पूरा रिफ्लक्स इसोफेजाइटिस हो जाता है। तो ऐसे फूड से क्या होता है, दुख होता है, शोक होता है एंड बीमारी। आमय मीन्स बीमारी, कहते हैं ना पहला सुख निरोगी काया, निरामय। तो this has been told to us 5,000 years ago in Bhagavad Gita, but we ignored it. यात यामम गत रसम पूति परिश्रुतम च यत उच्छिष्टम चामेध्यम भोजनम तामस प्रियम। तामसी फूड का वर्ष बताया उन्होंने। तो यम कहते हैं एक पहर को, तो दोपहर सब लोग जानते हैं, दोपहर मीन्स दूसरा पहर। तो एक दिन में 24 घंटे में 8 पहर हैं, तो 24 को 8 से भाग दीजिए, 8 या 24, तो 3 घंटे का एक पहर हो गया, ठीक है, दोपहर दूसरा पहर।
सर,
तो बता रहे हैं कि जिस पहर में आपने खाना बनाया है
उसी में खाना
उसी पहर में खाना खाइए आप। अगर वो दूसरे पहर में खा लिया तो वो इस डेफिनेशन के अनुसार तामसी हो गया, बासी हो गया। तो जब से ये मैंने 20 साल पहले ये श्लोक पढ़ा था, तब से मैंने ब्रेड, जिसको डबल रोटी आप कहते हैं, वो बंद कर दी, क्योंकि उससे सैंडविच वगैरह जो भी बनता है। आज मॉडर्न ब्रेड बेकरी में बनी, कल मदर डेयरी मार्केट में आई, परसों आपने खरीदी, 3 दिन तो ऐसे ही पुरानी हो गई। तो बाय दिस डेफिनेशन दैट ब्रेड दैट वी कॉल डबल रोटी इन हिंदी इज तामसी, don't eat it.
Thank you so much.
Thank you.
Basically,
But
Anurag ji,
I actually, one thing there, the fact that it was written 3,000 years ago, it must be happening then also, right? Otherwise there was no need to write. And the problem has been persistent. I think everything in moderation is right. Extremes of anything are dangerous. So do not get carried away by, don't start closing down all the shops around. You shouldn't be there, you shouldn't be there, you shouldn't be there, you shouldn't be there, ultimately who will disappear. So what we should all understand is everything in moderation, even exercise skills. The sudden dropping on the tennis court, squash court, I was playing squash and my colleague just dropped, fit man, but they were overexerting. So that is also not right. So middle path of Buddha is what we should look at. I think
Last part. One thing I want to add, we are speaking of physical aspect now. Let us really think the mental aspect, stress-free life and honesty life. This is what is called in Ayurveda, Achar Rasayana. Honesty life and as well as stress-free life will really help with this, all the things what Chintamani has told me. Please, yeah.
Thank you so much, sir. I would like to thank you all for listening to us, and especially thank my learned panelists, Professor Ravi, Dr. Dhanraj, and Dr. Bhavna, Dr. Sanjay. Brilliant to have you on screen. You look as fresh and as good as if you're right there. So that is the gift of COVID to all of us. You could be anywhere, but that's making the most of the adversity. So virtually being present. Thank you all for being there. Thank you all.
Thank you.
Professor Chintamani and the panelists, it was very insightful. I would request, just take a minute, Ritesh Kakkar, Mr. Ritesh Kakkar, General Manager Marketing, Malayalam Manorama TV, to please hand over the certificates to our speakers.
Thank you, Dr. Dhanraj.
Sure. Atul, is it there? Otherwise, we can take it later after the break. Atul? I know everyone's waiting for the tea break. Apologies for it to be running a little behind. But don't worry, we'll get our 20 to 25 minutes of break. That's what I have negotiated with them. And especially when Dr. Srivastava was talking about food, I know how it can feel at times. Just before the break. Can we all clap for them?
और no more फिजूल का खर्च।
लेकिन
Thank you, Dr.
अगर इसका
Dhanraj.
फ्यूचर ऑलरेडी सिक्योर्ड हो तो?
Professor Chintamani.
Really?
Thank you. So we have our tea break now for next 20 minutes. So let's try to be back around 11:50, 55 for our next session. Thank you.
Life is about to change, है? No more 8 घंटे की नींद, no more late night movies.
इसके फ्यूचर के लिए अब नो मोर हॉलीडेज, नो मोर शॉपिंग और नो मोर फिजूल का खर्च।
लेकिन अगर इसका फ्यूचर ऑलरेडी सिक्योर्ड हो तो?
रियली?
डैडी बने हो, देवदास नहीं।
अच्छा
सीरियसली राहुल, मेरा पूरा घर नाउ इट्स एन ऑनलाइन रिटेल स्टोर। देख।
वाओ, लेकिन पैसे?
कुछ साल पहले दिवाली बोनस को इन्वेस्ट किया था।
और अब तो है LIC का यूलिप प्लान निवेश प्लस। एक बार इन्वेस्ट करो, इंश्योरेंस से सुरक्षा का लाभ और मार्केट की बढ़त का फायदा दोनों पाओ।
1 sec राहुल।
मैडम, यू आर डबल कूल।
Life is about to change, है? No more 8 घंटे की नींद, no more late night movies, no more parties with friends.
बिल्कुल सही कहा तुमने। इसके फ्यूचर के लिए अब नो मोर हॉलीडेज, नो मोर शॉपिंग और नो मोर फिजूल का खर्च।
लेकिन अगर इसका फ्यूचर ऑलरेडी सिक्योर्ड हो तो?
रियली?
डैडी बने हो, देवदास नहीं। जीना छोड़ दूंगा, हॉलीडेज छोड़ दूंगा।
स्मार्ट लोगों की क्लियर है प्रायोरिटी, बाकी सब बाद में। क्यूट वाले मेहमान से पहले LIC।
पता है, I was a bright student. कुछ करना चाहती थी, कुछ बनना चाहती थी। आप अपना खुद का स्टार्ट कीजिए ना,
खुद का बिजनेस। पर उसमें पैसे तो बहुत लगेंगे ना?
जीरो इन्वेस्टमेंट। जीरो इन्वेस्टमेंट? हाँ, I'm doing it. मैं एक
प्रिंसिपल मैडम।
She's my client. मैं LIC एजेंट हूँ।
LIC एजेंट बनो, अब बड़ा सोचो। हमारी वेबसाइट पर जाएं या अपनी नजदीकी LIC शाखा से संपर्क करें।
पूजा जॉब छोड़ा फिर भी सो कूल।
ब्रो, नए चैलेंजेस नए मौके लाते हैं।
अच्छा
सीरियसली राहुल, मेरा पूरा घर नाउ इट्स एन ऑनलाइन रिटेल स्टोर। देख।
वाओ, लेकिन पैसे?
कुछ साल पहले दिवाली बोनस को इन्वेस्ट किया था।
और अब तो है LIC का यूलिप प्लान निवेश प्लस। एक बार इन्वेस्ट करो, इंश्योरेंस से सुरक्षा का लाभ और मार्केट की बढ़त का फायदा दोनों पाओ।
1 sec राहुल।
मैडम, यू आर डबल कूल।
Life is about to change, है? No more 8 घंटे की नींद, no more late night movies, no more parties with friends.
बिल्कुल सही कहा तुमने। इसके फ्यूचर के लिए अब नो मोर हॉलीडेज, नो मोर शॉपिंग और नो मोर फिजूल का खर्च।
लेकिन अगर इसका फ्यूचर ऑलरेडी सिक्योर्ड हो तो?
रियली?
डैडी बने हो, देवदास नहीं। जीना छोड़ दूंगा, हॉलीडेज छोड़ दूंगा।
स्मार्ट लोगों की क्लियर है प्रायोरिटी, बाकी सब बाद में। क्यूट वाले मेहमान से पहले LIC।
पता है, I was a bright student. कुछ करना चाहती थी, कुछ बनना चाहती थी। आप अपना खुद का स्टार्ट कीजिए ना,
खुद का बिजनेस। पर उसमें पैसे तो बहुत लगेंगे ना?
जीरो इन्वेस्टमेंट। जीरो इन्वेस्टमेंट? हाँ, I'm doing it. मैं एक
प्रिंसिपल मैडम।
She's my client. मैं LIC एजेंट हूँ।
LIC एजेंट बनो, अब बड़ा सोचो। हमारी वेबसाइट पर जाएं या अपनी नजदीकी LIC शाखा से संपर्क करें।
पूजा जॉब छोड़ा फिर भी सो कूल।
ब्रो, नए चैलेंजेस नए मौके लाते हैं।
अच्छा
सीरियसली राहुल, मेरा पूरा घर नाउ इट्स एन ऑनलाइन रिटेल स्टोर। देख।
वाओ, लेकिन पैसे?
कुछ साल पहले दिवाली बोनस को इन्वेस्ट किया था।
और अब तो है LIC का यूलिप प्लान निवेश प्लस। एक बार इन्वेस्ट करो, इंश्योरेंस से सुरक्षा का लाभ और मार्केट की बढ़त का फायदा दोनों पाओ।
1 sec राहुल।
मैडम, यू आर डबल कूल।
Life is about to change, है? No more 8 घंटे की नींद, no more late night movies, no more parties with friends.
बिल्कुल सही कहा तुमने। इसके फ्यूचर के लिए अब नो मोर हॉलीडेज, नो मोर शॉपिंग और नो मोर फिजूल का खर्च।
लेकिन अगर इसका फ्यूचर ऑलरेडी सिक्योर्ड हो तो?
रियली?
डैडी बने हो, देवदास नहीं। जीना छोड़ दूंगा, हॉलीडेज छोड़ दूंगा।
स्मार्ट लोगों की क्लियर है प्रायोरिटी, बाकी सब बाद में। क्यूट वाले मेहमान से पहले LIC।
पता है, I was a bright student. कुछ करना चाहती थी, कुछ बनना चाहती थी। आप अपना खुद का स्टार्ट कीजिए ना,
खुद का बिजनेस। पर उसमें पैसे तो बहुत लगेंगे ना?
जीरो इन्वेस्टमेंट। जीरो इन्वेस्टमेंट? हाँ, I'm doing it. मैं एक
प्रिंसिपल मैडम।
शी इज माई क्लाइंट। मैं LIC एजेंट हूँ।
LIC एजेंट बनो, अब बड़ा सोचो। हमारी वेबसाइट पर जाएं या अपनी नजदीकी LIC शाखा से संपर्क करें।
मुझे जॉब छोड़ा फिर भी सो कूल।
ब्रो, नए चैलेंजेस नए मौके लाते हैं।
अच्छा,
सीरियसली राहुल, मेरा पूरा घर नाउ इट्स एन ऑनलाइन रिटेल स्टोर। देख।
वाओ, लेकिन पैसे?
कुछ साल पहले दिवाली बोनस को इन्वेस्ट किया था।
और अब तो है LIC का यूलिप प्लान निवेश प्लस। एक बार इन्वेस्ट करो, इंश्योरेंस से सुरक्षा का लाभ और मार्केट की बढ़त का फायदा दोनों पाओ।
वन सेक राहुल।
मैडम, यू आर डबल कूल।
Life is about to change, है? No more 8 घंटे की नींद, no more late night movies, no more parties with friends.
बिल्कुल सही कहा तुमने। इसके फ्यूचर के लिए अब नो मोर हॉलीडेज, नो मोर शॉपिंग और नो मोर फिजूल का खर्च।
लेकिन अगर इसका फ्यूचर ऑलरेडी सिक्योर्ड हो तो?
रियली?
डैडी बने हो, देवदास नहीं। जीना छोड़ दूंगा, हॉलीडेज छोड़ दूंगा।
स्मार्ट लोगों की क्लियर है प्रायोरिटी, बाकी सब बाद में। क्यूट वाले मेहमान से पहले LIC।
पता है, I was a bright student. कुछ करना चाहती थी, कुछ बनना चाहती थी। आप अपना खुद का स्टार्ट कीजिए ना।
खुद का बिजनेस, पर उसमें पैसे तो बहुत लगेंगे ना।
जीरो इन्वेस्टमेंट। जीरो इन्वेस्टमेंट? हाँ, I'm doing it. मैं एक
प्रिंसिपल मैडम।
शी इज माई क्लाइंट। मैं LIC एजेंट हूँ।
LIC एजेंट बनो, अब बड़ा सोचो। हमारी वेबसाइट पर जाएं या अपनी नजदीकी LIC शाखा से संपर्क करें।
मुझे जॉब छोड़ा फिर भी सो कूल।
ब्रो, नए चैलेंजेस नए मौके लाते हैं।
अच्छा,
सीरियसली राहुल, मेरा पूरा घर नाउ इट्स एन ऑनलाइन रिटेल स्टोर। देख।
वाओ, लेकिन पैसे?
कुछ साल पहले दिवाली बोनस को इन्वेस्ट किया था।
और अब तो है LIC का यूलिप प्लान निवेश प्लस। एक बार इन्वेस्ट करो, इंश्योरेंस से सुरक्षा का लाभ और मार्केट की बढ़त का फायदा दोनों पाओ।
वन सेक राहुल।
मैडम, यू आर डबल कूल।
Life is about to change, है? No more 8 घंटे की नींद, no more late night movies, no more parties with friends.
बिल्कुल सही कहा तुमने। इसके फ्यूचर के लिए अब नो मोर हॉलीडेज, नो मोर शॉपिंग और नो मोर फिजूल का खर्च।
लेकिन अगर इसका फ्यूचर ऑलरेडी सिक्योर्ड हो तो?
रियली?
डैडी बने हो, देवदास नहीं। जीना छोड़ दूंगा, हॉलीडेज छोड़ दूंगा।
स्मार्ट लोगों की क्लियर है प्रायोरिटी, बाकी सब बाद में। क्यूट वाले मेहमान से पहले LIC।
पता है, I was a bright student. कुछ करना चाहती थी, कुछ बनना चाहती थी। आप अपना खुद का स्टार्ट कीजिए ना।
खुद का बिजनेस, पर उसमें पैसे तो बहुत लगेंगे ना।
जीरो इन्वेस्टमेंट। जीरो इन्वेस्टमेंट? हाँ, I'm doing it. मैं एक
प्रिंसिपल मैडम।
शी इज माई क्लाइंट। मैं LIC एजेंट हूँ।
LIC एजेंट बनो, अब बड़ा सोचो। हमारी वेबसाइट पर जाएं या अपनी नजदीकी LIC शाखा से संपर्क करें।
मुझे जॉब छोड़ा फिर भी सो कूल।
ब्रो, नए चैलेंजेस नए मौके लाते हैं।
अच्छा,
सीरियसली राहुल, मेरा पूरा घर नाउ इट्स एन ऑनलाइन रिटेल स्टोर। देख।
वाओ, लेकिन पैसे?
कुछ साल पहले दिवाली बोनस को इन्वेस्ट किया था।
और अब तो है LIC का यूलिप प्लान निवेश प्लस। एक बार इन्वेस्ट करो, इंश्योरेंस से सुरक्षा का लाभ और मार्केट की बढ़त का फायदा दोनों पाओ।
वन सेक राहुल।
मैडम, यू आर डबल कूल।
Life is about to change, है? No more 8 घंटे की नींद, no more late night movies, no more parties with friends.
बिल्कुल सही कहा तुमने। इसके फ्यूचर के लिए अब नो मोर हॉलीडेज, नो मोर शॉपिंग और नो मोर फिजूल का खर्च।
लेकिन अगर इसका फ्यूचर ऑलरेडी सिक्योर्ड हो तो?
रियली?
डैडी बने हो, देवदास नहीं। जीना छोड़ दूंगा, हॉलीडेज छोड़ दूंगा।
स्मार्ट लोगों की क्लियर है प्रायोरिटी, बाकी सब बाद में। क्यूट वाले मेहमान से पहले LIC।
पता है, I was a bright student. कुछ करना चाहती थी, कुछ बनना चाहती थी। आप अपना खुद का स्टार्ट कीजिए ना।
खुद का बिजनेस, पर उसमें पैसे तो बहुत लगेंगे ना।
जीरो इन्वेस्टमेंट। जीरो इन्वेस्टमेंट? हाँ, I'm doing it. मैं एक
प्रिंसिपल मैडम।
शी इज माई क्लाइंट। मैं LIC एजेंट हूँ।
LIC एजेंट बनो, अब बड़ा सोचो। हमारी वेबसाइट पर जाएं या अपनी नजदीकी LIC शाखा से संपर्क करें।
मुझे जॉब छोड़ा फिर भी सो कूल।
ब्रो, नए चैलेंजेस नए मौके लाते हैं।
अच्छा,
सीरियसली राहुल, मेरा पूरा घर नाउ इट्स एन ऑनलाइन रिटेल स्टोर। देख।
वाओ, लेकिन पैसे?
कुछ साल पहले दिवाली बोनस को इन्वेस्ट किया था।
और अब तो है LIC का यूलिप प्लान निवेश प्लस। एक बार इन्वेस्ट करो, इंश्योरेंस से सुरक्षा का लाभ और मार्केट की बढ़त का फायदा दोनों पाओ।
वन सेक राहुल।
मैडम, यू आर डबल कूल।
Life is about to change, है? No more 8 घंटे की नींद, no more late night movies, no more parties with friends.
बिल्कुल सही कहा तुमने। इसके फ्यूचर के लिए अब नो मोर हॉलीडेज, नो मोर शॉपिंग और नो मोर फिजूल का खर्च।
लेकिन अगर इसका फ्यूचर ऑलरेडी सिक्योर्ड हो तो?
रियली?
डैडी बने हो, देवदास नहीं। जीना छोड़ दूंगा, हॉलीडेज छोड़ दूंगा।
स्मार्ट लोगों की क्लियर है प्रायोरिटी, बाकी सब बाद में। क्यूट वाले मेहमान से पहले LIC।
पता है, I was a bright student. कुछ करना चाहती थी, कुछ बनना चाहती थी। आप अपना खुद का स्टार्ट कीजिए ना, खुद का बिजनेस। और उसमें पैसे तो बहुत लगेंगे ना। जीरो इन्वेस्टमेंट। जीरो इन्वेस्टमेंट? हाँ, I'm doing it. मैं एक प्रिंसिपल मैडम। She's my client. मैं LIC एजेंट हूँ।
LIC एजेंट बनो, अब बड़ा सोचो। हमारी वेबसाइट पर जाएं या अपनी नजदीकी LIC शाखा से संपर्क करें।
मुझे जॉब छोड़ा फिर भी सो कूल।
ब्रो, नए चैलेंजेस नए मौके लाते हैं।
अच्छा,
सीरियसली राहुल, मेरा पूरा घर नाउ इट्स एन ऑनलाइन रिटेल स्टोर। देख।
वाओ, लेकिन पैसे?
कुछ साल पहले दिवाली बोनस को इन्वेस्ट किया था।
और अब तो है LIC का यूलिप प्लान निवेश प्लस। एक बार इन्वेस्ट करो, इंश्योरेंस से सुरक्षा का लाभ और मार्केट की बढ़त का फायदा दोनों पाओ।
वन सेक राहुल।
मैडम, यू आर डबल कूल।
Life is about to change, है? No more 8 घंटे की नींद, no more late night movies, no more parties with friends.
बिल्कुल सही कहा तुमने। इसके फ्यूचर के लिए अब नो मोर हॉलीडेज, नो मोर शॉपिंग और नो मोर फिजूल का खर्च।
लेकिन अगर इसका फ्यूचर ऑलरेडी सिक्योर्ड हो तो?
रियली?
डैडी बने हो, देवदास नहीं। जीना छोड़ दूंगा, हॉलीडेज छोड़ दूंगा।
स्मार्ट लोगों की क्लियर है प्रायोरिटी, बाकी सब बाद में। क्यूट वाले मेहमान से पहले LIC।
पता है, I was a bright student. कुछ करना चाहती थी, कुछ बनना चाहती थी। आप अपना खुद का स्टार्ट कीजिए ना, खुद का बिजनेस। और उसमें पैसे तो बहुत लगेंगे ना। जीरो इन्वेस्टमेंट। जीरो इन्वेस्टमेंट? हाँ, I'm doing it. मैं एक प्रिंसिपल मैडम। She's my client. मैं LIC एजेंट हूँ।
LIC एजेंट बनो, अब बड़ा सोचो। हमारी वेबसाइट पर जाएं या अपनी नजदीकी LIC शाखा से संपर्क करें।
मुझे जॉब छोड़ा फिर भी सो कूल।
ब्रो, नए चैलेंजेस नए मौके लाते हैं।
अच्छा,
सीरियसली राहुल, मेरा पूरा घर नाउ इट्स एन ऑनलाइन रिटेल स्टोर। देख।
वाओ, लेकिन पैसे?
कुछ साल पहले दिवाली बोनस को इन्वेस्ट किया था।
और अब तो है LIC का यूलिप प्लान निवेश प्लस। एक बार इन्वेस्ट करो, इंश्योरेंस से सुरक्षा का लाभ और मार्केट की बढ़त का फायदा दोनों पाओ।
वन सेक राहुल।
मैडम, यू आर डबल कूल।
Life is about to change, है? No more 8 घंटे की नींद, no more late night movies, no more parties with friends.
बिल्कुल सही कहा तुमने। इसके फ्यूचर के लिए अब नो मोर हॉलीडेज, नो मोर शॉपिंग और नो मोर फिजूल का खर्च।
लेकिन अगर इसका फ्यूचर ऑलरेडी सिक्योर्ड हो तो?
रियली?
डैडी बने हो, देवदास नहीं। जीना छोड़ दूंगा, हॉलीडेज छोड़ दूंगा।
स्मार्ट लोगों की क्लियर है प्रायोरिटी, बाकी सब बाद में। क्यूट वाले मेहमान से पहले LIC।
पता है, I was a bright student. कुछ करना चाहती थी, कुछ बनना चाहती थी। आप अपना खुद का स्टार्ट कीजिए ना, खुद का बिजनेस। और उसमें पैसे तो बहुत लगेंगे ना। जीरो इन्वेस्टमेंट। जीरो इन्वेस्टमेंट? हाँ, I'm doing it. मैं एक प्रिंसिपल मैडम। She's my client. मैं LIC एजेंट हूँ।
LIC एजेंट बनो, अब बड़ा सोचो। हमारी वेबसाइट पर जाएं या अपनी नजदीकी LIC शाखा से संपर्क करें।
मुझे जॉब छोड़ा फिर भी सो कूल।
ब्रो, नए चैलेंजेस नए मौके लाते हैं।
अच्छा,
सीरियसली राहुल, मेरा पूरा घर नाउ इट्स एन ऑनलाइन रिटेल स्टोर। देख।
वाओ, लेकिन पैसे?
कुछ साल पहले दिवाली बोनस को इन्वेस्ट किया था।
और अब तो है LIC का यूलिप प्लान निवेश प्लस। एक बार इन्वेस्ट करो, इंश्योरेंस से सुरक्षा का लाभ और मार्केट की बढ़त का फायदा दोनों पाओ।
वन सेक राहुल।
मैडम, यू आर डबल कूल।
Life is about to change, है? No more 8 घंटे की नींद, no more late night movies, no more parties with friends.
बिल्कुल सही कहा तुमने। इसके फ्यूचर के लिए अब नो मोर हॉलीडेज, नो मोर शॉपिंग और नो मोर फिजूल का खर्च।
लेकिन अगर इसका फ्यूचर ऑलरेडी सिक्योर्ड हो तो?
रियली?
डैडी बने हो, देवदास ने जीना छोड़ दूंगा, हॉलीडेज छोड़ दूंगा।
स्मार्ट लोगों की क्लियर है प्रायोरिटी, बाकी सब बाद में। क्यूट वाले मेहमान से पहले LIC।
पता है, आई वॉज अ ब्राइट स्टूडेंट, कुछ करना चाहती थी, कुछ बनना चाहती थी। आप अपना खुद का स्टार्ट कीजिए ना, खुद का बिजनेस। पर उसमें पैसे तो बहुत लगेंगे ना। जीरो इन्वेस्टमेंट। जीरो इन्वेस्टमेंट? हाँ, आई एम डूइंग इट। मैं एक प्रिंसिपल मैडम, शी इज माई क्लाइंट। मैं LIC एजेंट हूँ।
LIC एजेंट बनो, अब बड़ा सोचो। हमारी वेबसाइट पर जाएं या अपनी नजदीकी LIC शाखा से संपर्क करें।
मुझे जॉब छोड़ा फिर भी सो कूल।
ब्रो, नए चैलेंजेस नए मौके लाते हैं।
अच्छा,
सीरियसली राहुल, मेरा पूरा घर नाउ इट्स एन ऑनलाइन रिटेल स्टोर। देख।
वाओ, लेकिन पैसे?
कुछ साल पहले दिवाली बोनस को इन्वेस्ट किया था।
और अब तो है LIC का यूलिप प्लान निवेश प्लस। एक बार इन्वेस्ट करो, इंश्योरेंस से सुरक्षा का लाभ और मार्केट की बढ़त का फायदा दोनों पाओ।
वन सेक राहुल।
मैडम, यू आर डबल कूल।
लाइफ इज अबाउट टू चेंज है। नो मोर 8 घंटे की नींद, नो मोर लेट नाइट मूवीज, नो मोर पार्टीज विद फ्रेंड्स।
बिल्कुल सही कहा तुमने। इसके फ्यूचर के लिए अब नो मोर हॉलीडेज, नो मोर शॉपिंग और नो मोर फिजूल का खर्च।
लेकिन अगर इसका फ्यूचर ऑलरेडी सिक्योर्ड हो तो?
रियली?
डैडी बने हो, देवदास ने जीना छोड़ दूंगा, हॉलीडेज छोड़ दूंगा।
स्मार्ट लोगों की क्लियर है प्रायोरिटी, बाकी सब बाद में। क्यूट वाले मेहमान से पहले LIC।
पता है, आई वॉज अ ब्राइट स्टूडेंट, कुछ करना चाहती थी, कुछ बनना चाहती थी। आप अपना खुद का स्टार्ट कीजिए ना, खुद का बिजनेस। और उसमें पैसे तो बहुत लगेंगे ना। जीरो इन्वेस्टमेंट। जीरो इन्वेस्टमेंट? हाँ, आई एम डूइंग इट। मैं एक प्रिंसिपल मैडम, शी इज माई क्लाइंट। मैं LIC एजेंट हूँ।
LIC एजेंट बनो, अब बड़ा सोचो। हमारी वेबसाइट पर जाएं या अपनी नजदीकी LIC शाखा से संपर्क करें।
मुझे जॉब छोड़ा फिर भी सो कूल।
ब्रो, नए चैलेंजेस नए मौके लाते हैं।
अच्छा,
सीरियसली राहुल, मेरा पूरा घर नाउ इट्स एन ऑनलाइन रिटेल स्टोर। देख।
वाओ, लेकिन पैसे?
कुछ साल पहले दिवाली बोनस को इन्वेस्ट किया था।
और अब तो है LIC का यूलिप प्लान निवेश प्लस। एक बार इन्वेस्ट करो, इंश्योरेंस से सुरक्षा का लाभ और मार्केट की बढ़त का फायदा दोनों पाओ।
वन सेक राहुल।
मैडम, यू आर डबल कूल।
लाइफ इज अबाउट टू चेंज है। नो मोर 8 घंटे की नींद, नो मोर लेट नाइट मूवीज, नो मोर पार्टीज विद फ्रेंड्स।
बिल्कुल सही कहा तुमने। इसके फ्यूचर के लिए अब नो मोर हॉलीडेज, नो मोर शॉपिंग और नो मोर फिजूल का खर्च।
लेकिन अगर इसका फ्यूचर ऑलरेडी सिक्योर्ड हो तो?
रियली?
डैडी बने हो, देवदास ने जीना छोड़ दूंगा, हॉलीडेज छोड़ दूंगा।
स्मार्ट लोगों की क्लियर है प्रायोरिटी, बाकी सब बाद में। क्यूट वाले मेहमान से पहले LIC।
पता है, आई वॉज अ ब्राइट स्टूडेंट, कुछ करना चाहती थी, कुछ बनना चाहती थी। आप अपना खुद का स्टार्ट कीजिए ना, खुद का बिजनेस। और उसमें पैसे तो बहुत लगेंगे ना। जीरो इन्वेस्टमेंट। जीरो इन्वेस्टमेंट? हाँ, आई एम डूइंग इट। मैं एक प्रिंसिपल मैडम, शी इज माई क्लाइंट। मैं LIC एजेंट हूँ।
LIC एजेंट बनो, अब बड़ा सोचो। हमारी वेबसाइट पर जाएं या अपनी नजदीकी LIC शाखा से संपर्क करें।
मुझे जॉब छोड़ा फिर भी सो कूल।
ब्रो, नए चैलेंजेस नए मौके लाते हैं।
अच्छा,
सीरियसली राहुल, मेरा पूरा घर नाउ इट्स एन ऑनलाइन रिटेल स्टोर। देख।
वाओ, लेकिन पैसे?
कुछ साल पहले दिवाली बोनस को इन्वेस्ट किया था।
और अब तो है LIC का यूलिप प्लान निवेश प्लस। एक बार इन्वेस्ट करो, इंश्योरेंस से सुरक्षा का लाभ और मार्केट की बढ़त का फायदा दोनों पाओ।
वन सेक राहुल।
मैडम, यू आर डबल कूल।
लाइफ इज अबाउट टू चेंज है। नो मोर 8 घंटे की नींद, नो मोर लेट नाइट मूवीज, नो मोर पार्टीज विद फ्रेंड्स।
बिल्कुल सही कहा तुमने। इसके फ्यूचर के लिए अब नो मोर हॉलीडेज, नो मोर शॉपिंग और नो मोर फिजूल का खर्च।
लेकिन अगर इसका फ्यूचर ऑलरेडी सिक्योर्ड हो तो?
रियली?
डैडी बने हो, देवदास ने जीना छोड़ दूंगा, हॉलीडेज छोड़ दूंगा।
स्मार्ट लोगों की क्लियर है प्रायोरिटी, बाकी सब बाद में। क्यूट वाले मेहमान से पहले LIC।
पता है, आई वॉज अ ब्राइट स्टूडेंट, कुछ करना चाहती थी, कुछ बनना चाहती थी। आप अपना खुद का स्टार्ट कीजिए ना, खुद का बिजनेस।
पर उसमें पैसे तो बहुत लगेंगे ना।
जीरो इन्वेस्टमेंट।
जीरो इन्वेस्टमेंट?
हाँ, आई एम डूइंग इट। मैं एक
प्रिंसिपल मैडम,
शी इज माई क्लाइंट। मैं LIC एजेंट हूँ।
LIC एजेंट बनो? अब बड़ा सोचो। हमारी वेबसाइट पर जाएं या अपनी नजदीकी LIC शाखा से संपर्क करें।
मुझे जॉब छोड़ा फिर भी सो कूल।
ब्रो, नए चैलेंजेस नए मौके लाते हैं।
अच्छा,
सीरियसली राहुल, मेरा पूरा घर नाउ इट्स एन ऑनलाइन रिटेल स्टोर। देख।
वाओ, लेकिन पैसे?
कुछ साल पहले दिवाली बोनस को इन्वेस्ट किया था।
और अब तो है LIC का यूलिप प्लान निवेश प्लस। एक बार इन्वेस्ट करो, इंश्योरेंस से सुरक्षा का लाभ और मार्केट की बढ़त का फायदा दोनों पाओ।
वन सेक राहुल।
मैडम, यू आर डबल कूल।
लाइफ इज अबाउट टू चेंज है। नो मोर 8 घंटे की नींद, नो मोर लेट नाइट मूवीज, नो मोर पार्टीज विद फ्रेंड्स।
बिल्कुल सही कहा तुमने। इसके फ्यूचर के लिए अब नो मोर हॉलीडेज, नो मोर शॉपिंग और नो मोर फिजूल का खर्च।
लेकिन अगर इसका फ्यूचर ऑलरेडी सिक्योर्ड हो तो?
रियली?
डैडी बने देवदास नहीं। जीना छोड़ दूंगा, हॉलीडेज छोड़ दूंगा।
स्मार्ट लोगों की क्लियर है प्रायोरिटी, बाकी सब बाद में। क्यूट वाले मेहमान से पहले LIC।
पता है, आई वॉज अ ब्राइट स्टूडेंट। कुछ करना चाहती थी, कुछ बनना चाहती थी।
आप अपना खुद का स्टार्ट कीजिए ना, खुद का बिजनेस। पर उसमें पैसे तो बहुत लगेंगे ना।
जीरो इन्वेस्टमेंट।
जीरो इन्वेस्टमेंट?
हाँ, आई एम डूइंग इट। मैं एक
प्रिंसिपल मैडम,
शी इज माई क्लाइंट। मैं LIC एजेंट हूँ।
LIC एजेंट बनो? अब बड़ा सोचो। हमारी वेबसाइट पर जाएं या अपनी नजदीकी LIC शाखा से संपर्क करें।
मुझे जॉब छोड़ा फिर भी सो कूल।
ब्रो, नए चैलेंजेस नए मौके लाते हैं।
अच्छा,
सीरियसली राहुल, मेरा पूरा घर नाउ इट्स एन ऑनलाइन रिटेल स्टोर। देख।
वाओ, लेकिन पैसे?
कुछ साल पहले दिवाली बोनस को इन्वेस्ट किया था।
और अब तो है LIC का यूलिप प्लान निवेश प्लस। एक बार इन्वेस्ट करो, इंश्योरेंस से सुरक्षा का लाभ और मार्केट की बढ़त का फायदा दोनों पाओ।
वन सेक राहुल।
मैडम, यू आर डबल कूल।
लाइफ इज अबाउट टू चेंज है। नो मोर 8 घंटे की नींद, नो मोर लेट नाइट मूवीज, नो मोर पार्टीज विद फ्रेंड्स।
बिल्कुल सही कहा तुमने। इसके फ्यूचर के लिए अब नो मोर हॉलीडेज, नो मोर शॉपिंग और नो मोर फिजूल का खर्च।
लेकिन अगर इसका फ्यूचर ऑलरेडी सिक्योर्ड हो तो?
रियली?
डैडी बने देवदास नहीं। जीना छोड़ दूंगा, हॉलीडेज छोड़ दूंगा।
स्मार्ट लोगों की क्लियर है प्रायोरिटी, बाकी सब बाद में। क्यूट वाले मेहमान से पहले LIC।
पता है, आई वॉज अ ब्राइट स्टूडेंट। कुछ करना चाहती थी, कुछ बनना चाहती थी।
आप अपना खुद का स्टार्ट कीजिए ना, खुद का बिजनेस। पर उसमें पैसे तो बहुत लगेंगे ना।
जीरो इन्वेस्टमेंट।
जीरो इन्वेस्टमेंट?
हाँ, आई एम डूइंग इट। मैं एक
प्रिंसिपल मैडम,
शी इज माई क्लाइंट। मैं LIC एजेंट हूँ।
LIC एजेंट बनो? अब बड़ा सोचो। हमारी वेबसाइट पर जाएं या अपनी नजदीकी LIC शाखा से संपर्क करें।
मुझे जॉब छोड़ा फिर भी सो कूल।
ब्रो, नए चैलेंजेस नए मौके लाते हैं।
अच्छा,
सीरियसली राहुल, मेरा पूरा घर नाउ इट्स एन ऑनलाइन रिटेल स्टोर। देख।
वाओ, लेकिन पैसे?
कुछ साल पहले दिवाली बोनस को इन्वेस्ट किया था।
और अब तो है LIC का यूलिप प्लान निवेश प्लस। एक बार इन्वेस्ट करो, इंश्योरेंस से सुरक्षा का लाभ और मार्केट की बढ़त का फायदा दोनों पाओ।
वन सेक राहुल।
मैडम, यू आर डबल कूल।
लाइफ इज अबाउट टू चेंज है। नो मोर 8 घंटे की नींद, नो मोर लेट नाइट मूवीज, नो मोर पार्टीज विद फ्रेंड्स।
बिल्कुल सही कहा तुमने। इसके फ्यूचर के लिए अब नो मोर हॉलीडेज, नो मोर शॉपिंग और नो मोर फिजूल का खर्च।
लेकिन अगर इसका फ्यूचर ऑलरेडी सिक्योर्ड हो तो?
रियली?
डैडी बने देवदास नहीं। जीना छोड़ दूंगा, हॉलीडेज छोड़ दूंगा।
स्मार्ट लोगों की क्लियर है प्रायोरिटी, बाकी सब बाद में। क्यूट वाले मेहमान से पहले LIC।
पता है, आई वॉज अ ब्राइट स्टूडेंट। कुछ करना चाहती थी, कुछ बनना चाहती थी।
आप अपना खुद का स्टार्ट कीजिए ना, खुद का बिजनेस। पर उसमें पैसे तो बहुत लगेंगे ना।
जीरो इन्वेस्टमेंट।
जीरो इन्वेस्टमेंट?
हाँ, आई एम डूइंग इट। मैं एक
प्रिंसिपल मैडम,
शी इज माई क्लाइंट। मैं LIC एजेंट हूँ।
LIC एजेंट बनो? अब बड़ा सोचो। हमारी वेबसाइट पर जाएं या अपनी नजदीकी LIC शाखा से संपर्क करें।
मुझे जॉब छोड़ा फिर भी सो कूल।
ब्रो, नए चैलेंजेस नए मौके लाते हैं।
अच्छा,
सीरियसली राहुल, मेरा पूरा घर नाउ इट्स एन ऑनलाइन रिटेल स्टोर। देख।
वाओ, लेकिन पैसे?
कुछ साल पहले दिवाली बोनस को इन्वेस्ट किया था।
और अब तो है LIC का यूलिप प्लान निवेश प्लस। एक बार इन्वेस्ट करो, इंश्योरेंस से सुरक्षा का लाभ और मार्केट की बढ़त का फायदा दोनों पाओ।
वन सेक राहुल।
मैडम, यू आर डबल कूल।
Life is about to change, है? No more 8 घंटे की नींद, no more late night movies, no more parties with friends.
बिल्कुल सही कहा तुमने। इसके फ्यूचर के लिए अब नो मोर हॉलीडेज, नो मोर शॉपिंग और नो मोर फिजूल का खर्च।
लेकिन अगर इसका फ्यूचर ऑलरेडी सिक्योर्ड हो तो?
रियली?
डैडी बने, देवदास नहीं। जीना छोड़ दूंगा, हॉलीडेज छोड़ दूंगा।
स्मार्ट लोगों की क्लियर है प्रायोरिटी, बाकी सब बाद में। क्यूट वाले मेहमान से पहले LIC।
पता है, I was a bright student. कुछ करना चाहती थी, कुछ बनना चाहती थी। आप अपना खुद का स्टार्ट कीजिए ना, खुद का बिजनेस। और उसमें पैसे तो बहुत लगेंगे ना। जीरो इन्वेस्टमेंट। जीरो इन्वेस्टमेंट? हाँ, I'm doing it. मैं एक प्रिंसिपल मैडम। She's my client. मैं LIC एजेंट हूँ।
LIC एजेंट बनो, अब बड़ा सोचो। हमारी वेबसाइट पर जाएं या अपनी नजदीकी LIC शाखा से संपर्क करें।
मुझे जॉब छोड़ा फिर भी सो कूल।
ब्रो, नए चैलेंजेस नए मौके लाते हैं।
अच्छा?
सीरियसली राहुल, मेरा पूरा घर नाउ इट्स एन ऑनलाइन रिटेल स्टोर। देख।
वाओ, लेकिन पैसे?
कुछ साल पहले दिवाली बोनस को इन्वेस्ट किया था।
और अब तो है LIC का यूलिप प्लान निवेश प्लस। एक बार इन्वेस्ट करो, इंश्योरेंस से सुरक्षा का लाभ और मार्केट की बढ़त का फायदा दोनों पाओ।
वन सेक राहुल।
मैडम, यू आर डबल कूल।
Life is about to change, है? No more 8 घंटे की नींद, no more late night movies, no more parties with friends.
बिल्कुल सही कहा तुमने। इसके फ्यूचर के लिए अब नो मोर हॉलीडेज, नो मोर शॉपिंग और नो मोर फिजूल का खर्च।
लेकिन अगर इसका फ्यूचर ऑलरेडी सिक्योर्ड हो तो?
रियली?
डैडी बने, देवदास नहीं। जीना छोड़ दूंगा, हॉलीडेज छोड़ दूंगा।
स्मार्ट लोगों की क्लियर है प्रायोरिटी, बाकी सब बाद में। क्यूट वाले मेहमान से पहले LIC।
पता है, I was a bright student. कुछ करना चाहती थी, कुछ बनना चाहती थी। आप अपना खुद का स्टार्ट कीजिए ना, खुद का बिजनेस। और उसमें पैसे तो बहुत लगेंगे ना। जीरो इन्वेस्टमेंट। जीरो इन्वेस्टमेंट? हाँ, I'm doing it. मैं एक प्रिंसिपल मैडम। She's my client.
May I request everyone to settle down now? We are about to begin our next session. Can I request everyone to settle down and also close the doors to the hall, please? Can you increase the volume? Hello? May I request everyone to please settle down? Mr. Ramesh, if you can help us with closing of the doors. Thank you. And there's a request that has come that I know we ladies are famous for our little chit-chats, but I didn't agree with the person, but there's a request if we can avoid whispers, and if it's urgent, can step out, and once the conversation is over, can be back in the hall. All right, so moving on, the next topic for our panel discussion is breast cancer care perspectives, patients, providers, and enablers. For this discussion, I request our panelists to please join us on stage. Dr. Navneet Kaur, Professor of Surgery, University College of Medical Sciences and GTB Hospital, New Delhi. Dr. Anita Dhar, Professor, Department of Surgical Disciplines, AIIMS, New Delhi. Dr. Neeti Chhabra, Founder and President, Yes to Life. And Dr. Anurag Srivastava, former Professor and Head of Department of Surgery, AIIMS, New Delhi. Please, sir. Dr. Navneet Kaur is a professor of surgery at University College of Medical Sciences and GTP Hospital, serving there for last 28 years. She pioneered oncoplastic breast surgery in India after acquiring training at European Institute of Oncology at Milan, Italy. A founder member and currently the honorary treasurer of Association of Breast Surgeons of India, she has published many research papers in the area of breast cancer survivorship. Her other areas of interest include medical education technology and healthcare management. Could I please request everyone to settle down? There's a lot of disturbance that's happening. Ma'am, please. And also, sir, can I request someone to close the door? There's a lot of noise coming from the outside. Thank you so much. Thank you. Moving on, Dr. Anita Dhar is a professor at Department of Surgery, AIIMS, New Delhi. She has over 32 years of extensive experience in breast-related surgery and is actively raising awareness related to self-breast examination. Her research experience lies in mastalgia and lymphedema. She has presented many scientific papers at national and international levels. Dr. Neeti Chhabra is a breast cancer winner, having dealt with this disease at young age of, yes, why not? Having dealt with this disease at a young age of 31, she left her full-time corporate profession and made her mission to serve others struggling with this dreaded disease. She founded Yes to Life in 2014, an NGO which works towards breast cancer awareness, cancer screening, and patient support. A breast care center has recently been opened in Gurgaon to aid the mission further. She's a TEDx speaker and also an author. Last but not the least, our moderator for this session, Dr. Srivastava, who needs no further introduction. So, sir, over to you.
Thank you, thank you. May I take the liberty of inviting a very learned person in the field of breast care, Mrs. Jyotsna Govil, ma'am. She is the chairperson of the Delhi branch of Indian Cancer Society and has been serving our mothers and sisters afflicted by breast cancer for almost half a century. 40, for nearly 40 years, nearly so. She slipped in the bathroom and injured her. Yeah. So, you slipped. So, can you just, okay, shall I hold you there? Please.
Let me speak from.
The chair में बैठना नहीं आप?
मैं खड़ी हो सकती हूँ. My problem is my eye, not anything else. So I'm happy standing.
Whatever you're comfortable.
हाँ, chair यहाँ रख देते हैं. यहाँ रख.
Whenever you feel comfortable, you can sit and stand.
Chalo, I'll do one of the things, either sit or stand.
She has an appointment with her eye doctor, so we'll start with her views about the survivorship and breast care, and then let you go. Okay? Thank you. Thank you.
Sorry that I'm hurrying in on your session. Dr. Srivastav has been very kind in asking me to come up and speak at this event. I think the rest of the event is talking about the way forward. I want to go back a little bit, because until we understand where we have come from, We don't realize the extent of progress that has been made and the huge opportunities that there are ahead of us. I start, Dr. Srivastav, with the first of my lessons, which is gratitude. Gratitude to all the patients, to all the survivors, to all the doctors. I've put the doctors last for a specific reason. When we started Cancer Sahyog in 1991, we were the odd persons out. Doctors needed patients, and patients needed doctors. Nobody knew quite what to do with us. So we have made a place for ourselves and for other support groups, because I dare say we were the first of the support groups in Delhi. This special cause, or the special feeling, the unique identity of our organization is that our members are survivors, cancer survivors, caregivers, and others who want to do something for the benefit of everyone. My gratitude is to all of them, because I believe that I have learned much from everybody. I see Dr. Raina sitting right in front. He was one of our first trainers. He was known as quite a dragon in IRCH. We didn't find him so, because I think all the dragons have very tender hearts. And he has accepted a lot of nonsense, perhaps, from us. I remember a conference we went to in Udaipur, Dr. Raina, where you were the moderator. And you told me that when I press the orange button, it means that you have a minute and you stop. Well, Dr. Raina pressed that orange button I don't know how many times. I didn't stop. The great thing was he didn't touch the red button. So I said everything that I wanted to. So today, maybe that will happen. Yeah? The next lesson I learned was from patients. You know, everyone says women come late. They don't know why they come late. Sometimes women come with different issues, and nobody asks them, why have you come late? If they come to a breast clinic, you only look at the breast. But what about the rest of the woman? I remember one woman whose job it was to break stones. You know, jo rodi banti hai. She was wrapped up, it was winter, she was wrapped up in a shawl. And one day when she was adjusting her shawl, we noticed that she was very pregnant. She'd been taking her chemotherapy, I think it was adriamycin, and we were scared that something would happen to her baby. But nobody in the 8 months that she had been coming to the clinic even realized that she was pregnant. Should she have stayed at home? Well, this woman chose to come and be treated for her cancer first. We sent her to the gynae department, and we told her, now don't come back till the baby is born, and we were really scared that the baby might be malformed. The next week she comes, she thrusts a dirty blanket into my arms and say, "Yellow." Yellow. When I looked down, it was the most beautiful baby. And she called her Lakshmi. I've never forgotten that. What else did we learn? A great many things, but I don't want to delay your session. So my basic message is that it's not the textbooks that are required. We do need them. We do need information about cancer as support workers. But our cardinal rule for all our members is don't give medical advice. You won't find two doctors in the room who agree with each other. There'll always be an if or a but. Ravi, I think you know. So with the ifs and the buts, it's best that we keep our mouths shut on medical affairs. So I have had a very eventful, a very fulfilling 40 years with patients, with everyone in the field of cancer. So I thank the doctors who trained us. I thank the doctors who put up with us in their clinics, even though they had no clue as to what we were actually doing. And generally, to everyone, but most particularly our members who are here today, thank you. God bless you all.
Thank you, ma'am. I wish you well and fast recovery, and may God bless you. Thank you. Thanks for coming and enlightening us with your experience. So we start with the rest of the session, and the first speaker in this session, a very important session, is by Dr. Neeti Lekha Chhabra, founder of the President Yes to Life. So Dr. Neeti, please. Would you have some presentation, PowerPoint presentation, or just... Okay, okay. Express your views.
Hi, a very good morning to all of you, and thank you for having me over. So, as introduced, I am a breast cancer winner. I got diagnosed in 2012. I was working as a professor at that time, and two things that triggered me at that point were, one, that I was 31 at that time. You know, my son was 3 years old. Thankfully, I was diagnosed at an early stage, but a lot of women whom I was meeting during my treatment were around the same age, but their diagnosis had happened at very later stages, you know. So it always pained me to think that how difficult it must be for them mentally to think about their future, you know, with small kids. And two, when I went to a government hospital, I saw the burden of cancer patients, you know, the way that they were waiting on the floors, waiting for their turns to come. And I thought that something had to be done. And the burden of cancer in India is so much that you cannot only rely on government or the hospitals to do everything. So I thought that instead of feeling bad for people, there's something that I need to do, my bit towards the cause, and that is how Yes to Life started in 2014. And 2 years back, we started a breast cancer center in Sector 45, Gurgaon. And the idea and the vision behind the center is to reach out to all the villages, starting with Gurgaon. So what we do is we adopt each village at a time. We've finished with one village. We reached out to 1,000+ families. We do door-to-door breast cancer awareness. The team goes there, teaches them how to do self-breast exam, what are the signs and symptoms. We give them brochures that have pictures of how to do examinations. Every Monday, we have free of cost OPD for these women, which is taken by Dr. Kanchan Kaur, Senior Director from Medanta. And one day in a week, we also do cancer screenings for these women. We go to Anganwadis along with a team of doctors who do their clinical breast examinations. And when these ladies come to us, we take care of all their screening needs, whether it is mammography, ultrasound, moving forward, somebody needs a biopsy, PET CT, MRI, whatever it is. Because what I have seen is that these women are more open to coming to us rather than people who are more educated, you know. You give them awareness, still they are somewhere in denial or they're fearful. But with women who are coming from rural villages, if they know that financially they'll be taken care of, they are much more open to come to you. And anybody who gets diagnosed with cancer, we also help them out with treatment support. And the reason why I am very often asked this question, that why only breast cancer? One is because we are a team of breast cancer winners, so our knowledge lies in this area. Number two, I personally find it very cruel to tell somebody that you have cancer and then to tell them that go and fetch for yourself if they are from, lower income group. And the burden for breast cancer only is so large that one can do only as much. So that is why we work only in the area of breast cancer. And for people from rural sectors, we start from giving them awareness to OPD, to screenings, to treatment support, everything. And for educated people, our primary role is doing breast cancer awareness talks. Thank you.
Thank you, ma'am, for wonderful presentation of a unique initiative that you have taken and increasing the awareness and teaching them breast self-examination. If you read the literature, most of the oncologists and cancer care groups in America, Europe, they will say that self-breast examination has no role. They will quote 2 trials done in Shanghai and one in Philippines, that the trial where half of the women in the trial were taught to do self-breast examination, examining their own breasts, and the other half were just left to, as a control group. And they demonstrated that there was no reduction in mortality. Just on this basis, the whole world is taught by these American groups that there is no role of teaching breast self-examination. On the other hand, it may be harmful because it will pick up lot of false negative, fibroadenoma, cysts, etc., and ladies will get unnecessary alarms. We do not buy this American or European idea because breast self-examination is the only way of becoming aware of breast self-health. जैसे आप चेहरा अपना देखते हैं, आप हेयर करते हैं, men हम लोग शेव करते हैं, तो इस तरह से लेडीज अगर नहाते समय, कपड़े बदलते समय अगर एक बार, महीने में एक बार, सिर्फ रोज नहीं कह रहे हम, अगर ब्रेस्ट अपना देख लेते हैं कि भाई एक निपल ऊपर जा रहा है, पहले तो नीचे था, ऐसा छोटा सा कोई भी चेंज, एनी चेंज फॉर दैट, डिम्पलिंग है. So what is the harm? It is being done at no cost, no radiation exposure, and so we should not buy everything that is being taught in the Western literature. So I'm very glad that you are teaching them breast self-examination. We ourselves have made films in Hindi, English, and all the vernacular languages in India through the National Health Mission, and it is being distributed for training by the ASHA worker and ANMs. So anybody can take this copy of this film on self-breast examination. The other thing you're doing very well is using clinical breast examination. I'm really glad that you're adopting clinical breast examination rather than mammography. In 30% cancers, 1/3 cancers among our mothers occur in the age group of 30 to 50. This is the most of the data, Shankar Narayanan's data, sir. So in 30 to 50 age group, mammography doesn't work because breast is radio dense, absolutely white, and you can't see white on white. So in this age group, I think clinical breast examination, plus doing self-breast examination is the only way of picking the disease early, as Dr. Raina emphasized on early detection. So thank you and congratulations.
Just to add one point, sir, here, since we've been talking about late presentation of breast cancer and the mortality rate being higher in India because of late presentation, our aim is to look at downstaging cancer. And since we cannot take mammography everywhere, since we are working with rural sections, so I think everybody who's sitting here also should start to do their self-breast exams and also tell your family members, your friends about how easy it is to do and, just encourage them to do it every month.
Thank you, thank you. So thank you, ma'am. So now I request Dr. Anita Dhar, who is a senior professor of surgery in the Department of Surgical Disciplines, All India Institute of Medical Sciences, AIIMS, New Delhi. And she has done a lot of work on breast care and breast cancer care. So Dr. Anita, please have a mic.
So,
you have some slides? Or yes,
I have. As was requested to touch the topic of lymphedema amongst these
If you want to
patients.
present your slides, you can.
I can.
You can come here.
So from the audience, somebody just asked about the density of the breast. They were a little confused whether this density of the breast is what we palpate. We're not talking about on self-examination density of breast. It's an image designated line, like when we do mammogram, the radiologist will look at that image and then tell how dense the breast is. Please don't confuse it on yourself when you are palpating what kind of breast is dense. So that I thought of giving this clarification. Maybe others also have this type of mindset towards the density. So we know after any type of surgery, whether it's a breast conservative surgery or it's a full breast removal, there are many survivors out here with variety of surgeries already done on them. And it's a hard fact. It's a hard fact to know that any surgery has its own complication. No matter how brilliant the surgeon is, how best the patient has been their response. So every surgery has its own type of some after effects of complications. Lymphedema is one of them. And earlier everybody would believe that all the lymph nodes जो गांठें हैं, बगल की गांठें हैं, उन सबको निकाला गया तो इसीलिए लिम्फेडिमा हुआ. बट फिर पूरे दुनिया में उस थॉट को लेके काफ़ी रिसर्च हो गई. सेंटिनल लिम्फ नोड बायोप्सी किया गया, मतलब कि सबसे पहले एक गांठ जो लिम्फ नोड सबके लिए मैं बता दूं, जैसे हमारा गला खराब हो जाता है तो यहाँ पे एक गिट्ठी सी बन जाती है गले के अंदर, तो बहुत दर्द होता है उसमें, लेकिन जैसे जैसे गला ठीक हो जाता है वो ख़त्म हो जाता है. वो है लिम्फ नोड. हमारे पूरी बॉडी में कई सारे ऐसे नोड्स हैं जो प्रोटेक्शन देते हैं, हमें रोकते हैं उस इन्फेक्शन को. नहीं तो हर बार जब भी इन्फेक्शन हो पूरी बॉडी में फैल जाए, ऐसा नहीं होता है. सो वैसे ही कुदरत ने, नेचर ने ऐसा बनाया है कि ब्रेस्ट से निकलने हुई कुछ भी सेल्स हो वो बगल वाली गांठ आर्म पिट में जाता है. आर्म पिट में ऐसे ही कई सारे लिम्फ नोड्स होते हैं. सो उसमें से एक लिम्फ नोड ऐसा होता है जिसमें सबसे पहले पहुंचता है वो. सो रिसर्चर्स ने, साइंटिस्ट ने ये देखा कि अगर हम उस एक नोड को सबसे पहले ढूंढे अलग अलग विधियों से, और जो कि अब हिंदुस्तान में ऑलमोस्ट हर सेंटर में किया जाता है, और वो उस नोड को ढूंढ के उसमें देखें कण है या नहीं है, तो हम बाकी के गांठें नहीं निकालें, जिसके कारण हमें लगता है कि भैया ये बहुत सूजन आ जाती है बाजू में. सो सूजन बाजू में आना आफ्टर सर्जरी, ब्रेस्ट सर्जरी, लिम्फेडिमा है. सूजन वेन की वजह से भी आता है. मैं यहाँ पे आपको एक इमेज दिखा रही हूँ, ये आपको दिख रहा है. सो लाल वाला है हार्ट से खून निकल के आर्टरी में जाता है खून, जो कि पूरा हमारी फिंगर्स तक पहुँचता है. और ये नीली वाली जो है ये वापस लाती है खून हार्ट के अंदर. लेकिन इस दौरान, आने और जाने के दौरान, कुछ पानी रिश्ता है जो हमारी बॉडी के अंदर रह जाता है, टिश्यूज़ के अंदर रह जाता है. उसके साथ प्रोटीन और कई सारे पदार्थ होते हैं, बहुत ज़रूरी होता है हमारे शरीर के लिए. सो एक थर्ड सिस्टम है, तीसरा है लिम्फेटिक्स, जो उसको सबको पकड़ के वापस ले आता है सर्कुलेशन में फेंकने के लिए. सो हम तभी हमारी बॉडी सूझती नहीं है, हम वैसे ही बने रहते हैं. सो ये तीसरा साइलेंटली काम करता है. सो इसमें भी बहुत ही साइलेंटली ये काम करता है लिम्फेटिक्स, जो हमारा पूरा वो पानी निकालता रहता है. बट जब सर्जरी होती है, चाहे वो सेंट्रल लिम्फ नोड बायोप्सी हो, उसमें बहुत ही कम है. बट जब पूरा का पूरा निकाला जाए, चांसेस हैं उसमें ज़्यादा हो. स्पेशली अगर किसी का ज़्यादा पानी बना हो, सिरोमा हो, या किसी का इन्फेक्शन हो. ये सारी चीज़ें हमें ध्यान रखनी है ऑपरेशन से दौरान सर्जन को, और उसके बाद साफ़ सुथरा रखना है, सिरोमा नहीं होना चाहिए, इसका केयर करना है. ये सारी चीज़ें उसको ज़्यादा बनने देती हैं लिम्फेडिमा को. तो होता क्या है, सूज जाती है बाजू. सो आर्म पिट में स्कारिंग बोलते हैं उसको, अगर वो बिल्कुल फंस जाए वहाँ पे वो टिश्यू, वो उससे भी ज़्यादा हो जाता है. फिर अगर उस मरीज़ को रेडियोथेरेपी भी उसके ऊपर मिले, एडवांस डिजीज़ है, रेडियोथेरेपी की भी ज़रूरत होती है. कई प्रकार की कीमोथेरेपी भी देखी गई है, उसमें लिम्फेडिमा थोड़ा सा ज़्यादा है बाकी कीमोथेरेपी से। गांठें अगर और ज़्यादा बड़ी हों, हमें पूरी की पूरी निकालनी पड़ी और ऊपर तक जाना पड़ा, तो उसमें क्या होता है, कभी कभी जो बाजू की ड्रेनेज है जहाँ से वो लिम्फ निकले वो फंस जाता है उसके अंदर, तो उससे भी चांसेस होते हैं कि हमारा बाजू सूज जाए, जो रुक जाए वो लिम्फ जिसको हम बात कर रहे हैं। तो और क्या क्या तरीके हैं जो हम इसको बचाने के लिए कर सकते हैं। वेट कंट्रोल देखा गया है, जैसे जैसे किसी भी लेडी का वज़न बढ़ जाता है, ऑपरेशन के बाद काम करने के लिए मना करते हैं घर वाले, या वो खुद काम कर लेती है कम, तो वज़न बढ़ने लगता है। सो वो नहीं होने देना है, वज़न अपना कंट्रोल करना है। एक्सरसाइजेज, सिर्फ बाजू के एक्सरसाइज नहीं, पूरे शरीर के एक्सरसाइजेज वेट कंट्रोल करेंगी। काम करना बंद मत कीजिए, उससे वज़न कंट्रोल में रहेगा, एक स्टेबल सा वेट रहेगा, गेन नहीं करेंगे आप, जो कि डायरेक्टली इसके साथ संबंधित होता है, लिम्फेडिमा और बुरा बना देता है। एक्सरसाइजेस हमने बात की, शोल्डर के एक्सरसाइजेस और पूरी शरीर के एक्सरसाइजेस। फटीग की बात करते हैं, कीमोथेरेपी के बाद बॉडी फटीग्ड हो जाती है। सो आज अभी पहले सेशन में किसी ने बात की मसल उसको स्ट्रेंथन करने के लिए खाली चलना नहीं है, अलग अलग ग्रुप की एक्सरसाइजेस करनी है ताकि उसको उसकी फ्लेक्सिबिलिटी, उसको थोड़ा स्ट्रांग बना जाए हर मसल ग्रुप को। वो बहुत ज़रूरी है क्योंकि फटीग आ जाती है। कई सारी लेडीज़ कंप्लेन करती है कीमोथेरेपी के बाद सुस्ती आ गई, थोड़ा वीक है। वीक माइंड नहीं होता, बहुत स्ट्रांग है। सब लेडीज़ बहुत स्ट्रांगली फेस करती हैं, अपना घर का काम भी करती हैं, फाइट भी करती हैं कैंसर के अगेंस्ट, बट कहीं ना कहीं थोड़ी फटीग आ जाती है, उसमें एक्सरसाइज करने की ज़रूरत पड़ती है उनको। सो फिर हम कॉम्प्रेशन देते हैं, चूज़ करते हैं पेशेंट्स को कैसे करना है, आगे क्या क्या तरीके देने हैं। इन्फेक्शन की वजह से उनका ट्रीटमेंट देते हैं हम, कई प्रकार की ट्रीटमेंट्स शुरू होती हैं उनकी और वो कंटिन्यू करनी पड़ती है, और कई प्रकार की ट्रीटमेंट्स जो टाइमली देनी पड़ती है उनको बीच बीच में, अगर किसी का इस्टेब्लिश हुआ हो। कई सारी विधियां हैं पहले से ही उसको जानने के लिए कि हो रहा है या नहीं हो रहा है। मेजरमेंट्स हम करते हैं, पेशेंट्स खुद को पता चल जाता है कि थोड़ा सा ड्रेस टाइट होने लगा या हेवी होने लगी बाजू, तो वो वाला ध्यान रखेंगे। और एक्सरसाइजेज स्पेसिफिक फॉर आर्म और गारमेंट्स, कॉम्प्रेशन, बैंडेज, ये सारी विधियां हैं, और पम्प्स आर अवेलेबल, वो खाली ट्रीटमेंट के लिए जब इस्टेब्लिश हो जाए। कई सारी मिथ्स हैं, ब्लड प्रेशर नहीं लेना चाहिए, इंजेक्शन नहीं लगाना चाहिए, ट्रैवल नहीं करना चाहिए, कई सारी मिथ्स हैं। इसमें सच्चाई कितनी है, क्या है, आपके माइंड में भी कई सारे सवाल होंगे। इंजेक्शन के लिए हम मना करते हैं क्योंकि इन्फेक्शन होने के चांसेस होते हैं। बीपी कफ एक बार लगाया जाए ऐसा कुछ होता नहीं है, जेंटली अगर लगाया जाए कुछ फ़र्क नहीं पड़ती है। एयर ट्रैवल में कोई फ़र्क नहीं पड़ती है, बहुत ही 12 घंटे का हम ट्रैवल है लोअर लिम्स के लिए, सॉफ्ट कंप्रेशन दे देते हैं, स्लीव उसमें स्टॉकिंग्स पहना देते हैं, बट ऐसा कुछ फ़र्क नहीं पड़ती है। ओबेसिटी की हमने पहले से बात की। सेम साइड पे सोना, कई सारे लेडीज़ शायद कई महीनों तक और सालों तक शायद उसी साइड से कभी सोए नहीं हो, बट अगर हम प्रिकॉशंस ले कोई कुछ नहीं होता, कोई कॉम्प्रेशन नहीं है। नॉर्मल इंसान भी अगर एक ही साइड में पूरे घंटे घंटे हिसाब से सो जाए, उसकी भी बाजू सुन्न हो जाती है। सो वो एक अलग वो कैंसर की वजह से नहीं है, ऑपरेशन की वजह से नहीं है उसकी ज़रूरत। और ये एक जस्ट एक आपको दिखाने के लिए है कि पहला वाला स्लाइड जो है इसमें दिखाया गया है, ये जो लिम्फ है ये कैसे फ्लो करता है, फटाक से ऊपर चला जाता है। ये दूसरी वाला स्लाइड है, ये रुका है। ये जस्ट आपको आइडिया देने के लिए है कि ऐसा होता है, वो दिखता नहीं है हमें बट ऐसा हो जाता है, मतलब वो रुक जाता है। उसका अगर हम जेंटल मसाज करें, स्लीव पहने, ये सब सेटल हो जाता है। रात को रखने के लिए बाजू, एक पिलो रखा, उसके ऊपर रखा, और बैंडेजिंग स्पेशल प्रकार की बैंडेज होती है जो अगर हो जाए उसके साथ बहुत हेल्प हो सकती है। और उसके बाद स्लीव पहन के दिन में ऑफिस जाना है, कोई काम करना है, वो रख सकते हैं। घर जाके स्लीव को उतार के ये बैंडेज लगा सकते हैं, बहुत फ़र्क पड़ती है। एंड देयर आर लॉट ऑफ पीपल हु आर हैप्पी डूइंग इट। ये एक फोटोग्राफ लास्ट में दिखा रही हूँ। ये एक लेडी है जिसका पहले ऐसी वाली बाजू थी, फुल एस्टैब्लिश लिम्फेडिमा। वो अपना बाजू कंगा करने के लिए तक नहीं उठा सकती थी, साइज कम फर्क नहीं पड़ता था उसको, उससे वजन जो बढ़ता है, हैवी हो जाती है बहुत बाजू, उससे फर्क पड़ता था। उसके बाद हमने कुछ विधि से सर्जरी किया उनका, ये साइज में फर्क तो आ गया, नॉर्मल बाजू तो नहीं दिख रही है बट साइज में बहुत फर्क आ गया। मोस्ट इंपॉर्टेंट था कि उसकी हल्की हो गई बाजू, जो कि वो चाहती थी, और उसको इस्तेमाल करना लगी, एंड शी इज ए हैप्पियर पर्सन नाउ। थैंक यू। सो दैट्स अ लास्ट थिंग, बी हैप्पी ऑलवेज। हैप्पीनेस से कई सारी चीजें, आज पहले सेशन में भी बोला गया, हैप्पी रहेंगे कई सारी चीजें भाग जाती हैं। थैंक यू सो मच। थैंक यू।
Thank you, Professor Anita Dhar. Wonderful presentation of a very important and common and disabling condition after breast surgery called lymphedema or legs arm swelling. जी मैम, हाँ माइक मैम को माइक दीजिए प्लीज, माइक दीजिए। नहीं, या तो आगे आ जाइए, माइक है, माइक दे दीजिए पीछे।
हेलो
जी मैम, जी।
Hello, my name is Sudha Kapoor. I'm from ICS. A friend of mine, for 2 years after surgery, she was fine, and then she suddenly developed this lymphedema. What could be the reason for that?
हाँ, तो 2 साल के बाद अगर हुआ है तो वो इन्फेक्शन कहा रहा होगा, क्योंकि जैसे डॉक्टर अनीता ने बताया कि हमारे हाथ में या शरीर के हर भाग में 2 तरह की ड्रेनेज सिस्टम है। जैसे हम इसका उदाहरण देते हैं ऐसा जनरल पब्लिक को, कि जैसे आपके घर में जो साफ पानी का पानी आता है वो नगर महापालिका से, जलकल विभाग से आता है, तो वो क्लीन वाटर है, ठीक है। तो हृदय से जो जा रहा है ऑक्सीजन, ब्लड, आर्टरी एक सिस्टम है। फिर जो लेकिन जो ड्रेनेज होती है आपके घर से बाहर, वो 2 हैं आपके यहाँ ड्रेनेज। एक तो जो है किचन का और बाथरूम का नॉट सो डर्टी वाटर, वो एक अलग नाली से जाता है, लेकिन जो दूसरा है बहुत डर्टी जिसमें बड़े पार्टिकल हैं, सीवेज का पानी, वो उसके अलग सीवेज का नाला है, ठीक है। तो इसी प्रकार से भगवान ने हमारे सिस्टम में 2 प्रकार की नलियां बनाई हैं। अच्छा खून लाने वाली हृदय से, आर्टरीज कहते हैं उसको, नाड़ी जैसे पल्स जैसे देखते हैं हम लोग, और गंदा पानी ले जाने वाली 2 तरह की नलियां हैं। एक को लिम्फेटिक्स बोला और दूसरे को वेन्स बोला। वेन तो जो नीली नीली आपको दिखती हैं जिसमें इंजेक्शन लगाते हैं, लेकिन जो डर्टी वाटर ले जा रही हैं लिम्फेटिक्स, वो बड़े बड़े स्वेलिंग पार्टिकल्स को ले जा रही हैं। और जब ब्रेस्ट की सर्जरी करते हैं हम लोग, तो बगल की गिल्टियाँ जो मैडम ने फोटो दिखाई थी, 15 से 20 गिल्टियाँ हैं, वो निकाल देते हैं, एक्सिलरी डिसेक्शन। और अगर रेडियोथेरेपी दी गई तो उसके बाद और ज़्यादा वो ब्लॉक हो जाती हैं, तो उनका कारण है लिम्फेडिमा। तो अगर 2 साल के बाद हो रहा है तो वो इन्फेक्शन से होगा। क्यों डॉक्टर नीता, क्या आपका ख्याल है?
पॉसिबिलिटी है, मरीज को देखने के बगैर ऐसे कमेंट
लेकिन क्योंकि जो ब्रेस्ट कैंसर के ट्रीटमेंट के कारण है वो इमीडिएट होना चाहिए। 2 साल के बाद अगर हो रहा है तो इसके माने इन्फेक्शन हो रहा है। तो इन्फेक्शन से क्या होता है कि थोड़ी सी लिम्फेटिक्स ब्लॉक होते हैं, लिम्फेंजाइटिस कहते हैं उसको। तो जैसे मान लीजिए 100 लिम्फेटिक्स हैं आपके हाथ में, आपने 60 या 70 निकाल दी हमने, तो अब बची जो 40 हैं उनके द्वारा भी थोड़ा गंदा पानी लिम्फ जा रहा है, ठीक है। तो आपको ज़्यादा स्वेलिंग नहीं हुई। अब जब भी इन्फेक्शन होगा, जितने अटैक होंगे इन्फेक्शन के, हर बार वो मान लीजिए 10 नलियाँ और ब्लॉक कर दी, तो फिर 10% और चली गई। तो ऐसे धीरे धीरे जितने अटैक इन्फेक्शन के होंगे हाथ में, चाहे कोई आपको सुई चुभ गई, खाना बना रहे हैं तो रोटी से हाथ जल गया, या प्रेस कर रही हैं तो थोड़ा जल गया, तो बर्न, या अगर आपको गार्डनिंग का शौक है, आपने रोज़ या जो कैक्टस वगैरह होती है उसको छू लिया, कांटे लग गए कटीले, तो उन सब से इन्फेक्शन जाता रहता है हाथ में। इसलिए हम लोग कहते हैं या तो गार्डनिंग वगैरह मत करिए, अवॉइड करिए, या गार्डनर्स ग्लव आते हैं या किचन ग्लव्स हैं वो उनको पहन के करिए, जिससे एक्स्ट्रा प्रोटेक्शन रहे। और जब भी कभी लाली सूजन हो इन्फेक्शन की, तुरंत डॉक्टर को दिखा के एंटीबायोटिक्स का एक कोर्स जरूर लीजिए।
इवन स्कारिंग,
और सर बताएंगे जी,
सख्त हो जाता है वहाँ पे स्किन,
सर को माइक दीजिए,
स्पेशली रेडियोथेरेपी के बाद स्कारिंग बोलते हैं उसको, उससे भी कई सारी लिम्फेटिक्स बंद हो जाती हैं जो कि खुली थी, तो उसमें टाइम लगता है। रेडियोथेरेपी के बाद स्कारिंग होना और ये सब हो सकता है डिलेड रीजन वो भी हो।
सर प्लीज।
मैम एक मेरा एक क्वेश्चन है आपसे, मैम एक क्वेश्चन है मेरा आपसे।
Myself. Fast becoming a thing of the past. In the last 10 years, we have seen a massive reduction in the incidence and complications due to lymphedema because of the change in the techniques of surgery, introduction of sentinel node where only limited number of nodes are removed. Now hardly a surgeon removes too many nodes. And also the introduction of chemotherapy first, which reduces the nodal burden and it therefore also reduces the risk of lymphedema. So it's fast becoming a thing of the past. I don't see so much lymphedema now.
Very true.
But
Sir-
in patients, so, who was the lady who was saying that it has happened after 2 years, one, of course, infection is there. Other possibility is the recurrence in the axilla, in the lymph nodes. That has to be investigated.
थैंक यू सर, थैंक यू।
हाँ, सर,
प्रोफेसर
मैं-
रैना इस सभा में सबसे ज़्यादा लर्नेड एक्सपीरियंस्ड ब्रेस्ट कैंसर केयर के डॉक्टर हैं, ऑन्कोलॉजिस्ट हैं, तो वी आर रियली ऑनर्ड बाय हिज प्रेजेंस। सो इन रिकरेंस का जो बताया सर ने, रिकरेंस हो रही है एक्जिला में, उससे भी और लिम्फेडिमा हो सकता है, तो उसका ख्याल चेक करें। Dr.
Sir, मेरा एक
Navneet Kaur
question है।
is a senior professor of surgery and especially dedicated to care of women suffering from breast disease at the University College of Medical Sciences, Shahadra, GTB Hospital, and she has done her PhD on breast cancer survivorship, how women cope after surgery for breast cancer. This was her PhD topic, and I was fortunate to be her PhD thesis examiner. So, Dr. Navneet, please.
Sorry, sir. May I,
I
ask
think
a question?
there is a question.
Yes, ma'am.
I would just like to add कि there is a session on survivorship, जिसमें कि आपके ये सारे सवाल जो कि survivor से mainly interest करते हैं, वो address करने की कोशिश करी जाएगी. This session is meant for talking about perspectives in breast cancer care and enablers. So let's stick to the theme of this particular session, and survivorship care में हम वो वाले सवालों को भी ले सकते हैं. Again, thank you, Dr. Anurag, for that generous introduction. क्योंकि आई वॉज एक्सपेक्टिंग अ पैनल डिस्कशन, तो मैंने कोई पीपीटी नहीं बनाया, और रैंडम थॉट्स जो कि मैं स्टिकिंग टू द थीम इनेबलर्स एंड पर्सपेक्टिव्स इन केयर. सो व्हाट कैन बी माय टेक होम मैसेज ऑन दिस प्लेटफॉर्म इज, जब हम ब्रेस्ट कैंसर की बात करते हैं तो उसके डिफरेंट स्टेजेस हैं, राइट फ्रॉम स्क्रीनिंग और अर्ली डिटेक्शन टू डायग्नोसिस टू ट्रीटमेंट एंड टू आफ्टर केयर. And at every level, at the moment, we are definitely far behind the desired objectives. We are far behind the developed world with which we compare our standards. And what can be the enablers for each of these stages, right? जिसमें से हमने piecemeal काफ़ी कुछ discuss किया already. हम लोगों ने बात करी कि screening के लिए हमारे पास में कोई ऐसा solid tool नहीं है जो कि पूरी population पे हम apply कर सकें और we get the best results in a cost-effective manner. सो एज ऑन डेट जो हमारे पास में इफेक्टिव टूल है वो है ब्रेस्ट अवेयरनेस. हम इन वर्ड्स के बीच में बात करते रहते हैं, सेल्फ एग्जामिनेशन, क्लिनिकल एग्जामिनेशन, मैमोग्राफिक स्क्रीनिंग इज डेफिनेटली अ मोर सोफिस्टिकेटेड वे ऑफ लुकिंग एट द अर्ली डिटेक्शन. अगर हम इन बारीकियों में नहीं जाएं, क्योंकि ये भी स्टडी हुई कि अगर हम और बहुत ज़्यादा अवेयर कर देते हैं कि आप ये चेंजेस देखिए कि थोड़ा सा निपल ऊपर है तो गड़बड़ है, अगर थोड़ा टीथरिंग है तो गड़बड़ है, तो पीपल बिकम ओवर कॉन्शियस, ओवर एंशियस, और ज़रा सा भी चेंज जो कि एक नॉर्मल भी हो सकता है उस पर्टिकुलर ब्रेस्ट के लिए, बिकॉज आवर ब्रेस्ट आर नॉट आइडेंटिकल ट्विंस, दे कैन हैव स्लाइट डिफरेंसेस. तो वो अननेसेसरी एंग्जाइटी पैदा कर रहा था. इसीलिए जो स्टडी हुई शंघाई में, यूएसए में, दे सेड कि नो, सेल्फ एग्जामिनेशन इज नॉट अ गुड टूल. But at the same time, at least knowing what the normal breast looks like or being breast aware is the most basic tool which is required as an enabler for early detection. और अगर हम इस बात को भी हमने आई थिंक 20 बार रिपीट किया इस सेशन के दौरान भी, एंड एवर सिंस वी टॉक अबाउट ब्रेस्ट कैंसर अवेयरनेस प्रिवेंशन, कि आप जल्दी अगर उस चीज़ को पिकअप कर लेते हैं तो उसका ट्रीटमेंट इज़ मच बेटर. ट्रीटमेंट हैज़ डेफिनेटली एडवांस्ड ड्रामेटिकली. तो जो एक सर्जरी का एक मेजर रोल हुआ करता था, आई थिंक दैट हैज़ बीन श्रिंकिंग, नॉट टू द दिस थिंग ऑफ सर्जन्स जो कि लीड टीम मेंबर्स हुआ करते थे इस टीम के. लेकिन अब सिस्टमिक थेरेपी बहुत मेजर रोल प्ले करती है, वो बीमारी को उतना श्रिंक कर देती है जिसमें कि हम मिनिमल सर्जरी के साथ में मिनिमल डैमेज टू द ह्यूमन बॉडी वी कैन गेट द ट्यूमर आउट एंड कंट्रोल इट. तो अर्ली डायग्नोसिस इज़ इम्पॉर्टेंट. जो लोग जानते भी हैं कि उनको गांठ है, वो या तो डिनाई करते हैं, दे कीप ऑन डिनाइंग द एग्जिस्टेंस. आई हैव ऑल द पेशेंट्स कमिंग इन कि था लेकिन हमें लगा कि ठीक हो जाएगा, कुछ उसमें बदलाव नहीं था, सडनली 2 ही दिन पहले देखा, पहले तो कभी था भी नहीं. So if you pick up something which is looking not good, it is desirable. Not everybody is a patient here. So it is reporting early and not denying a symptom. उसके बाद भी बहुत प्रॉब्लम्स है. हॉस्पिटल में नेविगेशन इज़ अ बिग इशू, स्पेशली इन पब्लिक हॉस्पिटल्स जहाँ पर कि इतनी भीड़ है. एक टेस्ट की रिपोर्ट 1 महीने में आती है, उसी में इतना कुछ डिले हो जाता है. और पेशेंट हॉस्पिटल में रिपोर्ट करने के बाद में भी 5-6 महीने तक उसका जब तक ट्रीटमेंट का नंबर आता है उसकी स्टेज आगे बढ़ सकती है. So I think this is not at the level of the doctors, these are policy matters. Lekin we should have more infrastructure because we have definitely far more numbers of cancers which are happening now, multiple factors. जो चीज़ में सबसे ज़्यादा मेरे को आई वुड लाइक टू कन्वे ऑन दिस प्लेटफॉर्म इज व्हेन वी डिसाइड ट्रीटमेंट, इट हैज़ टू बी अ शेयर्ड डिसीजन मेकिंग. जब भी पेशेंट को डायग्नोसिस बनता है, दे आर स्टन्ड, दे विल बी लाइक इन शॉक कि ये मेरे साथ क्यों हो गया, मेरे को ये क्यों हो गया, नहीं कुछ और ही होगा, है ना. डॉक्टर्स मुझे ज़बरदस्ती डरा रहे हैं, जल्दी से उन्होंने ऐसे बोल दिया. वी विल गो टू द सेकेंड डॉक्टर, वी विल ट्राई द ऑल्टरनेटिव ट्रीटमेंट, मे बी दैट विल वर्क फॉर मी. सो ट्रीटमेंट डिसीजन को लेके पहले तो बहुत डायलेमा होता है. उसके बाद में एक होता है कि जो डॉक्टर ने कहा वही ठीक है, जो डॉक्टर डिसाइड करेंगे वो ठीक है. व्हाट इज, एंड इवन डॉक्टर्स सो फार हैज़ बीन यूज्ड टू दिस पेटर्नलिस्टिक एटीट्यूड कि मैं पेशेंट को, मैं आई नो द बेस्ट क्या है उसके लिए, और मेरे बताए ट्रीटमेंट के हिसाब से पेशेंट को फॉलो करना चाहिए. दैट विल बी फॉर द बेस्ट इंटरेस्ट ऑफ द पेशेंट. Then people became more educated and now we have so much of information on every possible place, mobiles, internet. तो बहुत सारी information आप नेट से स्क्रीन कर सकते हो, ठीक है ना. उसके बाद में it is for everybody, not I am saying I am not addressing the patients or the survivors. So people can access lot of information on the net to know beforehand when go for a consultation कि क्या क्या चीज़ें हैं possible जो कि हो सकती हैं. And it is also the responsibility of the doctor who is treating to give information. सो टेलिंग कि हाँ ये ट्रीटमेंट हो सकता है, इसमें ये रिस्क है, इसमें ये रिस्क है, आपको इतना टाइम लगेगा, इसमें पहले ये ट्रीटमेंट होगा, नहीं तो दूसरा ट्रीटमेंट पहले होगा. क्योंकि ब्रेस्ट कैंसर में एक सिंगल ट्रीटमेंट इज़ नॉट द बेस्ट लाइन. फॉर एवरी पेशेंट देयर मे बी अ डिफरेंट सेट ऑफ काइंड ऑफ थेरेपीज विच कैन बी प्लान. दे आर इफेक्टिव. सो व्हाट इज द थर्ड मोस्ट इंपॉर्टेंट फैक्टर इज पेशेंट्स पर्सपेक्टिव्स एंड पेशेंट वैल्यूज़. डॉक्टर आपको बता सकता है, आप उस पर छोड़ सकते हो कि ठीक है डॉक्टर साहब ने कहा था, बाद में आपको अफसोस हुआ कि उन्होंने तो मुझे बताया नहीं कि छाती बच भी सकती थी, मैंने छाती निकलवा ली. या आपको उन्होंने बताया कि हाँ हो सकता है छाती बच भी सकती है, हम पूरी भी निकाल सकते हैं, हम सेंटिनल नोड भी कर सकते हैं, हम डिसेक्शन भी कर सकते हैं, सब तरह की ट्रीटमेंट. बट इट इज़ टू डिफिकल्ट टू एब्जॉर्ब दैट नॉलेज. Even as doctors, when we are giving this information, we are not 100% updated. Every day there is a new research coming in. And what we tell, we try to do our best to tell you कि ये बेस्ट एविडेंस है, ये ऐसा होता है, ठीक है. उसमें अभी भी जो चीज़ लैकिंग है वो है पेशेंट का पर्सपेक्टिव, पेशेंट की वैल्यूज़ क्या हैं, उसके लिए उस वक्त क्या चीज़ सबसे इम्पॉर्टेंट है. टू सर्वाइव, टू कट डाउन द कॉस्ट, टू नॉट टू पुट बर्डन ऑन द फैमिली, टू बी पर्टिकुलर अबाउट बॉडी इमेज, टू इफेक्ट हर सेक्शुअल लाइफ. So many things are there. Doctor cannot decide what patient is finding as important. So patient को अपना perspective डॉक्टर के साथ में डिस्कस करना ज़रूरी है. And it is also important for doctors to share in and have that bi-directional conversation कि okay, this can be done, but how important it is for you to have your breast at this point of time, because if you try conservation, you will require radiation, maybe some additional treatment which can be avoided, right? So probably इस topic में मैं I know we are already overshooting time and I'll just kind of जो मेरे लिए सबसे important message इस platform पे देने के लिए था वो ये है कि shared decision making is important so that you later on don't have regrets कि मैंने ये क्यों करा लिया, क्योंकि this is not something which can be rectified. You can have a reconstruction but it's not easy, right? So be aware and follow up is equally important. And जो लोग यहाँ पे बैठे हैं और बहुत सारे लोगों ने promptly सवाल पूछे, it is important they go back to doctors and discuss these problems. They are problems they face. Doctors are too busy. They may not ask. Even if you tell them, they may not pay attention in the first go because they are either not able to handle that or they are too busy. But it is important that you kind of, again, lot of sources are there, their support groups are there, and follow-up protocols are now being told that all should be adhered to and problems discuss करके उसका आप लोग समाधान ढूंढिए, क्योंकि बहुत चीज़ों के बहुत सोल्यूशंस हैं, केवल उनकी डिस्कशन की इम्पोर्टेंस है और उसके बारे में अवेयर होने की इम्पोर्टेंट है. आई थिंक विद दैट आई थिंक आई वुड कंक्लूड माय स्टेटमेंट.
One more point. With due respect to the family members, sometimes what happens, patient कभी discussion में होता ही नहीं है. They don't like patient to be there. They try to hide things from patient. बट आई कीप ऑन टेलिंग देम कि हर एक के घर राष्ट्रपति भवन जैसे नहीं है कि एक कमरे में बात किया और 100th कमरे में पेशेंट है कि वो सुनेगा नहीं. पेशेंट को सब पता होती है कि क्या हो रहा है उसके साथ. इट्स बेस्ट कि पेशेंट को लेके जो भी करना है डिस्कशन करें. और फैमिली का डिसीजन मेकिंग इज़ नॉट द फाइनल. पेशेंट का व्यू पॉइंट भी जानना बहुत ज़रूरी है, उसकी क्या मर्जी है, क्योंकि कभी कभी फादर हस्बैंड डिसीजन ले लेते हैं और पेशेंट की इन्वॉल्वमेंट होती नहीं है. So it's a very important part of the treatment कि उसका viewpoint जाना जाए.
Thank you, Dr. Anita.
Just half a
Yeah,
minute.
yes, please.
Since we have dignitaries, from Ministry of Health and public hospitals, private hospitals here, two requests that I feel can really help us in this area of breast cancer diagnosis and further treatment. One is that, we've been working very closely with Anganwadi workers now. And while they are working in the area of NCD, but when it comes to breast cancer, the primary thing that they do is that they go into the villages, they ask the ladies, "Aapko गांठ है?" वो कहती हैं नहीं, because they are unaware, they've never ever even touched their breasts, and they tick mark कि ये healthy हैं, इनको breast cancer का कोई issue नहीं लग रहा. So if we are able to teach Anganwadi Didis at least how to do a self-breast exam, I understand they don't have time to go and do clinical examinations on the ladies in the villages, but at least if they are taught self-breast examination, if they are at least taught signs and symptoms, they would be able to convey the same to the ladies, and they are the ones जो कि हर घर में, हर नुक्कड़ में हैं. They know all the ladies of those 100 or 200 households that each one of them has been given. And number two, we see so many women, especially from rural villages, who come and they have a lump and they say कि हम उस डॉक्टर के पास गए थे, उन्होंने ये दवाई खाने को दी, 1 महीना, 2 महीना, 3 महीना, और अब वो बढ़ गई. And I feel that it is worse in those cases because they at least took a step to go to the doctor rather than just sit at home and ignore what they had. So if, as through the government or whichever way it can be done, जो ये सारे villages में, सब urban areas में doctors हैं who don't specialize in oncology, of course, they are general physicians, they are MBBS doctors, if they can be trained into this, because so many cases actually get diagnosed in later stages despite the patients going to the doctors at the right time. अगर उन डॉक्टर्स को ट्रेन किया जा सकता है इन इवैल्यूएटिंग ब्रेस्ट, असेसिंग कि ये कुछ और हो सकता है rather than just giving a hormonal medicine or vitamin E or something, I think that can really help in downstaging it further.
Thank you, ma'am. So with this, we conclude this session. Thank you very much. Thank you, Shruti ji.
Thank you. Thank you, panelists, for that insightful discussion. Could I tell speakers to just stay for the certificate on the stage? Yeah. I request Mr. Georgia Peter Patros, General Manager Marketing, Malayalam Manorama Group, to hand over the certificate to the speakers.
Thank you so much. Thank you so much. Thank you so much.
Thank you once again. Thank you so much. Our next discussion is on innovations, disruptive technologies, and early adoption challenges in breast cancer care, risk and screening. For this discussion, I call upon the panelists to please join us on stage. Dr. Geeta Manjunath, Founder, CEO, and CTO, Niramai Bangalore. Dr. Anurag Varshney, Vice President and Head, Drug Discovery and Development Research, Patanjali Research Institute, Haridwar. Professor Chintamani, in charge Department of Breast and Endocrine at Vardhaman Mahavir Medical College, Safdarjung, New Delhi. Professor Anurag Agarwal, Dean, Bioscience and Health Research, Trivedi School of Biosciences, Ashoka University, New Delhi. Giving brief bio of each of them. Dr. Geeta Manjunath is the founder, CEO, and CTO of Niramai and has led the company to develop a breakthrough AI solution for detecting early-stage breast cancer in a non-invasive, radiation-free manner. In her over 25 years of experience in IT innovation, she has worked at various organizations like Xerox and Hewlett-Packard. A PhD from Indian Institute of Science, Bangalore, and Management Education from Kellogg's, Chicago, she has won many international and national awards. To name a few: CSI Gold Medal, Birac Winner Award, Economic Times Accenture Vahini Innovator, Biospectrum Woman Entrepreneur. She is the inventor of 20 US patents and is also on the Forbes list of top 20 self-made women 2020. Dr. Anurag Varshney is a development professional with 24 years of research and managerial experiences. He's PhD from National Center for Biological Sciences, Bangalore, and postdoctorate from Yale University School of Medicine, US. He's also the elected fellow of Royal Society of Biology, UK. Dr. Varshney has worked at different capacities at Marine Biological Labs, at Ranbaxy Research Labs, and at Daiichi Sankyo Pharmaceuticals. In multilingual, multicultural environments, he has driven more than 100 diverse research themes. Currently, Dr. Varshney and his team is adding the scientific evidences to the age-old medicinal wisdom of Ayurveda. Then we have Professor Chintamani. As shared earlier about him, is the Chief of Breast and Endocrine Unit of former Head Department of Surgery at Vardhaman Mahavir Medical College, Safdarjung Hospital, holding many titles under his belt. Last but not the least, on the panel we have Dr. Anurag Agarwal. He's Dean Biosciences and Health Research, Trivedi School of Biosciences, Ashoka University, former Director of the Institute of Genomics and Integrative Biology, CSIR. After completing graduate medical education at AIIMS, he further trained in internal medicine, pulmonary disease, and critical care at Baylor College of Medicine, Houston, followed by a PhD in physiology from Delhi University. He serves on numerous national and global advisory groups, most recently chairing the World Health Organization Technical Advisory Group for Viral Evolution. He received the Shanti Swarup Bhatnagar Prize in 2014, Sun Pharma Foundation Award in 2020, and is a fellow of the Indian National Science Academics. I request Dr. Anurag Agarwal to be the moderator for this one.
Thank you very much. It's a pleasure to be here, and thank you all for your patience while we wait for the minister and perhaps after that lunch. The least informed person in the topic of breast cancer in this very distinguished panel is myself, so I'll try to guide the discussions along some critical lines. Before me, more articulate people have pointed to great quotes from great people. I will instead choose Spider-Man. With great power comes great responsibility. And when we speak about disruptive technologies, the point is not just to disrupt, but to improve. So when we introduce these technologies, and these can be genomics, these can be AI, these can be anything. It could be new drug discovery. The point really is, how are we going to make things better? And I'm going to start with the first very illustrious panelist, Dr. Geeta Manjunath, whom we have met before. Imaging for breast cancer remains one of the most critical ways for early diagnosis. If you don't have early diagnosis, it really doesn't matter what else you do. And you have seamlessly blended the interface of artificial intelligence, medical imaging, but more importantly, research around it that would look towards making a difference to the lives of people with breast cancer. So we'd love to hear from you your thoughts in the path to disruptive innovation, such as what you did. What were the main challenges you see? What are the confusions you think progress is creating? And what do you see as the way out for all of us? Over to you.
Sure. Thank you so much. And it's really, really a great pleasure to be among experts on stage and off stage as well. I'm probably one of those sort of rare doctors who doesn't have a medical degree, but actually my PhD is in AI. And having developed an innovative solution for breast cancer, thanks to my great team to make this bigger. So just for some of you who may not be aware of what we've done at Niramai, if I may take a few minutes describing that. Also before that, because we have some survivors also, 1 minute on how I started this, right? So because Dr. Anurag said, we all know and we've all heard since morning that breast cancer is the top cancer, survivorship, and the survivor ratio, survivability ratio, everything depends on early detection. Stage 0 has 95% survival rate, whereas stage 4 can be like as low as 20% comparing 2-year survival, etc. So I was actually one of the person who got affected with my very close 2 cousin sisters who were just 38 and 42. I lost them. Mammography did not detect their cancer. I lost them in 6 months time frame, 2 of them. And I was lab director for AI research at Xerox. And suddenly I just lost 2 of my very close friends and family members. It was very shocking. Till then, I didn't even sort of bother to think about breast cancer, honestly. Right? I was solving several other problems in healthcare as well. So that's when I said, this can't happen. Looked up the statistics and saw that so many women are actually losing their life unnecessarily because, like it was said, it's something that is curable. That's when I started a small research to do this. So what is that we are doing? We wanted to first have a tool that can detect cancer even in dense breast. We've been talking about dense breast before, younger women population and so on. And X-rays can't do it. So we started using thermal imaging, that is basically measurement of tissue activity using a thermal sensor. And this was there in earlier studies, but then accuracy was questionable because it was bare eyes which was used for detection. So I said, can we use AI, an artificial intelligence or machine learning based analysis for increasing the accuracy? So we started this study on a few patients to start with and then develop this AI. So fast forward now, yes, we have developed this new method where small thermal sensors, handheld portable thermal sensors can be used to measure temperature variations. We measure about 4 lakh temperature points per person, and automated AI algorithms analyze this temperature map to say whether there's an abnormality, what is the probability that it's actually malignant, and where is the likely area so that a follow-up ultrasound and MRI and other methodologies can be used, of course biopsy before treating. And the best part is nobody sees or touches the person during this test. It's like a booth where the technician is outside and women is inside. So you go in, close the door, and then remove your clothes to sit in front of the device for about 10 minutes, and the report is generated immediately. And so far we've done many studies, 33 publications, prospective studies in different hospitals, HCG, Narayana Hridayalaya, Max, RCC, and also hopefully our ICMR results also will be ready, sir. So all of these show, very high levels of sensitivity and very low false positive rate as well. And I would love to partner with anyone here to make that happen. So expanding on the question that Dr. Anurag asked, earlier seen was that the mortality rate in India is 50 to 60%. So many women are dying because of late detection. Now, with the kind of tools which are enabled with AI that we can develop, we can at least enable people to automatically identify, that is healthcare workers to automatically identify women who need to be brought to a hospital for further diagnosis. Because you cannot take a mammogram or even an ultrasound machine to the rural areas to screen lots of women. But this is a portable method, so you could actually screen, let's say, we've done many studies. In Karnataka, for example, when we did a study on 4,000 women, only 80 people need to be brought inside. Of course, it's after multiple rounds of clinical breast examination as well as thermolytics, which we call as a test that we did. So this enables high quality healthcare to be done very precisely, and very, very early detection is possible. We can actually, with AI, analyze this data in such a way that we can detect 4 millimeters of cancer, which of course, that is clinically proven, which is basically stage 0 because it's sub-centimeters. So all this is possible because AI can analyze a lot of data. And imaging can look at high resolution information about the body, right? And it could be thermal imaging, ultrasound, or mammography. Now AI is playing a role in each of these imaging modalities, and AI in healthcare, the best application is AI in radiology. And that we are seeing sometimes used inside a hospital, and in many cases, wherever possible, used outside a hospital as well.
Maybe one follow-up question for you, Geeta, since I do know the story to some degree. I think one of the challenges that you faced, AI images in a lab, was different. But maintaining a constant temperature for every woman so the AI doesn't get confused by temperature fluctuations, you had to develop entire rooms, right? To come up with how to make it better in terms of actual performance, prevent the noise, make every situation, every image the same. Those are the usual real life problems.
Yeah, so
that
basically,
AI alone can't solve.
Yeah, so basically, just to sort of expand on that, there are many AI algorithms that are developed within the lab, and what I was mentioning in the talk I gave at your institution was that how can we enable prospective studies, real life prospective field studies, and what are the challenges that come in. So instead of just doing the AI algorithm, we had to look at it like an end-to-end, which is the device that we need to do. And the process also we had to innovate, right? So we came up with a new method of thermal imaging itself, where we blow cool air for about 8 minutes on the person. And we actually have a small booth. It's not like a very big thing. Any place you can just put 4 curtains, but we have a protocol which can actually analyze these images and capture these images in any place, be it in villages or in hospitals also. Yes, we had to innovate even on the process. We also innovated on the AI algorithms to detect that the process was followed. That is, if you have not taken one image, because we are giving this to health workers, if she makes mistakes in the protocol of imaging, that also we identified using AI algorithms.
There's always a human side to AI.
Precisely, you just said it. Wonderful, thank you for that information. There was a presentation, in fact a seminar in ACS last year, and the question that everyone was asking was, who is giving this report? Now, it's like coming from nobody who's responsible for it, so you can blame it on AI. So that becomes a very important part of treatment in cancer. The second thing is, of course, the confidentiality issue, which would erupt as we go along, not only diagnosing when treating also. I'm sure you'll address that. But when you're giving that report, particularly when you talk about screening, madam, the issues with screening, it is becoming very unpopular even in US and in Europe. And ever since they did the two cities trial, whatever you call it, they've always had this confusion, because we don't really know whether we are harming or benefiting, because when we are picking up very, very, very tiny insignificant lesions, it adds to anxiety while it may never become cancer per se. So there are a couple of issues which were there with screening anyway, but they would probably, with AI, maybe you can answer that, they may change.
Yes, it's a good point. So you don't want to pick up every small high thermal activity. So what the algorithm now does, because it's 7 years of research in refining every year, every study. So what it does is, once we find an activity which is higher than a threshold, that is also learned across cancer and non-cancer patients, we have scoring. So based on the scoring, we can identify whether the person needs an additional screening within 6 months or 1 year, or she can, it's more like high risk pickup. And if she has a scoring which is more than 0.5, that means she needs an ultrasound immediately. Because when everyone is not doing ultrasound, it's about trying to, or even mammogram, for example, it's about picking up in a right way the right people who need the follow-up diagnostic. And these have been published now in Lancet Oncology, ASCO, and all this, the results of what our test can do compared to the mammogram and all that. And your point about pricking early, like DCIS is also always a debatable thing. And that's with mammography, because every microcalcification may not be cancerous. But what thermalytics picks up is abnormal tissue activity and abnormal vascularity, which is usually resulting in a malignancy.
See, thermography has been in use in the past also, and the false positives is an issue. That is why
that's where AI plays a picture, so thank you.
In fact, Dr. Chintamani, we'll continue with your thoughts on these in a slightly different perspective. No matter what any result shows, in the end, clinical medicine is a big hairy ball. And making sense of it is difficult for anyone. And given the same piece of data, you can't even come up with exactly the same advice for two different people. One of the areas that bothers me more and more is the downstream of what we will do as AI starts determining more things. Recently, we had big deployments for diabetic retinopathy for AI. Very successful in one way, but if you look at the endpoint as people getting laser treatment for the retinopathy, the funnel was actually quite tight. So how we call success is also critical. And I'll come to you with a very specific challenge that I think genomics is throwing up. So, for example, when you look at tissue imaging and AI, you're primarily diagnosing people who have a tissue that is showing metabolic activity or some structural thing in radiology that may need to be excised, done something with. But genetic risk for breast cancer is another story altogether. It is now thought, and please correct me if I go wrong on this, that in a country with a high life expectancy, where people are no longer dying of heart attacks and infectious diseases, up to 20 to 25% of women will develop breast cancer at some point in their life. Now, if they were to have a genetic mutation increasing that risk, you could almost say it is more likely than not that they will get breast cancer in their life. These kind of genetic tests can provide information at a very young age, in theory as soon as you are born, but are not actionable at that point. So we are going to have an overload of information as we disrupt healthcare. More information can be a very complicated thing, and I would love to know your perspective on how people are planning to deal with this increasing information, knowing that on one extent we are going to see people like Angelina Jolie who decided to get all the relevant organs removed. On the other side, you would have people who are so young they can't even begin to understand, and there is not even a need to know. So your thoughts on this very, very messy topic. I know there are no right answers here, but what do you think?
Thank you very much, and you already provided the perspective so beautifully. I mean, you're talking about if you know when you're going to die, or if you know when you're going to get a disaster in life, how do you plan yourself, how do you go about it? But naturally there are not just two ways, but 200 ways of answering it. But one way that I thought would be closest to my understanding is to restrict or to tailor the information. I mean, that is something which is very, very dicey, very difficult. We are living in an era of information. You just click Google and you have so much information that it can actually make you sick. There would hardly be a normal person sitting in this room. Everybody is sick. Now, does everyone go for the same thing that we are talking about theoretically? The answer is obviously no. And it should not amount to writing a horoscope, like you will get a cancer at 30, then you will die at 35, but if you possibly go for this prayer, you will live a little longer. Probably these things came in mainly because people would stop living. Now, having said that, that's a philosophical part to it. You know, there is a definite advantage of finding it out. Patients can be, or individuals can be kept under good surveillance, and maybe you can detect it early. I'll add here, early detection is translating into better survival, but we don't really know. I know of a TNBC presenting with a less than 1 centimeter, opportunistic screening, early cancer. 6 months later, distant metastasis, and we lost the patient in a year. While large tumors can continue to grow indolent way. So it's a biology of the tumor rather than anything else that matters. It's no longer just the size. And therefore the biology has also become a part of your staging system. The reason is obviously there is a capital G of it, which we did not know earlier. So coming to the, approaching it in the algorithmic way can have its own disastrous effects, if I may say, because you would be dying more than you would be living, and the planning would be a complete mess. And I understand that you started by saying it's already messy. We can't make it messier by saying that maybe you will die at 30. And when we are doing the prophylactic or so-called risk reduction surgery, we never tell the patient you're going to live forever. You may have another cancer. Nobody lives forever. So there's another way of looking at it. Tailor it to the individual, provide the information. But you very specifically mentioned about some girl born and you know in a couple of years that she may get breast cancer later on. So even before she started living, we have killed her. So I think that's a classical example of too much information killing us for sure. We know our death is imminent. We are going to have it someday. But is it very, very important to know about the finer details? That's a gray zone. So it will depend who is providing the information and more importantly, to whom he is providing the information. I don't know whether I answered it or made it complicated even worse, but this is how I think about it. I personally tell the patient all that is necessary and nothing that is unnecessary. This is an old Morrison's aphorism in surgery. Do not unnecessarily provide information which is not going to make a difference. Having said that, I was asking this question earlier also, who is responsible for this report? Who is responsible for finally saying the word that I've said it, so that's the end of it? Always is always wrong and never is never right, especially in life and in oncology. So we don't really know. And it's very safe to say, I don't know. This is what your, the study shows. You may get it, you may not get it. It's exactly like the screening did. Screening killed more people out of fear and anxiety than out of breast cancer. They found that there was a reduction by 25% after 20 years of follow-up of the 2-county trial. But did it really translate into survival? We don't know. People reported to doctors more, they got treated early. That's what I think is the answer. Did I answer it?
I think you answered it very well.
Thank you, sir.
And it was an absolute pleasure because it's very obvious that medicine is not just a science. Medicine is an intersection of medical science and social sciences or humanities, if some people prefer to call it that, because it's really about an individual, it's about society, it's about decisions. Science is just one part of the input, and I'm so glad you brought it up. I do see, however, that you asked a very important question in the end, who will take the decision? The challenge we're going to have is how to even maintain the information. Let's say we sequence this person today, and the doctor decides, let's not convey the information. Will the information get lost? Right. So, in some ways, I think the field will come back to, Manju, your area of AI, where computers will be responsible for making sure the information is not lost, neither communicated, nor lost, but comes up as a prompt to every new doctor who sees that patient. So the decision can be made again and again, but the background of it is not lost. And that, I think, is a stage
it will be reviewed by a doctor,
we are all going to
definitely.
have to move to. From this now, let me move to our third very distinguished panelist. Once upon a time, my institute wrote an article, Old is the New. And I think more and more we are seeing that a lot of new stuff is coming from old knowledge. And you, at Patanjali, and having previously done drug discovery in a modern science drug discovery company, are wonderfully placed to tell us how we are planning to use multiplicities of knowledge to disrupt healthcare through drug discovery. And I know you have slides, so I'll let you come here. And
good afternoon, everyone. Thank you very much for this opportunity. I express my deep sense of gratitude to Professor Anurag Srivastava sir, Professor Chintamani sir, Anurag sir. He's my old chum, and calling him sir sometimes feel funny, and ma'am right over there. So today I'm going to talk a little bit about what we are doing at Patanjali and trying to see what can be done for a cancer as such. So I personally see myself as an odd one out here. I'm a basic biomedical researcher, has a little information about the disease and of course not so much information about the clinical manifestations. So pardon me if I go in a different way, but what I'm trying to say here, the theme that I am working on and the whole team behind Patanjali Research Foundation working is plant the best chemist naturally. That means when we talk about drugs, the drugs has to be synthesized in the medicinal chemistry laboratory, and they have their own inherent challenges. You have to see what kind of drug pharmacophore should be there, how it's going to look at the disease, what are the side effects going to be. It's a huge challenge. but nature does it beautifully. The plants do the synthesis of the compounds within themselves so smartly that as of today, I don't think any good medicinal chemistry can do that. So there are natural chemists that we have it around there, and I'm going to quickly talk about that. So I think the slides that I got it here, I don't think it need to be kind of discussed in this August gathering, where we're going to talk about the cancer stats, that what are there and how many people are suffering, what are the deaths and all. I can quickly go to the point that, you know, the existing cancer drugs, anti-cancer agents, has some limitation. There comes a lot of drug resistance, and the basic reasons of those are right on the screen. But what I will come into it, that drug discovery companies where I have worked in past have been developing various drugs. And if you see on screen, the anti-cancer drug pipeline in USA for 2022 have been focusing a lot into new different trials, and breast cancer comes here at number 4, where the 64 different trials were going on for looking for anti-cancer drug for breast cancer. And then if you see the number of approvals for new drugs in last 2 decades, they have been going up and down, and there are historically few blockbuster drugs and few drugs which came and actually went away. And now if I look at the latest data, which is there from 2023 in July, the latest drug that got approved like few days before, where actually has then specific mode of actions looking for controlling various form of cancer and its progression. But what really happens that, you know, most of these drugs have their own inherent problems. Sometimes they cannot be used. Sometimes they have issues with side effects. Sometimes need to have a specific patient stratification, and sometimes the cost become humongous. So the question is that, you know, when you have to reach even to that level, you have to go through a huge funnel of preclinical and clinical trials. So most of drugs get filtered out in those processes. So the thought comes that why don't we explore the traditional health system, what just now Dr. Anurag Agrawal talked about, how we can combine it together. So the traditional drug discovery route starts from the laboratory, goes towards the man or the patient, and the other way would be that you go from wrong side, you do a reverse pharmacology, which we think is the right size, to go from bench side towards the clinical needs. So what we do, we actually get fascinated by the total amount of patents that came from for anti-cancer things on plant products. It has been kind of peaking up pretty well, and there's just a list of the total amount of publications that came on anti-cancer natural products. So we thought, okay, how about we look into it? Let's focus on Ayurveda, which is our ancient medicinal system, and actually then try to see if we can hit the cancer with the big, deep strength of natural medicines. So the idea was to develop formulation inspired by Ayurveda, do a complete characterization, and come as a scientifically evidence-based research product which could be taken as an anti-cancer medication, where we have a deep understanding of mechanism of action, and we know what are the major metabolites which nature has made inside those plants are playing those roles. So with this, we start screening lots and lots of compounds. We have a library of close to 1,000 different plant extracts, and out of those we actually work with close to 6,000 different plant metabolites, the chemicals which are there inside those plants. And we could find that some of those plant extract has a good capability as an anti-cancer. But what we found something more fascinating, this is a plant which not many people knows it. It's called Kakla Singhi, which actually grows on up Himalayas, and it's a big tree, and where when an insect goes and start making a new home at that tree, the tree start to secrete some sort of a protective layer. It's sort of an immune response of the plant towards that invasion, and that makes it something called a gall, what you see on the screen. Those galls have been collected, and in Ayurveda they have been defined to have a very strong medicinal value. So we start working on those, and we found those galls have indeed some fantastic capability. So we screened in many cancer models, but we start doing the breast cancer one very recently. So today I'll show a little bit of data about how this extract from Pistacia integrima would be actually working on there too. So we generated an extract, and that formulation was generated, which comes as a brand name called Orogrit, which actually goes evaluated against lung cancer, colon cancer, and the breast cancer. So I'll just quickly show some information on the breast cancer. This I can quickly escape, this I can escape, and I just want to show this here. So this is an experiment which was done on the human breast cancer cells, which can grow in the laboratory. These are just a very early preclinical data. I do not want anyone to take a very strong ideas from here that this is the medicine. No, this is just the first spark that we are working on it, and we will develop it further too. But the exciting result was that MCF7, which is a human breast cancer cells, when we treat those cells and see how those cells grow, you can see the cell death, that if any compound has a capability to kill those cells, it might become a good anti-cancer compound. So we did that, and we found that Orogrit can actually kill those cells in 24 hours or 48 hours, and in 48 hours treatment can actually kill it slightly better, and within half maximal effect, I mean the effect where half of those cells are dead, comes around to 40 microgram per ml concentration. But we found even better, then we start working on human triple-negative breast cancer cells. So these were the tough cells to work with, and the biggest challenge to find something that might work against that. And what we found excitingly, that the plant extract from Kakrasinghi does it even better in these cells. So that was the first exciting data that we booked upon, that the triple-negative breast cancer cell can indeed be actually controlled by this plant extract. And excitingly, if you take the normal breast epithelial cells, which are non-cancer in nature, they also get affected, but their killing rate was too slow, not really too slow, like twofold slower. So at the dose where we see the effect on the triple-negative cancer cells, the same extract was not working as strongly onto normal cells. So we had some sort of safety window to play with. So we then moved ahead and tried to find out what might be happening. And I'm going to show some sort of those gray graphs for people in the audience who are not very familiar with the scientific background. It's for them, it's just to say that what are the pathways the cells are going through. So each cell, when it's born, is designed to die someday. And that death is called apoptosis, which is programmed cell death. So what we try to see, can we measure those parameters? And we found that when we give this plant extract, we are pushing those cancerous cells towards programmed cell death. They're going to go towards apoptosis. And this data shows the total amount of cell population, how they're shifting from a normal cell population to an apoptotic cell population. And we can then quantify the total amount of cells in early apoptosis or late apoptosis, and we can see that as we increase the concentration or the time, the cancer cells are getting pushed more towards early apoptosis and the late apoptosis. That would mean that those cells would eventually be actually weeded out. And when we do the same thing for triple negative, the data was further exciting. So our team is currently working on those cells, on those different kind of markers, and these extract to generate that data too. So in the triple negative, if you see, the cells actually go towards early apoptosis, late apoptosis, and some of them goes towards necrosis, which is again a pathway of the death. So what we can think, and we have been working on those, that the nature designed compounds which are there in our plants, they might become a very good handle to play with it. And not to mention the adverse effect from these extracts are actually really barely minimum. We have done the detailed tox studies and have found that the acceptability of this into animal models at least were actually very high too. So at this moment, we are working on those. We're trying to find out different parameters too. And I'm sorry I've taken much of the time, but I'll show just 2 more slides. It's about showing the colony forming potentials. So whenever the cancer cells grow, they make their own colonies. So we actually measure that if those potential can also be decreased. So on the screen, what you see, those blue dots, so each single blue dot is a single colony. So as we increase the concentration of this plant extract, the colonies are also getting decreased. That means the homing in capability of these cancer cells are also getting modified. In triple negative cancer cells, this response was actually even much stronger, what we saw in the earlier part of biology too. So taking together, the take-home message is that these preclinical studies suggest that Orogrit may be effective against the lung cancer, colorectal cancer, and in the breast cancer. We are conducting many more detailed experiments here and trying to find out what might be critical. We have now found that this plant extract has a very specific glucose analog called PGG, and that analog, when we purify, has a much stronger effect as well. So we have been working on those, and we're trying to find out what could be done the next. Our animal studies are right now ongoing, and we are also getting scheduled for conducting clinical studies with various patients. And one of the trials that would get shoot up very quickly is in Tata Memorial Center in Mumbai, where we are trying to help the patient and try to give this as an adjuvant therapy with the existing treatment that is happening. So thank you very much indeed, and my apologies for taking some bit longer time, but if there is something I can help.
Thanks.
Sure. I can.
So you saw the potential of plants. In fact, if you look back at medical history, many drugs we use today have come from plants. I'm quite certain many more will as well. But the point in the end, of course, is getting to the clinical trials. One thing I forgot to ask you, Geeta, is what is the current status of adoption and regulatory approvals for your work?
Yeah, thank you very much for asking that question, Anuragji. Basically, we have now scanned more than 1 lakh women in India. Of course, we are India regulatory cleared because it is a non-invasive test. And also we have done several prospective clinical studies, systematic studies by doctors, as I mentioned, where every person takes thermolytics and the same person takes mammography, ultrasound, and if positive, she goes for biopsy. The good news is our sensitivity in screening population has been 100% in all of these, which means that we have not missed any cancer that has been found by either a mammogram or ultrasound. And by far, maybe we are the only company which has done serious medical imaging and AI study from India, and we have both European approval as well as US FDA approval, clearance we call it, which means that it has now been not just used in 200 hospitals in India. Certain governments like Punjab government, Maharashtra, Karnataka, Andhra Pradesh is starting. So all of them have started screening thousands of population using our portable test. And we've also now expanded to Philippines, UAE, that is Dubai, Abu Dhabi, Turkey, Sweden. All of these have been possible with grilling reviews by doctors, oncologists, radiologists, doing short clinical studies and long clinical studies before even adoption. So we really hope it can change the way cancer is detected in India, because it can work on dense breast as well as fatty breast. And all we are trying to do is identify women who need to be brought to the hospital for early treatment. That is what we are attempting to do with this in a non-invasive, privacy-aware manner.
Thank you, great. Just one minor thing. That will be concordance, right? 100% concordance as opposed to 100% sensitivity.
No, it is it is sensitivity where every person goes. Sensitivity is true positive by.
So Geeta, here I know what I'm saying. Sensitivity for a medical doctor, denominator is all people who have disease.
Yes.
Here you're using another test results as your denominator. So the correct terminology from our point of view would be concordance.
No, sir, actually I can go into the debate of this. Okay. We are talking about true positives by it's true positives by true positives plus false negatives, which is 100%. That is, we have not missed any cancer. False negatives is 0. In the sense, that is sensitivity. So the concordance is when both the positive and negative. It is sensitivity. Yeah.
So using the formula.
Go through it. These are all published literature.
In fact, panel discussions are a wonderful time to discuss these things.
Exactly. So
the formula
specificity is when you have false
So the formula is that of sensitivity. Positive is from another test as opposed to the patient.
Yes.
Which is why it gets confusing for doctors, because when doctors hear sensitivity of 100%, they put patients in the denominator, not tests.
Right.
Because there is no gold standard at the level of screening.
I think you have a good point. So the gold standard I didn't explain.
So
the way it was done is gold standard, correct. In the Senate, gold standard is, in this particular case, mammography plus ultrasound, because mammography misses cancer intensity. So that is as close as it can get, actually.
Which itself has a sensitivity which is low. And so you start with a low sensitivity. So 100% of a low sensitivity is still not perfect. So
if you're saying there are people who are missing cancer by both mammography and ultrasound, I agree. Because that is the only thing the whole world is following as for screening, either mammography or ultrasound. And that's as good as it can get to.
Since Dr. Chintamani is here, I'll take your comment also on this. we are missing people with cancer despite mammography and ultrasound.
Absolutely, and we are picking up wrong ones too.
Yeah.
And therefore, there's nothing like one test for it. We triple test. The whole concept is basically, in spite of doing all the 3 tests, we are missing out. So there's no question of, with due respect.
Yeah.
I mean,
Sure, but we have to figure out where the
so
missing
in
out
most
case is.
most
Who is
scenarios,
detecting it, right?
okay.
Yeah, who is detecting the missed case? You know,
I think Dr.
MRI
Chintamani
is
probably would use the word concordance more.
I would use
You would use
concordance.
concordance.
Ask a question, please?
Absolutely, ma'am. Over to you.
I am Dr. Inderjit Sethi from Indian Cancer Society. One of my friends, she is wheelchair bound, and she could not be, she couldn't get her mammography done, but ultrasound was done. So there is a calcification, and she has been referred that she should get it. But with great, you know, she has just found one place in Delhi, Mahajan Imaging. SDA, they do it sitting on chair because she cannot stand. So what other options she has, because she has already got her ultrasound done. Madam, whatever you were saying, thermal imaging,
yeah,
is it applicable for her?
Yes,
and
yes,
where can she go to get it done?
Sure. So we have done many screening for wheelchair people in HCG Bangalore, for example. They come for this test itself. So because it is a non-touch, you know, you keep the device there and the person sits 3 feet from the device itself. So the screening is done without touching the person, and it's portable. As I said, it can also be done at home also. You know, whoever wants to do this test can come to our website and put their PIN code. We will tell. It's also available in Google, near my breast clinic near me, it is available. Here we have in Dr. Lal Path Labs, Apollo Clinics, and also Gurudwara Hospital in Gurgaon. And many camps have been done so far. But mostly because we are based in South, we have many more centers in South right now. Yeah, 200 hospitals are having. We can discuss.
So I thank you very much for that. But the doctor sitting here, can they guide me where else she could have got it? Because in SDA, she has found one person who can do her mammography, which she is getting tomorrow. What other centers are there available in Delhi or in the NCR? No, she was not advised to go in. Of course, one person said FNAC, but then it was advised that she should first get the mammography done.
See, actually, if I understand the problem, there was an ultrasound done,
yeah,
and mammography could not be done due to technical issues.
Yeah.
Ultrasound is not a hopeless investigation. The only problem is it is operator dependent, one. And you cannot swear by any of these tests. None of them is complete. And nowadays FNAC is not done. We do core needle biopsy for obvious reasons. The gold standard is core needle biopsy. Ultrasound guided core biopsy would give you the diagnosis. So where is the problem?
She was advised FNAC. Why one
No,
doctor?
not FNAC. FNAC is not done these days. I mean, I'm talking that there is already a finding, no? That's why I was
Yeah.
saying. So we don't do FNAC as a routine these days. Where FNAC can be done, you can do core biopsy, provided there is a lesion as. Yeah. This is picked up. No, there is a finding on ultrasound. That's what she's saying.
The finding is that it is benign, but they want to make sure.
No, that's what I'm saying. So you don't have to make it impossible. I mean, it shouldn't be so difficult that mammography has to be done somehow. That's not, I mean, in any case, none of them alone is a gold standard. We have to do the triple test. That's what I was mentioning. And triple test is classically good history examination followed by good imaging and core needle biopsy. Because FNAC can have false negatives and guided FNAC can still be all right. As a screening tool, we don't use FNA. We are doing screening imaging basically. So in your case, when you're mentioning there is calcification detected and they're finding, that guided core biopsy can be a diagnosis. In any case, that's very sensitive. There's no problem.
Thank you. Thank you so much, sir.
Rather than looking for a center where it can be somehow done, still it may not give you the information. It's desirable but not mandatory, right?
So this can be done anywhere in the Lal Path lab or for
No, I don't know about these labs. When this, I would not know where they do what. But by and large, it's available in most institutions.
Thank you, sir.
वो आप कहीं भी करा सकते हैं, ऐसा कुछ कोई खास लैब अलग से नहीं.
Okay, let's open it up to the room for any other questions as well. If there are no other questions, we can end the session or continue a bit longer? Okay. 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 All right. So we're expecting the minister shortly. No. And I don't sing and dance. So, but any case, I think we have raised a very important topic that is worth exploring further, based on the question that was just asked. And I honestly think this is a great point of confusion, isn't it? Once you have tissue, that is the definitive solution compared to everything else that we know today. So what are the reasons that almost all of us know that imaging, no matter how, will always leave some gaps? Because that is a question I think you were also talking about. What are those group of people in whom, despite imaging and everything coming, we get them wrong? What are those types of reasons? It's a good biological question, actually.
Absolutely, very good biological question. I mean, and it's good to drive home a point that nobody would treat a patient of cancer with imaging alone, except in very selected scenarios. In other cancers, breast cancer, you need a diagnosis. Now, and when it comes to getting a diagnosis, FNAC used to be done, fairly good, but again operator dependent, cytologist, and many limitations. There's no tissues, you can't get to know the details, etc. And false negatives, that's an issue. So core biopsy is no rocket science again, it can be done. But your question is different. I was once again trying to reinforce that point, I'm sorry about that. You were asking why imaging, we can't stop at imaging, why tissue?
Yes.
Well, traditionally, if you read the book Final Diagnosis, Pearson gives the final diagnosis, he's the pathologist.
Yes.
Imaging can be deceptive. I mean, it's again my answer, it may not be the only way to look at it. Imaging can still have some, we have false negatives and false positives, that's why you raise that point. But the minimum, the risk of missing it is with the tissue diagnosis. So, and then you come to another point. How about core biopsy, which again is a type of incisional biopsy, little amount of tissue. Excisional biopsy, then getting more out of it. It's like getting the whole mountain or that jari booty alone. So there's no end to it, but within acceptable limits, core biopsy will give you, that's the gold standard.
So maybe I'll add to this. It's a good question, and thanks for allowing for expansion. Because especially we have many people from non-medical background also. As Sir said, core biopsy is the best way to figure out whether it's really cancer or not. Now the question is, where do I poke into the body to find out which tissue to take? That is where the imaging comes into the picture. So you have a person, you do the imaging can be done by X-rays, ultrasound, MRI, thermal. So you can do the imaging and try to identify likely, suspicious, abnormal areas where you need to do further analysis. So that further analysis definitely has to be tissue test, but you can't do it.
I agree
so
completely.
That is where
I agree.
yes,
and
yes.
you raise this point.
Yes.
Nowadays, I mean, the standard of care is, I mean, I was not bringing that out. The recommendation today is no needle is put in without guidance.
Yes.
You need an ultrasound guidance to do, so it's called guided core biopsy.
Exactly.
So that you don't hit a dead spot.
Correct.
And you get the yield is, representative.
Yes, yes. So before the core biopsy, there is the imaging that is done, which in the radiology, which is either a mammogram or and ultrasound. Why and? Because mammogram does not pick up abnormalities in dense breast. So then ultrasound we go to, but ultrasound is excellent with target already identified. That means you know where to look more into, then we can identify if the tissue requires a biopsy and guided biopsy, as Sir said. Now, that is where if they do mammogram, they'll figure out if there's a microcalcification and then do an ultrasound at that location. Now, when there's a dense breast, then it becomes an issue. So that is where if you do, let's say, a thermal scan, you can identify the location where you need to do guided ultrasound guided biopsy rather, and that's where the screening comes into the picture. Unfortunately today, the only 3 modalities in imaging that is used in practice for breast is mammography, ultrasound and breast MRI. And breast MRI, many times it is contrast enhanced, so you need to put in radioisotopes in the body, etc. So it's not like a screening test as such, unless it's a very high risk person. And of course, there may be other radiologists in the group, they can talk about it. So that's why when I said, you're right in terms of it's not like a ground truth, but today in the world, if anything can catch cancer in a screening mode, it is either mammography or ultrasound, and in some cases breast MRI. So that's why we use that as the basis of golden truth, while you can debate, maybe there is some cancer missed by all the 3. It's likely, but it's more hypothetical, not really, applicable in practical scenarios.
Can I make a point, sir, here?
Yes, please. Who was that? Yes.
I think when we are finding a lump, and then that patient is being seen, then triple assessment is the gold standard, and we do all. When we find something on a screening, right, the ultrasound as well as mammogram, they grade that lesion. If it is completely benign looking, it is BIRAD 1 or either on ultrasound, and then at that stage you can stop. There is nothing to do more.
Exactly.
So those stages which are totally benign or very likely benign, they can wait. So if this particular patient who is a wheel-bound person who has been shown to have a finding on ultrasound which is likely benign, another option can be she can just wait and watch. Exactly. And if possible, another imaging can be done which is not as traumatic. If they both show it is completely benign, macrocalcification which are 99.9% benign, it can be left alone without any needling. Because these are invasive procedures, should only be done when you have a strong suspicion.
Exactly, because all the 3 of them do not show anything that is considered as negative. That's how the sensitivity equation comes in. But anyway, you can debate that offline.
The nice thing about using any 3 tests, it doesn't really matter which 3, and using a combined positive or any one of the 3 positive, if you use a combined positive, sensitivity falls, specificity rises. If you use any one positive, sensitivity rises, specificity falls.
Correct, absolutely.
And that's always mathematically true no matter which test you take into account. So disease positive always remains the elusive denominator that we seek as opposed to test positive or combination test positive. But I have another question for especially the 2 of you. Anurag, you're always free to chime in case that's an area of your interest. Why don't we imagine ultrasound as a direct screening tool for breast cancer? I mean, in common practice, because we still speak of other tests.
There are answers clearly known. One, it has the issue with who is doing it.
Okay.
It is operator dependent, which is a big issue. And I think when Navneet was mentioning that you can stop there, you really need the sonologist to swear by it. Okay, so there are situations where you have those popcorn calcifications or other things. You know the imaging you can stop, but most places you'll have to go to the next step. You understand. Ultrasound cannot be. It doesn't have the kind of sensitivity and specificity that you have with mammography. It is superior. MRI, she mentioned, MRI is very sensitive, but not specific at all. So it'll pick up, it'll light up everything. So you'll get into trouble. Too many false positives. So the middle path was mammography. Again, mammography has its limitations in dense breasts, younger women, etc. So I think there is no one answer for this. Most radiologists would like to use both. And in any case, now the recommendations are for axilla, you can't do clinical staging like we used to do, you have to do ultrasound. It's mandatory. And for the breast, mammography is what they do. Unless the results are equivocal or there is, MRI is a problem-solving tool. It steps in. And a lot of us call it the problem-causing tool because it picks up too many artifacts. And then your decision goes haywire. It's like the pet, you can't bet on pet. Everywhere it lights up. So therefore, there is a very important reason for not using it. It can't be used in all situations. And 2, it is operator dependent. I think that interpretation becomes a very important thing. We are not doing screening mammography anyway. This country is not for, we are detecting lumps. You're not treating images here, right? So in any case, it's not applicable. But ultrasound is a very useful extension of clinical examination. In fact, we call it the stethoscope of a oncologist. You can use it to look for anything in addition. That's it.
So here comes, Geeta, a question to you. As you just heard, operator dependence is one of the biggest problems we are talking about. And AI is always seen as a way to reduce operator dependence.
Exactly.
And robotics is seen as a way where some manual thing has to be done to remove that. Absolutely. If you were to imagine the future of ultrasound, where do you see a mixture of robotics and AI, well, both are combined actually, coming in for non-operator dependent assessments which can run across every spectrum of breasts? Do you see it happening?
Sure. So I'll answer the first part of the question that sir very nicely answered about the operator dependence, right? The skill needed to find an abnormality, especially when there is no localization, especially when there is no lump, using ultrasound is absolutely very, very diverse, and there are so many papers showing about this. The other disadvantage of ultrasound-based screening, or limitation, I would say, it's not really limitation of the test, but limitation of some of the rules in country. We have what is called as the PCPNDT law, which means that you cannot take out an ultrasound machine outside a hospital setting, outside a fully, clinical setting, because it can be misused for fetal sex determination, which is called PCPNDT law. Because of it, you cannot use ultrasound for community screening. So that becomes another limitation.
1 second here, just 1 second. In theory, an AI-based system never needs to display an image. So it would not be misusable.
It's not about, no, I will come to your answer of AI in this thing, but it's not about AI doing it, it's about who is doing it. And so that's a different law-related question, whether you can hide behind AI or not. But to your point about AI to have an objective assessment, absolutely. Objective assessment, reducing missed diagnosis and misdiagnosis. That is calling out somebody when there is no abnormality, calling them out as positive, that is false positives, or also the other way around, reducing false negatives and false positive. Adding as a tool to the radiologist is something that AI has done excellently, right? So I attend this RSNA, Radiological Society North America in Chicago every year for the last 6 years. And the one tagline that comes in is, they always say, will AI replace radiologists and so on. So for the only tagline was, radiologists using AI will replace radiologists without, because they're going to be more accurate, We're not saying AI will replace, because AI always requires a doctor to look at it. So coming to the ultrasound question, yes, it's not something like a future. There are already several machines available today where AI is integrated into a breast ultrasound machine. It's called automated breast ultrasound, ABUS. It's just that it is 3.5 to 4 crore rupees. Very few hospitals will be able to, afford it. And here also, it's more like a recording, because ultrasound, how it works, some of you may know, is that you have to move the probe on the breast. Where you move it on the breast determines whether you're going to catch it or not. How much you press and how much pressure you give, and where you press and how much pressure, that also determines. So there are several of this, which all of it cannot be automated, but that is the direction, ABUS, that is where we're going. So that's why when you use AI on thermal imaging, what happens is it is not operator dependent from a screening image capture perspective. So because of that, the image you get is relatively nice, and now you can do AI and tell which are the places where there is likely abnormality. Now, ultrasound can be done in a targeted manner at these places, so the probability of detecting the cancer is much, much higher.
Coming back to ABUS, because that's where I was kind of angling towards, cost always changes. The one thing that's a guaranteed constant is cost will come down. So would you say the right comparison for future is an ABUS? Dr. Chintamani, have you had experience in looking at ABUS results clinically? I mean, what do you think about an ABUS that automates everything, including finding the lesion?
I mean, it sounds very, very interesting and actually very exciting. And I'm sure the human error would be corrected. But I'm glad she mentioned, and let's think for the benefit of everyone, there's still a human being handling it. Like
Definitely.
when robots came, people were thinking that robotic surgery would mean the surgeon is gone. You need a surgeon to handle that robot. Robot is a slave. So as long as the man is the master,
Yes.
I think we'll get the answer, which is correct.
These are all assistive AI, ultimately the doctor. I know the tagline in RSNA because my wife is also a radiologist. I always point out that the person who uses these AI simply has to be a doctor, not a radiologist. So it is entirely possible that given AI tools, specialists taking care of that organ could easily displace radiologists of that specialty. It's not inconceivable, because what is required is for the AI to have a master. That master has to have experience and medical degree, and the person who controls the patients is the only one who can't be eliminated. And welcome to Dr. Jitendra Singh. And I think with that, we'll close this particular session.
Thank you very much. Welcome, sir.
Thank you, panelists. That was a very, very insightful session. Thank you for your time. We are so delighted to have the presence of guest of honor, Dr. Jitendra Singh, Honorable Minister of State, Independent Charge for Science and Technology, Government of India. I request Mr. R. Prasannan, Resident Editor, The Week, to give a welcome address, please.
Good afternoon. We now have the pleasure of having amidst us none less than the Honorable Minister of State, Independent Charge for Science and Technology, Government of India, Sri Jitendra Singh Ji. He has accepted our invitation for being the guest of honor today. He has a busy schedule with Parliament in session, that's from where he has just now come, and that is why he could not be here with us in the morning. All the same, we consider it a great honor that he should still make it. A warm welcome to you, sir. As you all know, the present government, led by our Honorable Prime Minister Sri Narendra Modi, has been pushing for early detection of breast cancer and free screenings for poor women under the Ayushman Bharat scheme. It's an important step in the fight against what Siddharth Mukherjee, the renowned oncologist, calls the emperor of maladies. The CSIR laboratories under the Ministry of Science and Technology, which Sir presides over, those labs are in the forefront of India's cancer research efforts. The Central Drug Research Institute in Lucknow is leading the way in the development of high-value generic drugs through non-infringing and cost-effective synthetic route, designing and synthesizing of new chemical entities and against clinically validated cancer drug targets, preclinical evaluation of potent anti-cancer entities, and several other activities. I don't want to stand between the Honorable Minister and you, who are waiting to hear about the efforts being made by his ministry in his own words. So let me conclude by saying a hearty welcome to you, sir. Sir.
Sir, I'll give your introduction a bit and then you can... Sure. Thank you so much. Dr. Jitendra Singh has taken over as the Minister of State, Independent Charge for Science and Technology, as the ministries were included on the charge of office of the Prime Minister. He is Minister of State for Prime Minister's Office, Personnel, Public Grievances and Pensions, Department of Atomic Energy and Department of Space. He is a Bharatiya Janata Party National Executive Member and was the Chief Spokesperson for the state of Jammu and Kashmir. He won the Udhampur seat in Indian General Election 2014 for the 16th Lok Sabha. He's a physician known for his work on diabetes, and he has been a professor, a consultant, clinical practitioner, author of 8 books, and a newspaper columnist, and also the ex-chairman for the National Scientific Committee Diabetes and the Research Society. With an MBBS degree from Stanley Medical College, Chennai, and MD from Government Medical College, Jammu, Dr. Singh has authored several books including monograms on diabetes and World Book Fair bestseller, Diabetes Made Easy. He's also the author of chapters on diabetes in textbooks for postgraduate course and runs a syndicated weekly column, Tales of Travesty, popularly read and regularly published for 3 decades. Sir, now can we have a few words?
Thank you for your kind introduction. Resident Editor Mr. Prasanna and the entire fraternity in the family from the Week and Malayalam Manorama. First of all, I have to compliment you for having organized an event like this and thinking something outside the domain of politics. Because mostly the news periodicals and news journals derive pleasure in organizing events dedicated to what is more, if not popular, at least populist, and then enjoy discussing who has abused whom and what was the retaliation. So I'm glad that you have at least taken upon yourself a foundational cause. And I think this is very much in keeping with the legacy and the tradition of Malayalam Manorama and the Week magazine, because you've been, as we were discussing on our way to this room, been coming out with supplements and exclusive issues dedicated to health. And I'm sure in that vein you've taken upon this also. Now, going by the introduction that was very kindly made by a very kind lady, I don't know whether I'm expected to talk as a medical professional or as a political person or as a minister or as nothing. But I think as we have learned to talk about the subject per se without beating about the bush, I think the first, when we discuss a subject like cancer, and that too a cancer which afflicts women primarily, and that too at a relatively younger age, and then we also talk in the context of India, first of all we have to ask ourselves why we are doing so. Why would not we be talking about some other subject? And would we also be talking about the same subject maybe 20 years earlier or 30 years earlier? Because it's not just because it sounds fancy, breast cancer in women. It makes a good banner, so we are indulging into this. I think first of all we have to understand that it is actually no disease per se is every disorder is too serious to be left to a doctor. So if you understand that, there's a huge socio and civilizational context to the prevalence of disease, to the spectrum of disease. We have seen times in this country, at the time of independence and also a few decades after that, in the immediate post-independence era, when we hardly talked about this. We had a program like this or a seminar like this in a room like this, in the same place, we would be talking about tuberculosis, we would be talking about cholera, we were talking about cholera, Kala Azar, because we were still struggling with infectious diseases. And like most other Indians, even women would not live long enough to develop a breast cancer. They would succumb to maybe antenatal events. And in case of women, most of the mortality happened, I mean, even a safe delivery was a great blessing, and you would distribute sweets. Not that she had delivered a boy or a girl, more so because she had survived. So gradually, then maybe after 80s, we got out of that phase of communicable diseases and also antenatal and maybe infant disorders, or afflictions which were major cause of mortality. And then finally graduated into these diseases, which are now also known as, I mean, in those days at least, it was fancifully described that India has entered into the diseases of the civilized, because they were known to be the disease of the West, and we were always known to be dabbling with the diseases which were related to poor hygiene, poor nutrition, everything related to poverty. So now we have heart attacks, we have diabetes, we have cancers, also because we have started living long enough to get all these diseases. Like a Nobel Prize, to win a Nobel Prize, first you have to be working consistently and then you have to live long enough, because you don't get it posthumously. So by the time you get it in your 7th or 8th decade, you have to be around, to pick it up. So similarly, at the time of independence, most of the mortality happened, the lifespan of an average Indian was hardly 50 or 55. The other day at a gathering of pensioners, I was saying, because they came out with a lot of grievances related to them. I said, first of all, you must thank God that you have had a good farewell at the time of superannuation. Because we have seen those times when God would not let you wait for a superannuation day. So from 55, now we are almost nearing 70. We were hardly 50 years, the average lifespan of an Indian around the time of independence, and now moving towards 70 and all that. So, and at the same time, with the advent of newer antimicrobials, antibacterials, antibiotics, we have largely got over the communicable diseases, infectious diseases, except for this mishap that we had in the form of pandemic, which took us back to those times. So now these, and many of the malignancies, of course, breast cancer is relatively at a younger age, but many other malignancies which were not happening because, and not known because people didn't live long enough, like for example, prostate cancer in males, etc. So these are now the challenges. And when we talk of India, in the context of India, and also the present government as she referred, and with Prime Minister Modi's focus on health, also on women welfare, and also on youth. So I think all the three things get addressed when we talk about a subject like breast cancer. So I hope I have tried to vindicate what I said in the beginning of, so first of all, why are we talking about breast cancer? Because when we talk about breast cancer, we are simultaneously talking about the well-being of a woman, we are talking of the well-being of, or conservation or preservation of the youth energy, because that would be the phase of it. And at the same time, we are also addressing a foundational health-related issue. And as we know, the overall mortality, because this is also considered one of the preventable or curable, if not preventable, maybe curable malignancies, but even then we have about 35–37% of mortality in this country, which is lesser than the global mortality of about 30%. And he was referring to the research being done. I think the research is not in isolation, because when you are addressing or looking at a problem like malignancy or breast cancer, it has to be a multifactorial, because the outcome or the genesis is also multifactorial. No doubt, of course, he referred to my portfolio, so I can take pride in saying that our lab in Lucknow, which is the Central Drug Research Institute, is deeply involved in conducting research on some of these drugs which could be effective. So also many other laboratories. We have a IIIM, the Indian Institute of Integrated Medicine in Jammu, which is dedicated more to the herbal medicines and also said to be working on some of the antioxidants and other compounds which could have a preventive role in the genesis of. But that apart, I think that we have to have a wider integration of approach, which mercifully and ironically COVID taught us. Because when you are faced with the threat of death, you learn to learn what you didn't want to learn. And many in my own fraternity did not think much about the indigenous methods of medicine. And even, we looked at some of these in the Oriental methods with a certain degree of contempt or cynicism. But you saw during pandemic some of the best of the physicians from Europe and America calling up their counterparts over here and asking them, is there a booster in homeopathy? This is so desperate. But that taught us the virtues of holistic approach. So that is A. So we have to have an integration of all the systems of medicine available, ranging from Indian to Chinese to allopathy to Ayurvedic, and also yoga. Because now the focus is going to be on the prevention part of it. And incidentally, this is one of the problems, this is one of the issues which is amenable to early detection, if not fully prevention. And that is something which is, I think, the mandate which the organizers also must be holding in mind to carry out these camps, and also self-inspection and all those things which you tend to teach the young females. So one is the holistic approach. The second is a wider extended approach, which also would involve the society. Also involve some of the cultural customs. Often there is, in a country like India, I think another attribute to the COVID and the pandemic, and also to Prime Minister Modi, is that he awakened us to the virtues of preventive health care. And there is also a legacy to that, because in a country like India, where you can hardly afford even treatment for a disease that you are already known to be having, it's difficult to enjoy the luxury of going for preventive health care or preventive checkups. Like the area that I am dealing with, as you was mentioning, diabetes, we usually expect the patient to have protracted medication or even lifelong. And I would see many of my patients would skip medicine for 2 days in a week. Some of them would make a calendar of scheme into 5 days in a month. And I would find one of my junior residents scolding him, कि अगर दवाई नहीं खानी थी तो आए क्यों, मेरा टाइम क्यों वेस्ट किया? Then I would quietly call them and I tell them, look here, a person who doesn't have anything else has tremendous amount of self-respect. So he doesn't want to disclose to you, but that must be the problem. So in a country where you have to skip a meal to have a drug, it was never a part of our culture. Many of us fell sick. If we got well, it was mother's blessing. If we didn't get well, it was Pishle Janam ka karam. And we happily reconciled to it. So gradually now that the socio-economic levels have also risen, and this COVID has also awakened us to the virtue, because can you imagine a country where we hardly thought about prevention? We are the first to have produced a COVID vaccine, the DN vaccine, and gifted it to the rest of the world. So that's something miraculous happening. So suddenly, because we inherently had that resilience within, but we didn't have the resources to express it, or the luxury to express it outside. But now gradually, as we move on to be a part of the global world and also look forward to playing a global role in more ways than one, as you've already seen happening in the sector of space, and also to a great extent in the sector of health, because as I said, you are the first one to have covered with the COVID vaccine, and so many other vaccines also now. You also have a nasal vaccine for COVID. So we would have to live up to those benchmarks, which are global. Secondly, when we talk of 2047 century India, and when we talk of India having more than 70% population below the age of 40, I think the other challenge would be how to optimally channelize the energies of our youth, or the 70% population, both male and female, because if you have to reach that pedestal, it has to be contributed to each and every citizen. So how far or how affordable it would be to allow the youth energy of these women, in this case, and youth in general, to get squandered at the altar of some of these disorders, which could have been prevented, or if not prevented, which could have been checked or cured at the early stage, but which were not done so, and they went on to debilitate the individual. So this is not only a loss of the individual per se, this is a national loss in that sense. So that is one aspect that we have to, because when we are visualizing India in that position, we have to take it also that way. Secondly, when we talk of India being a country of 70% below 40, let's not forget that even the percentage may be below 70, but the overall number of plus 60 is also on the increase. So it's rather I would say it is a biphasic life cycle, lifespan. It's not that 70% are below the age of 40 and the elders have agreed to quit the planet. We are still there. Though all kinds of colors are available in the market now, so you can choose to look grey, white, black, anything. So now that is another challenge. When we look forward to the growth of India, consistent growth, how best do we channelize these two segments of population? So in case of breast cancer, for example, you are actually somewhere connecting with both. If you prevent it, because it's something which is more often said to be happening relatively at a relatively younger age, you could conserve the youth. And if you are conserving the youth, and I have seen most of the women who get an early detection of a disorder like a breast cancer and get cured for it, they otherwise become conscious of their health and tend to lead a more energetic elderly life. So you are actually addressing both the graphs of this biphasic life cycle which is being witnessed in India today. And I think we would like to have more of an interaction rather than one-way monologue. But the prevention is now going to be the core of it. And for that, whatever means, of course, by publications, by infographics, I think the best medium would be the medium which is understood by the population today, whether it's the social media, whether the infographics, whether the jingles, and also getting out of some of the social taboos of not disclosing a disease you have or being embarrassed about it, and also about the virtues of, yourself, examining yourself every day. So these are some of the issues which, as I said, we have, it's a multifactorial subject, not necessarily related to a medical professional alone. And that's why we need to have a joint and a very integrated and a holistic approach from the part of the society itself, also from the part of families, and in case of breast cancer, also supportive. Times it is a relative blessing to have it and get away with it, and then march ahead with a healthier attitude towards life and a healthier way of life. So having said that, I think I'll stop there, and if there is anything we can talk about, we would do that. Thank you.
So would you like to take one or two questions? So from the audience, please, Eddie. Yes, please. Give the mic, please.
Good afternoon, sir. It's a very, very big privilege to have your support for such an important topic. I'm Geeta, Dr. Geeta from Niramai Health Analytics, where we have developed a new method of detecting breast cancer in affordable and accessible manner. My question is, and congratulations, first of all, you're a role model of what can be done for Indian population if a whole India level initiative can be taken, like Polio Hatao. I mean, it was an amazing initiative that you started, sir. So similarly, why can't we breast cancer deaths Hatao kind of a thing, where we enable early detection and early diagnosis? You have 100,000 or more number of health and wellness centers that you have started. Please start breast screening and tests in these places so that we can, make it more accessible and affordable, sir. And your comments on that.
No, thank you. I don't think there can be any second opinion about what you said. One constraint earlier was the financial constraint, which I was also referring in my talk. I think that has been to a great extent taken care of by this Ayushman Bharat. And I think the most beautiful, fascinating part of it, which is not often discussed, is, which I could say is one of the unique features anywhere in the world in a health insurance scheme, is that you could get yourself insured even for a pre-existing disease. So even if you happen to have got detected as a breast cancer patient, you can go tomorrow and get, which no other insurance company was doing earlier. I mean, even if you were insured, you had a sudden cardiac event or a myocardial infarction, next day you went and they were advised a stent or a bypass, you would go to the insurance company, they would try to find some reason to convince you that you had camouflaged the disease you already had, and they would avoid giving. But here it's nothing like that. So that is one, I think one of the greatest achievements or hallmarks of the Modi government as far as addressing the health issues. The second part, you rightly mentioned, wellness center, of course. But as I said, it has to be a culture and social movement. So unless it is that, the stakeholder individuals have to be made amenable to that. I have a wellness center, if I don't go to get my breast checked, or if I don't even, inspect it myself, whom am I going to get dictated from? So I think a lot of awareness is required, and getting over the taboos is very important.
Sir, with due respect, मेरा एक क्वेश्चन है, जैसे हम सब जानते हैं कि इंडिया में कैंसर बहुत तेज़ी से फैल रहा है, और इसके फैलने से हमारे पास जो डिजीज़ है ये कैंसर वाली, तो हमें सोल्यूशन इसका ज़्यादा मिल नहीं रहा है, और डेथ्स के मामले में अदर कंट्रीज से कंपैरिजन में हमारे यहाँ डेथ्स ज़्यादा है. तो हमें इसके ऊपर हम क्या काम कर रही है गवर्नमेंट, तो मैं थोड़ा सा ये जानना चाहता हूँ, और कैंसर के ऊपर क्या क्या हम स्टेप्स ले रहे हैं, थोड़ा सा आप अगर ये बता दें गवर्नमेंट क्या कर रही है तो बेटर रहेगा सर.
क्या कर रहे हैं वो तो अभी इन्होंने बताया, वो तो हो ही रहा है. I mean, our research levels are world class now. We are not behind, and that's not pertaining only to health. It's in every sector now. I think that is something that we should say with confidence. As far as science, technology, innovation, and our research is concerned, we are at the same level. And it's not difficult to also give evidence of that. For example, earlier on, what happened, there was a technology available in the West or in the USA. It would become popular there, it would become applicable, it would become a household amenity there, and then we would adopt it. Like, for example, I was in the US that day and I was telling them, we got to know of television through a 1-hour Chitrahar program sometime in 1970. Whereas in US you had television in 1950s. The famous 1960 election where Kennedy defeated Nixon was decided by a TV debate. And here we would get confused, what is this TV debate all about? So now it's not so. Quantum technology is something which only 4 or 5 countries in the world are dealing with. We are also at the same level. Same also in the oncology treatment. We have all the latest state-of-art regimens available in India. So you don't have to go to Houston for a bypass. And it would be a big event. Because आप बड़े लोग Houston जाते हैं हार्ट का बाईपास कराने. यहाँ तो आप हॉस्पिटल में एंटर करिए, बाहर आने तक बाईपास हो जाता है, चाहे जरूरत हो भी कि ना हो. I was telling my friend Naresh Tarehan the other day. So we are now, that much accomplished. We are doing it left and right. So that is one part of it. दूसरा ये है कि जो आपने कहा ना कि यहाँ डेथ क्यों ज़्यादा होती है, वो आपका कहना ठीक है. उसका एक, जैसे मैंने कहा, इसका एक सामाजिक और सांस्कृतिक संदर्भ है. क्योंकि बहुत से ऐसे देश हैं जहाँ पर ये एक परंपरा है रेगुलर प्रिवेंटिव फॉलोअप की हर 6 महीने के बाद, और वो हेल्थ भी चूँकि शुरू से इंश्योर्ड है, तो अर्ली डिटेक्शन, अर्ली ट्रीटमेंट एक प्राकृतिक प्रक्रिया के तहत हो जाती है. यहाँ ऐसा नहीं होता. बहुत सारे कैंसर्स का पता चलता ही नहीं है, क्यों मोस्टली दे आर पेनलेस. कई बार पता चलता है तो हम उसकी हमारा उस तरह का वातावरण भी नहीं है सामाजिक, और उस तरह का कई बार हमारे पास सामर्थ्य और साधन भी नहीं रहते और इसलिए देरी हो जाती है. Otherwise, if you see, you should not have 37% mortality in something like breast cancer. तो ये एक कारण है. लेकिन धीरे धीरे जैसे मैंने कहा ये आयुष्मान भारत जैसे प्रावधान आए हैं तो ये हम उसी तरफ उसी दिशा में बढ़ रहे हैं, क्योंकि अब अगर हमें भौगोलिक परिप्रेक्ष्य में अपनी भूमिका निर्धारित करनी है तो धीरे धीरे हम पहले से बहुत अंतर आया. और दूसरा, ultimately I keep telling everybody, you can have artificial intelligence, you can have all the modern modalities, but you have no replacement for integrity. अगर आप कोई आटे में रेत मिलाएंगे और वो खिलाएंगे तो अब वो उससे कुछ ना कुछ तो खराबी होगी, कैंसर नहीं होगा तो पेट खराब हो जाएगा. अब ये which certain nations have got over, वो हमें उसकी एस्टीम बननी है कि आपके हवा में भी पोल्यूशन है, पानी में भी कुछ है. The other day, many years back, I think about 20 years back, we had a small meeting like this when I was at AIIMS, and Mr. Khushwant Singh was there for the public session. So he was to conclude, and at the end he said, this is related to cancer actually. So he said, what all I have heard from all the experts, my one-line conclusion is to avoid cancer, you have to stop eating, stop drinking, and stop breathing. Because everywhere you have a carcinogen. So that's why I said there's a whole lot of socio and civilizational contribution to these genesis. It's a multifactorial thing. तो जब हमारे समाज में भी हमारे सोच में मानसिकता में परिवर्तन आएगा कि मैं जो स्वयं अपने लिए स्वच्छ सेवन की अपेक्षा रखता हूँ वही मैं दूसरे के लिए भी रखूँ, तो उस तरह की जब हमारे अंदर मर्यादा आ जाएगी तो बहुत सारी चीज़ों का उससे भी फर्क पड़ता है.
Thank you, sir.
We thank you, sir.
Can I have this one quick?
Okay, one last question.
Sir,
and
this is
then
Anurag
we can-
Shrivastava,
yes.
retired as head of surgery from AIIMS, New Delhi. Thank you, sir, for emphasizing the role of prevention and screening for early disease. Sir, Shri Nadda Sahab, the Honorable Health Minister, on 16th May 2017 launched the National Screening Program for non-communicable diseases, and he chose diabetes, hypertension, and 3 cancers, cancer of the mouth, breast, and cervix. I was part of that team where we developed the modules for screening and early detection. Sir, it's about 6-7 years since then. So we need more wider coverage for the rest of the society, the entire nation, so that we can detect these diseases. They are preventable just by lifestyle modification and early detection. We can do a lot and serve our society well. Thank you, sir.
No, I think absolutely I agree with you, and that's precisely you have added to what I was saying. You can't leave it to a medical professional alone. You have to have a huge social involvement, huge involvement of the NGOs. Because if you leave to medical professional alone, then it could be sometimes risky also. Because if you follow what doctors eat and drink, then sometimes it may not be always healthy. So I agree with you. It has to be a larger awakening. Because if you see the banquets that happen at the end of our conferences, I don't want to add to that.
Thank you. We thank you, our Honorable Minister. Thank you so much for taking our time and giving us valuable inputs. May I request Ms. Soni Mishra, Senior Political Correspondent, The Week, to please come and hand over the memento to our Honorable Minister as a gesture of appreciation. Thank you so much, sir.
So, that's a special gift from Kerala. It's a mirror, but actually not a mirror. It's actually polished metal. It's a traditional art form of Kerala, and so we are just. Thank you, sir.
Thank you so much, sir. Thank you for your valuable time. We can all proceed for lunch and be back in 40 minutes. Thank you, everyone. Enjoy your lunch.
और अब तो है LIC का यूलिप प्लान निवेश प्लस। एक बार इन्वेस्ट करो, इंश्योरेंस से सुरक्षा का लाभ और मार्केट की बढ़त का फायदा दोनों पाओ।
One sec, Rahul.
Madam, you're double cool.
Life is about to change, है? No more 8 घंटे की नींद, no more late night movies, no more parties with friends.
बिल्कुल सही कहा तुमने। इसके फ्यूचर के लिए अब no more holidays, no more shopping और no more फिजूल का खर्च।
लेकिन अगर इसका फ्यूचर ऑलरेडी सिक्योर्ड हो तो?
Really?
डैडी बने हो, देवदास नहीं। जीना छोड़ दूंगा, हॉलीडेज छोड़ दूंगा।
स्मार्ट लोगों की क्लियर है प्रायोरिटी, बाकी सब बाद में। क्यूट वाले मेहमान से पहले LIC।
पता है, I was a bright student. कुछ करना चाहती थी, कुछ बनना चाहती थी। आप अपना खुद का स्टार्ट कीजिए ना, खुद का बिजनेस। और इसमें पैसे तो बहुत लगेंगे ना। जीरो इन्वेस्टमेंट। जीरो इन्वेस्टमेंट? हाँ, I'm doing it. मैं एक प्रिंसिपल मैडम। She's my client. मैं LIC एजेंट हूँ।
LIC एजेंट बनो, अब बड़ा सोचो। हमारी वेबसाइट पर जाएं या अपनी नजदीकी LIC शाखा से संपर्क करें।
मुझे जॉब छोड़ा फिर भी सो कूल।
Bro, नए challenges, नए मौके लाते हैं।
अच्छा?
Seriously, राहुल, मेरा पूरा घर now it's an online retail store. देख।
वाओ, लेकिन पैसे?
कुछ साल पहले दिवाली बोनस को इन्वेस्ट किया था।
और अब तो है LIC का यूलिप प्लान निवेश प्लस। एक बार इन्वेस्ट करो, इंश्योरेंस से सुरक्षा का लाभ और मार्केट की बढ़त का फायदा दोनों पाओ।
One sec, Rahul.
मैडम, you're double cool.
Life is about to change, है? No more 8 घंटे की नींद, no more late night movies, no more parties with friends.
बिल्कुल सही कहा तुमने। इसके फ्यूचर के लिए अब no more holidays, no more shopping और no more फिजूल का खर्च।
लेकिन अगर इसका फ्यूचर ऑलरेडी सिक्योर्ड हो तो?
Really?
डैडी बने हो, देवदास नहीं। जीना छोड़ दूंगा, हॉलीडेज छोड़ दूंगा।
स्मार्ट लोगों की क्लियर है प्रायोरिटी, बाकी सब बाद में। क्यूट वाले मेहमान से पहले LIC।
पता है, I was a bright student. कुछ करना चाहती थी, कुछ बनना चाहती थी। आप अपना खुद का स्टार्ट कीजिए ना, खुद का बिजनेस। और इसमें पैसे तो बहुत लगेंगे ना। जीरो इन्वेस्टमेंट। जीरो इन्वेस्टमेंट? हाँ, I'm doing it. मैं एक प्रिंसिपल मैडम। She's my client. मैं LIC एजेंट हूँ।
LIC एजेंट बनो, अब बड़ा सोचो। हमारी वेबसाइट पर जाएं या अपनी नजदीकी LIC शाखा से संपर्क करें।
मुझे जॉब छोड़ा फिर भी सो कूल।
Bro, नए challenges, नए मौके लाते हैं।
अच्छा?
Seriously, राहुल, मेरा पूरा घर now it's an online retail store. देख।
वाओ, लेकिन पैसे?
कुछ साल पहले दिवाली बोनस को इन्वेस्ट किया था।
और अब तो है LIC का यूलिप प्लान निवेश प्लस। एक बार इन्वेस्ट करो, इंश्योरेंस से सुरक्षा का लाभ और मार्केट की बढ़त का फायदा दोनों पाओ।
One sec, Rahul.
मैडम, you're double cool.
Life is about to change, है? No more 8 घंटे की नींद, no more late night movies, no more parties with friends.
बिल्कुल सही कहा तुमने। इसके फ्यूचर के लिए अब no more holidays, no more shopping और no more फिजूल का खर्च।
लेकिन अगर इसका फ्यूचर ऑलरेडी सिक्योर्ड हो तो?
Really?
डैडी बने हो, देवदास नहीं। जीना छोड़ दूंगा, हॉलीडेज छोड़ दूंगा।
स्मार्ट लोगों की क्लियर है प्रायोरिटी, बाकी सब बाद में। क्यूट वाले मेहमान से पहले LIC।
पता है, I was a bright student. कुछ करना चाहती थी, कुछ बनना चाहती थी। आप अपना खुद का स्टार्ट कीजिए ना, खुद का बिजनेस। और इसमें पैसे तो बहुत लगेंगे ना। जीरो इन्वेस्टमेंट। जीरो इन्वेस्टमेंट? हाँ, आई एम डूइंग इट। मैं एक प्रिंसिपल मैडम, शी इज माई क्लाइंट। मैं LIC एजेंट हूँ। LIC एजेंट बनो, अब बड़ा सोचो। हमारी वेबसाइट पर जाएं या अपनी नजदीकी LIC शाखा से संपर्क करें।
मुझे जॉब छोड़ा फिर भी सो कूल।
प्रो, नए चैलेंजेस नए मौके लाते हैं।
अच्छा,
सीरियसली राहुल, मेरा पूरा घर नाउ इट्स एन ऑनलाइन रिटेल स्टोर। देख,
वाओ, लेकिन पैसे?
कुछ साल पहले दिवाली बोनस को इन्वेस्ट किया था।
और अब तो है LIC का यूलिप प्लान निवेश प्लस। एक बार इन्वेस्ट करो, इंश्योरेंस से सुरक्षा का लाभ और मार्केट की बढ़त का फायदा दोनों पाओ।
वन सेक राहुल।
मैडम, यू आर डबल कूल।
लाइफ इज अबाउट टू चेंज है। नो मोर 8 घंटे की नींद, नो मोर लेट नाइट मूवीज, नो मोर पार्टीज विद फ्रेंड्स।
बिल्कुल सही कहा तुमने। इसके फ्यूचर के लिए अब नो मोर हॉलीडेज, नो मोर शॉपिंग और नो मोर फिजूल का खर्च।
लेकिन अगर इसका फ्यूचर ऑलरेडी सिक्योर्ड हो तो?
रियली?
डैडी बने, देवदास नहीं। जीना छोड़ दूंगा, हॉलीडेज छोड़ दूंगा।
स्मार्ट लोगों की क्लियर है प्रायोरिटी, बाकी सब बाद में। क्यूट वाले मेहमान से पहले LIC।
पता है, आई वॉज अ ब्राइट स्टूडेंट। कुछ करना चाहती थी, कुछ बनना चाहती थी। आप अपना खुद का स्टार्ट कीजिए ना, खुद का बिजनेस। और उसमें पैसे तो बहुत लगेंगे ना। जीरो इन्वेस्टमेंट। जीरो इन्वेस्टमेंट? हाँ, आई एम डूइंग इट। मैं एक प्रिंसिपल मैडम, शी इज माई क्लाइंट। मैं LIC एजेंट हूँ। LIC एजेंट बनो, अब बड़ा सोचो। हमारी वेबसाइट पर जाएं या अपनी नजदीकी LIC शाखा से संपर्क करें।
मुझे जॉब छोड़ा फिर भी सो कूल।
प्रो, नए चैलेंजेस नए मौके लाते हैं।
अच्छा,
सीरियसली राहुल, मेरा पूरा घर नाउ इट्स एन ऑनलाइन रिटेल स्टोर। देख,
वाओ, लेकिन पैसे?
कुछ साल पहले दिवाली बोनस को इन्वेस्ट किया था।
और अब तो है LIC का यूलिप प्लान निवेश प्लस। एक बार इन्वेस्ट करो, इंश्योरेंस से सुरक्षा का लाभ और मार्केट की बढ़त का फायदा दोनों पाओ।
वन सेक राहुल।
मैडम, यू आर डबल कूल।
लाइफ इज अबाउट टू चेंज है। नो मोर 8 घंटे की नींद, नो मोर लेट नाइट मूवीज, नो मोर पार्टीज विद फ्रेंड्स।
बिल्कुल सही कहा तुमने। इसके फ्यूचर के लिए अब नो मोर हॉलीडेज, नो मोर शॉपिंग और नो मोर फिजूल का खर्च।
लेकिन अगर इसका फ्यूचर ऑलरेडी सिक्योर्ड हो तो?
रियली?
डैडी बने, देवदास नहीं। जीना छोड़ दूंगा, हॉलीडेज छोड़ दूंगा।
स्मार्ट लोगों की क्लियर है प्रायोरिटी, बाकी सब बाद में। क्यूट वाले मेहमान से पहले LIC।
पता है, आई वॉज अ ब्राइट स्टूडेंट। कुछ करना चाहती थी, कुछ बनना चाहती थी। आप अपना खुद का स्टार्ट कीजिए ना, खुद का बिजनेस। और उसमें पैसे तो बहुत लगेंगे ना। जीरो इन्वेस्टमेंट। जीरो इन्वेस्टमेंट? हाँ, आई एम डूइंग इट। मैं एक प्रिंसिपल मैडम, शी इज माई क्लाइंट। मैं LIC एजेंट हूँ। LIC एजेंट बनो, अब बड़ा सोचो। हमारी वेबसाइट पर जाएं या अपनी नजदीकी LIC शाखा से संपर्क करें।
मुझे जॉब छोड़ा फिर भी सो कूल।
प्रो, नए चैलेंजेस नए मौके लाते हैं।
अच्छा,
सीरियसली राहुल, मेरा पूरा घर नाउ इट्स एन ऑनलाइन रिटेल स्टोर। देख,
वाओ, लेकिन पैसे?
कुछ साल पहले दिवाली बोनस को इन्वेस्ट किया था।
और अब तो है LIC का यूलिप प्लान निवेश प्लस। एक बार इन्वेस्ट करो, इंश्योरेंस से सुरक्षा का लाभ और मार्केट की बढ़त का फायदा दोनों पाओ।
वन सेक राहुल।
मैडम, यू आर डबल कूल।
लाइफ इज अबाउट टू चेंज है। नो मोर 8 घंटे की नींद, नो मोर लेट नाइट मूवीज, नो मोर पार्टीज विद फ्रेंड्स।
बिल्कुल सही कहा तुमने। इसके फ्यूचर के लिए अब नो मोर हॉलीडेज, नो मोर शॉपिंग और नो मोर फिजूल का खर्च।
लेकिन अगर इसका फ्यूचर ऑलरेडी सिक्योर्ड हो तो?
रियली?
डैडी बने, देवदास नहीं। जीना छोड़ दूंगा, हॉलीडेज छोड़ दूंगा।
स्मार्ट लोगों की क्लियर है प्रायोरिटी, बाकी सब बाद में। क्यूट वाले मेहमान से पहले LIC।
पता है, आई वॉज अ ब्राइट स्टूडेंट। कुछ करना चाहती थी, कुछ बनना चाहती थी। आप अपना खुद का स्टार्ट कीजिए ना, खुद का बिजनेस। और उसमें पैसे तो बहुत लगेंगे ना। जीरो इन्वेस्टमेंट। जीरो इन्वेस्टमेंट? हाँ, आई एम डूइंग इट। मैं एक प्रिंसिपल मैडम, शी इज माई क्लाइंट। मैं LIC एजेंट हूँ। LIC एजेंट बनो, अब बड़ा सोचो। हमारी वेबसाइट पर जाएं या अपनी नजदीकी LIC शाखा से संपर्क करें।
मुझे जॉब छोड़ा फिर भी सो कूल।
प्रो, नए चैलेंजेस नए मौके लाते हैं।
अच्छा,
सीरियसली राहुल, मेरा पूरा घर नाउ इट्स एन ऑनलाइन रिटेल स्टोर। देख,
वाओ, लेकिन पैसे?
कुछ साल पहले दिवाली बोनस को इन्वेस्ट किया था।
और अब तो है LIC का यूलिप प्लान निवेश प्लस। एक बार इन्वेस्ट करो, इंश्योरेंस से सुरक्षा का लाभ और मार्केट की बढ़त का फायदा दोनों पाओ।
वन सेक राहुल।
मैडम, यू आर डबल कूल।
Life is about to change, है? No more 8 घंटे की नींद, no more late night movies, no more parties with friends.
बिल्कुल सही कहा तुमने। इसके फ्यूचर के लिए अब नो मोर हॉलीडेज, नो मोर शॉपिंग और नो मोर फिजूल का खर्च।
लेकिन अगर इसका फ्यूचर ऑलरेडी सिक्योर्ड हो तो?
रियली?
डैडी बने हो, देवदास नहीं। जीना छोड़ दूंगा, हॉलीडेज छोड़ दूंगा।
स्मार्ट लोगों की क्लियर है प्रायोरिटी, बाकी सब बाद में। क्यूट वाले मेहमान से पहले LIC।
पता है, I was a bright student. कुछ करना चाहती थी, कुछ बनना चाहती थी।
आप अपना खुद का स्टार्ट कीजिए ना, खुद का बिजनेस। पर उसमें पैसे तो बहुत लगेंगे ना।
जीरो इन्वेस्टमेंट।
जीरो इन्वेस्टमेंट?
हाँ, I'm doing it.
मैं एक प्रिंसिपल मैडम।
She's my client. मैं LIC एजेंट हूँ।
LIC एजेंट बनो, अब बड़ा सोचो। हमारी वेबसाइट पर जाएं या अपनी नजदीकी LIC शाखा से संपर्क करें।
मुझे जॉब छोड़ा फिर भी सो कूल।
ब्रो, नए चैलेंजेस नए मौके लाते हैं।
अच्छा?
सीरियसली राहुल, मेरा पूरा घर नाउ इट्स एन ऑनलाइन रिटेल स्टोर। देख।
वाओ, लेकिन पैसे?
कुछ साल पहले दिवाली बोनस को इन्वेस्ट किया था।
और अब तो है LIC का यूलिप प्लान निवेश प्लस। एक बार इन्वेस्ट करो, इंश्योरेंस से सुरक्षा का लाभ और मार्केट की बढ़त का फायदा दोनों पाओ।
वन सेक राहुल।
मैडम, यू आर डबल कूल।
Life is about to change, है? No more 8 घंटे की नींद, no more late night movies, no more parties with friends.
बिल्कुल सही कहा तुमने। इसके फ्यूचर के लिए अब नो मोर हॉलीडेज, नो मोर शॉपिंग और नो मोर फिजूल का खर्च।
लेकिन अगर इसका फ्यूचर ऑलरेडी सिक्योर्ड हो तो?
रियली?
डैडी बने हो, देवदास नहीं। जीना छोड़ दूंगा, हॉलीडेज छोड़ दूंगा।
स्मार्ट लोगों की क्लियर है प्रायोरिटी, बाकी सब बाद में। क्यूट वाले मेहमान से पहले LIC।
पता है, I was a bright student. कुछ करना चाहती थी, कुछ बनना चाहती थी।
आप अपना खुद का स्टार्ट कीजिए ना, खुद का बिजनेस। पर उसमें पैसे तो बहुत लगेंगे ना।
जीरो इन्वेस्टमेंट।
जीरो इन्वेस्टमेंट?
हाँ, I'm doing it.
मैं एक प्रिंसिपल मैडम।
She's my client. मैं LIC एजेंट हूँ।
LIC एजेंट बनो, अब बड़ा सोचो। हमारी वेबसाइट पर जाएं या अपनी नजदीकी LIC शाखा से संपर्क करें।
मुझे जॉब छोड़ा फिर भी सो कूल।
ब्रो, नए चैलेंजेस नए मौके लाते हैं।
अच्छा?
सीरियसली राहुल, मेरा पूरा घर नाउ इट्स एन ऑनलाइन रिटेल स्टोर। देख।
वाओ, लेकिन पैसे?
कुछ साल पहले दिवाली बोनस को इन्वेस्ट किया था।
और अब तो है LIC का यूलिप प्लान निवेश प्लस। एक बार इन्वेस्ट करो, इंश्योरेंस से सुरक्षा का लाभ और मार्केट की बढ़त का फायदा दोनों पाओ।
वन सेक राहुल।
मैडम, यू आर डबल कूल।
Life is about to change, है? No more 8 घंटे की नींद, no more late night movies, no more parties with friends.
बिल्कुल सही कहा तुमने। इसके फ्यूचर के लिए अब नो मोर हॉलीडेज, नो मोर शॉपिंग और नो मोर फिजूल का खर्च।
लेकिन अगर इसका फ्यूचर ऑलरेडी सिक्योर्ड हो तो?
रियली?
डैडी बने हो, देवदास नहीं। जीना छोड़ दूंगा, हॉलीडेज छोड़ दूंगा।
स्मार्ट लोगों की क्लियर है प्रायोरिटी, बाकी सब बाद में। क्यूट वाले मेहमान से पहले LIC।
पता है, I was a bright student. कुछ करना चाहती थी, कुछ बनना चाहती थी।
आप अपना खुद का स्टार्ट कीजिए ना, खुद का बिजनेस। पर उसमें पैसे तो बहुत लगेंगे ना।
जीरो इन्वेस्टमेंट।
जीरो इन्वेस्टमेंट?
हाँ, I'm doing it.
मैं एक प्रिंसिपल मैडम।
She's my client. मैं LIC एजेंट हूँ।
LIC एजेंट बनो, अब बड़ा सोचो। हमारी वेबसाइट पर जाएं या अपनी नजदीकी LIC शाखा से संपर्क करें।
मुझे जॉब छोड़ा फिर भी सो कूल।
ब्रो, नए चैलेंजेस नए मौके लाते हैं।
अच्छा?
सीरियसली राहुल, मेरा पूरा घर नाउ इट्स एन ऑनलाइन रिटेल स्टोर। देख।
वाओ, लेकिन पैसे?
कुछ साल पहले दिवाली बोनस को इन्वेस्ट किया था।
और अब तो है LIC का यूलिप प्लान निवेश प्लस। एक बार इन्वेस्ट करो, इंश्योरेंस से सुरक्षा का लाभ और मार्केट की बढ़त का फायदा दोनों पाओ।
वन सेक राहुल।
मैडम, यू आर डबल कूल।
Life is about to change, है? No more 8 घंटे की नींद, no more late night movies, no more parties with friends.
बिल्कुल सही कहा तुमने। इसके फ्यूचर के लिए अब नो मोर हॉलीडेज, नो मोर शॉपिंग और नो मोर फिजूल का खर्च।
लेकिन अगर इसका फ्यूचर ऑलरेडी सिक्योर्ड हो तो?
रियली?
डैडी बने हो, देवदास नहीं। जीना छोड़ दूंगा, हॉलीडेज छोड़ दूंगा।
स्मार्ट लोगों की क्लियर है प्रायोरिटी, बाकी सब बाद में। क्यूट वाले मेहमान से पहले LIC।
पता है, आई वॉज अ ब्राइट स्टूडेंट। कुछ करना चाहती थी, कुछ बनना चाहती थी। आप अपना खुद का स्टार्ट कीजिए ना,
खुद का बिजनेस। पर उसमें पैसे तो बहुत लगेंगे ना?
जीरो इन्वेस्टमेंट। जीरो इन्वेस्टमेंट? हाँ, आई एम डूइंग इट। मैं एक
प्रिंसिपल मैडम।
शी इज माई क्लाइंट। मैं LIC एजेंट हूँ।
LIC एजेंट बनो, अब बड़ा सोचो। हमारी वेबसाइट पर जाएं या अपनी नजदीकी LIC शाखा से संपर्क करें।
मुझे जॉब छोड़ा फिर भी सो कूल।
ब्रो, नए चैलेंजेस नए मौके लाते हैं।
अच्छा,
सीरियसली राहुल, मेरा पूरा घर नाउ इट्स एन ऑनलाइन रिटेल स्टोर। देख।
वाओ, लेकिन पैसे?
कुछ साल पहले दिवाली बोनस को इन्वेस्ट किया था।
और अब तो है LIC का यूलिप प्लान निवेश प्लस। एक बार इन्वेस्ट करो, इंश्योरेंस से सुरक्षा का लाभ और मार्केट की बढ़त का फायदा दोनों पाओ।
वन सेक राहुल।
मैडम, यू आर डबल कूल।
लाइफ इज अबाउट टू चेंज है। नो मोर 8 घंटे की नींद, नो मोर लेट नाइट मूवीज, नो मोर पार्टीज विद फ्रेंड्स।
बिल्कुल सही कहा तुमने। इसके फ्यूचर के लिए अब नो मोर हॉलीडेज, नो मोर शॉपिंग और नो मोर फिजूल का खर्च।
लेकिन अगर इसका फ्यूचर ऑलरेडी सिक्योर्ड हो तो?
रियली?
डैडी बने हो, देवदास नहीं। जीना छोड़ दूंगा, हॉलीडेज छोड़ दूंगा।
स्मार्ट लोगों की क्लियर है प्रायोरिटी, बाकी सब बाद में। क्यूट वाले मेहमान से पहले LIC।
पता है, आई वॉज अ ब्राइट स्टूडेंट। कुछ करना चाहती थी, कुछ बनना चाहती थी। आप अपना खुद का स्टार्ट कीजिए ना,
खुद का बिजनेस। पर उसमें पैसे तो बहुत लगेंगे ना?
जीरो इन्वेस्टमेंट। जीरो इन्वेस्टमेंट? हाँ, आई एम डूइंग इट। मैं एक
प्रिंसिपल मैडम।
शी इज माई क्लाइंट। मैं LIC एजेंट हूँ।
LIC एजेंट बनो, अब बड़ा सोचो। हमारी वेबसाइट पर जाएं या अपनी नजदीकी LIC शाखा से संपर्क करें।
मुझे जॉब छोड़ा फिर भी सो कूल।
ब्रो, नए चैलेंजेस नए मौके लाते हैं।
अच्छा,
सीरियसली राहुल, मेरा पूरा घर नाउ इट्स एन ऑनलाइन रिटेल स्टोर। देख।
वाओ, लेकिन पैसे?
कुछ साल पहले दिवाली बोनस को इन्वेस्ट किया था।
और अब तो है LIC का यूलिप प्लान निवेश प्लस। एक बार इन्वेस्ट करो, इंश्योरेंस से सुरक्षा का लाभ और मार्केट की बढ़त का फायदा दोनों पाओ।
वन सेक राहुल।
मैडम, यू आर डबल कूल।
लाइफ इज अबाउट टू चेंज है। नो मोर 8 घंटे की नींद, नो मोर लेट नाइट मूवीज, नो मोर पार्टीज विद फ्रेंड्स।
बिल्कुल सही कहा तुमने। इसके फ्यूचर के लिए अब नो मोर हॉलीडेज, नो मोर शॉपिंग और नो मोर फिजूल का खर्च।
लेकिन अगर इसका फ्यूचर ऑलरेडी सिक्योर्ड हो तो?
रियली?
डैडी बने हो, देवदास नहीं। जीना छोड़ दूंगा, हॉलीडेज छोड़ दूंगा।
स्मार्ट लोगों की क्लियर है प्रायोरिटी, बाकी सब बाद में। क्यूट वाले मेहमान से पहले LIC।
पता है, आई वॉज अ ब्राइट स्टूडेंट। कुछ करना चाहती थी, कुछ बनना चाहती थी। आप अपना खुद का स्टार्ट कीजिए ना,
खुद का बिजनेस। पर उसमें पैसे तो बहुत लगेंगे ना?
जीरो इन्वेस्टमेंट। जीरो इन्वेस्टमेंट? हाँ, आई एम डूइंग इट। मैं एक
प्रिंसिपल मैडम।
शी इज माई क्लाइंट। मैं LIC एजेंट हूँ।
LIC एजेंट बनो, अब बड़ा सोचो। हमारी वेबसाइट पर जाएं या अपनी नजदीकी LIC शाखा से संपर्क करें।
मुझे जॉब छोड़ा फिर भी सो कूल।
ब्रो, नए चैलेंजेस नए मौके लाते हैं।
अच्छा,
सीरियसली राहुल, मेरा पूरा घर नाउ इट्स एन ऑनलाइन रिटेल स्टोर। देख।
वाओ, लेकिन पैसे?
कुछ साल पहले दिवाली बोनस को इन्वेस्ट किया था।
और अब तो है LIC का यूलिप प्लान निवेश प्लस। एक बार इन्वेस्ट करो, इंश्योरेंस से सुरक्षा का लाभ और मार्केट की बढ़त का फायदा दोनों पाओ।
वन सेक राहुल।
मैडम, यू आर डबल कूल।
लाइफ इज अबाउट टू चेंज है। नो मोर 8 घंटे की नींद, नो मोर लेट नाइट मूवीज, नो मोर पार्टीज विद फ्रेंड्स।
बिल्कुल सही कहा तुमने। इसके फ्यूचर के लिए अब नो मोर हॉलीडेज, नो मोर शॉपिंग और नो मोर फिजूल का खर्च।
लेकिन अगर इसका फ्यूचर ऑलरेडी सिक्योर्ड हो तो?
रियली?
डैडी बने हो, देवदास नहीं। जीना छोड़ दूंगा, हॉलीडेज छोड़ दूंगा।
स्मार्ट लोगों की क्लियर है प्रायोरिटी, बाकी सब बाद में। क्यूट वाले मेहमान से पहले LIC।
पता है, आई वॉज अ ब्राइट स्टूडेंट। कुछ करना चाहती थी, कुछ बनना चाहती थी। आप अपना खुद का स्टार्ट कीजिए ना,
खुद का बिजनेस। पर उसमें पैसे तो बहुत लगेंगे ना। जीरो इन्वेस्टमेंट। जीरो इन्वेस्टमेंट? हाँ, आई एम डूइंग इट। मैं एक प्रिंसिपल मैडम। शी इज माई क्लाइंट। मैं LIC एजेंट हूँ। LIC एजेंट बनो, अब बड़ा सोचो। हमारी वेबसाइट पर जाएं या अपनी नजदीकी LIC शाखा से संपर्क करें।
जो जॉब छोड़ा फिर भी सो कूल।
प्रो, नए चैलेंजेस नए मौके लाते हैं।
अच्छा,
सीरियसली राहुल, मेरा पूरा घर नाउ इट्स एन ऑनलाइन रिटेल स्टोर। देख।
वाओ, लेकिन पैसे?
कुछ साल पहले दिवाली बोनस को इन्वेस्ट किया था।
और अब तो है LIC का यूलिप प्लान निवेश प्लस। एक बार इन्वेस्ट करो, इंश्योरेंस से सुरक्षा का लाभ और मार्केट की बढ़त का फायदा दोनों पाओ।
वन सेक राहुल।
मैडम, यू आर डबल कूल।
Life is about to change, है? No more 8 घंटे की नींद, no more late night movies, no more parties with friends.
बिल्कुल सही कहा तुमने। इसके फ्यूचर के लिए अब नो मोर हॉलीडेज, नो मोर शॉपिंग और नो मोर फिजूल का खर्च।
लेकिन अगर इसका फ्यूचर ऑलरेडी सिक्योर्ड हो तो?
रियली?
डैडी बने, देवदास नहीं। जीना छोड़ दूंगा, हॉलीडेज छोड़ दूंगा।
स्मार्ट लोगों की क्लियर है प्रायोरिटी, बाकी सब बाद में। क्यूट वाले मेहमान से पहले LIC।
पता है, आई वॉज अ ब्राइट स्टूडेंट। कुछ करना चाहती थी, कुछ बनना चाहती थी।
आप अपना खुद का स्टार्ट कीजिए ना, खुद का बिजनेस। पर उसमें पैसे तो बहुत लगेंगे ना। जीरो इन्वेस्टमेंट। जीरो इन्वेस्टमेंट? हाँ, आई एम डूइंग इट। मैं एक प्रिंसिपल मैडम। शी इज माई क्लाइंट। मैं LIC एजेंट हूँ। LIC एजेंट बनो, अब बड़ा सोचो। हमारी वेबसाइट पर जाएं या अपनी नजदीकी LIC शाखा से संपर्क करें।
जो जॉब छोड़ा फिर भी सो कूल।
प्रो, नए चैलेंजेस नए मौके लाते हैं।
अच्छा,
सीरियसली राहुल, मेरा पूरा घर नाउ इट्स एन ऑनलाइन रिटेल स्टोर। देख।
वाओ, लेकिन पैसे?
कुछ साल पहले दिवाली बोनस को इन्वेस्ट किया था।
और अब तो है LIC का यूलिप प्लान निवेश प्लस। एक बार इन्वेस्ट करो, इंश्योरेंस से सुरक्षा का लाभ और मार्केट की बढ़त का फायदा दोनों पाओ।
वन सेक राहुल।
मैडम, यू आर डबल कूल।
Life is about to change, है? No more 8 घंटे की नींद, no more late night movies, no more parties with friends.
बिल्कुल सही कहा तुमने। इसके फ्यूचर के लिए अब नो मोर हॉलीडेज, नो मोर शॉपिंग और नो मोर फिजूल का खर्च।
लेकिन अगर इसका फ्यूचर ऑलरेडी सिक्योर्ड हो तो?
रियली?
डैडी बने, देवदास नहीं। जीना छोड़ दूंगा, हॉलीडेज छोड़ दूंगा।
स्मार्ट लोगों की क्लियर है प्रायोरिटी, बाकी सब बाद में। क्यूट वाले मेहमान से पहले LIC।
पता है, आई वॉज अ ब्राइट स्टूडेंट। कुछ करना चाहती थी, कुछ बनना चाहती थी।
आप अपना खुद का स्टार्ट कीजिए ना, खुद का बिजनेस। पर उसमें पैसे तो बहुत लगेंगे ना। जीरो इन्वेस्टमेंट। जीरो इन्वेस्टमेंट? हाँ, आई एम डूइंग इट। मैं एक प्रिंसिपल मैडम। शी इज माई क्लाइंट। मैं LIC एजेंट हूँ। LIC एजेंट बनो, अब बड़ा सोचो। हमारी वेबसाइट पर जाएं या अपनी नजदीकी LIC शाखा से संपर्क करें।
जो जॉब छोड़ा फिर भी सो कूल।
प्रो, नए चैलेंजेस नए मौके लाते हैं।
अच्छा,
सीरियसली राहुल, मेरा पूरा घर नाउ इट्स एन ऑनलाइन रिटेल स्टोर। देख।
वाओ, लेकिन पैसे?
कुछ साल पहले दिवाली बोनस को इन्वेस्ट किया था।
और अब तो है LIC का यूलिप प्लान निवेश प्लस। एक बार इन्वेस्ट करो, इंश्योरेंस से सुरक्षा का लाभ और मार्केट की बढ़त का फायदा दोनों पाओ।
वन सेक राहुल।
मैडम, यू आर डबल कूल।
Life is about to change, है? No more 8 घंटे की नींद, no more late night movies, no more parties with friends.
बिल्कुल सही कहा तुमने। इसके फ्यूचर के लिए अब नो मोर हॉलीडेज, नो मोर शॉपिंग और नो मोर फिजूल का खर्च।
लेकिन अगर इसका फ्यूचर ऑलरेडी सिक्योर्ड हो तो?
रियली?
डैडी बने, देवदास नहीं। जीना छोड़ दूंगा, हॉलीडेज छोड़ दूंगा।
स्मार्ट लोगों की क्लियर है प्रायोरिटी, बाकी सब बाद में। क्यूट वाले मेहमान से पहले LIC।
पता है, आई वॉज अ ब्राइट स्टूडेंट। कुछ करना चाहती थी, कुछ बनना चाहती थी।
आप अपना खुद का स्टार्ट कीजिए ना, खुद का बिजनेस। पर उसमें पैसे तो बहुत लगेंगे ना। जीरो इन्वेस्टमेंट। जीरो इन्वेस्टमेंट? हाँ, आई एम डूइंग इट। मैं एक प्रिंसिपल मैडम। शी इज माई क्लाइंट। मैं LIC एजेंट हूँ। LIC एजेंट बनो, अब बड़ा सोचो। हमारी वेबसाइट पर जाएं या अपनी नजदीकी LIC शाखा से संपर्क करें।
जो जॉब छोड़ा फिर भी सो कूल।
प्रो, नए चैलेंजेस नए मौके लाते हैं।
अच्छा,
सीरियसली राहुल, मेरा पूरा घर नाउ इट्स एन ऑनलाइन रिटेल स्टोर। देख।
वाओ, लेकिन पैसे?
कुछ साल पहले दिवाली बोनस को इन्वेस्ट किया था।
और अब तो है LIC का यूलिप प्लान निवेश प्लस। एक बार इन्वेस्ट करो, इंश्योरेंस से सुरक्षा का लाभ और मार्केट की बढ़त का फायदा दोनों पाओ।
1 sec राहुल।
मैडम, you're double cool.
Life is about to change, है? No more 8 घंटे की नींद, no more late night movies, no more parties with friends.
बिल्कुल सही कहा तुमने। इसके फ्यूचर के लिए अब नो मोर हॉलीडेज, नो मोर शॉपिंग और नो मोर फिजूल का खर्च।
लेकिन अगर इसका फ्यूचर ऑलरेडी सिक्योर्ड हो तो?
रियली?
डैडी बने हो, देवदास नहीं। जीना छोड़ दूंगा, हॉलीडेज छोड़ दूंगा।
स्मार्ट लोगों की क्लियर है प्रायोरिटी, बाकी सब बाद में। क्यूट वाले मेहमान से पहले LIC।
पता है, I was a bright student. कुछ करना चाहती थी, कुछ बनना चाहती। आप अपना खुद का स्टार्ट कीजिए ना, खुद का बिजनेस। पर उसमें पैसे तो बहुत लगेंगे ना। जीरो इन्वेस्टमेंट। जीरो इन्वेस्टमेंट? हाँ, आई एम डूइंग इट। मैं एक प्रिंसिपल मैडम। शी इज माय क्लाइंट। मैं LIC एजेंट हूँ। LIC
सर कुछ खाया आपने एनर्जी कैलोरी
ये कहाँ क्लिक करना पड़ेगा ये फीचर है हाँ हाँ हाँ
ब्लाउज काले
मैं बताने कल तो मेरा वादा था कि और है तब मेडिकल इसलिए भी आपको मिलो प्रॉब्ली अभी तो आज यूएस जा रहे हैं 4 टाइप have those meetings. जब ये लग जाएगा उसके बाद फरीदाबाद फरीदाबाद तो जमीन है कनेक्टिविटी बनी है नोएडा ग्रेटर नोएडा जब उसके बाद ये नोएडा ग्रेटर जो पहला बनाया था मैंने विजय माल्या उसके थोड़ा और ये तो भले ही हम कुछ नहीं करते एक मोस्ट ऑफ चलिए शुरू करें सर मुझे खाली सर मैं गुलाब जामुन ठीक है सही कह रहे हैं नहीं कितना बड़ा ठीक है आपकी कार कहाँ पे है कार नहीं टैक्सी से और भारी चल सारे हाँ तो यही रख लेंगे
Good afternoon, ladies and gentlemen. I hope you all have enjoyed the lunch. Let us start the post-lunch session. And we have some very interesting sessions on. The next session would be entitled Molecular and Precision Oncology is Center Stage in Breast Cancer. And it is being organized by Fortis Cancer Institute, and we have a very learned panel with Dr. Vineet Govind Gupta, Dr. Vedant Kabra, Dr. Vinita Goyal, Dr. G. Arun Kumar, and moderator is Dr. Nitesh Rohatgi. So can we request Dr. Nitesh Rohatgi to come on the stage? ठीक है, आप करेंगे, ठीक है. तो Dr. Nitesh, हमने कहा Dr. Raina was
Thank you so much, Doctor.
ये प्रोग्राम है आपके पास? यहीं रखा था जो.
Please, I'll just use your introduction a bit. So please be on the stage. Please don't wait for that. Dr. Anurag has already mentioned it. Please come, please come. So as Dr. Anurag has already, can we, Atul, if you can hear me, can you help close the doors, please? This wasn't on. Okay, as Dr. Srivastava has already shared, our next panel discussion is on molecular. Our next panel discussion is on molecular and precision oncology. It's center stage in breast cancer by Fortis Cancer Institute team. So we already have Dr. Vineet Govinda Gupta, Senior Consultant Unit Head, Medical Oncology, Fortis Shalimar Bagh. Dr. Vedant Kabra, Principal Director, Surgical Oncology, Fortis Memorial Research Institute. Dr. Vinita Goyal, Director and Head of the Department, Radiation Oncology, Fortis Shalimar Bagh. Dr. G. Arun Kumar, Therapy Area Medical Expert, Roche Products India Limited. And our moderator, Dr. Nitesh Rohatgi, Senior Director, Medical Oncology, Fortis Memorial Research Institute. If you give me 2 minutes, I'll just probably do the introductions for all of you. A quick bio. Dr. Vineet Gupta is a Senior Consultant and Unit Head, Medical Oncology at Fortis Hospital, Shalimar Bagh. He's MBBS, MD, and Doctorate of Medicine with Gold Medal from AIIMS, New Delhi. He is an accomplished researcher with more than 50 publications in top national and international journals. Dr. Vedant Kabra is an alumnus of Tata Memorial Hospital, Mumbai, and National Cancer Center, Singapore, with over 25 years of experience. His special interests include breast cancer, and he's passionate about spreading cancer awareness and tobacco control. Dr. Vinita Goyal is the Director and Head of Radiation Oncology at Fortis Hospital. She has vast experience of 25 years in the field of oncology and is passionate about treating and supporting women with cancer. She's an alumnus of prestigious Tata Memorial Hospital. Dr. G. Arun Kumar is a genomicist with specialization in molecular oncology. He's working as therapy area medical expert for personalized healthcare at Roche Products, India. With over 15 years of experience, he has published more than 20 international publications. And not but the least, Dr. Nitesh Rohatgi is a Senior Director, Medical Oncology at Fortis Healthcare and was previously working at the prestigious London Oncology Clinic, Leaders in Oncology Care, London. He's a Fellow of the Royal College of Physicians, Edinburgh, UK, as well as Royal Society of Medicine. He is a key opinion leader in oncology in India. So I hand it over to Dr. Rohatgi to moderate this session. Thank you.
Thank you very much. First of all, thank you for having us here. And how do the slides move? Okay. So thank you for having us here. I think this is a great forum where we are discussing the length and breadth of oncology from accessibility, cost, technique, granularity of how it's treated, to what is very close to us as a group, me individually, which is really where is the cutting edge precision and molecular oncology changing the landscape of oncology. And very quick comment maybe from Vedant first, do you generally believe that the next center stage of oncology, not only breast, will be driven by cutting edge science of molecular oncology?
So I can't agree with you more, Nitesh. It has changed the way we treat our patients, not only breast cancer, as you said, other cancers as well. And I think we are going to see more and more changes. Actually, what we have seen is much less than what is going to come in near future.
Tip of the iceberg, yes, as you often call it. And the question often is, what has we seen in 10 years? 10 years is not a very long time for most of us. I think it just passed in a blip, few years in COVID and the rest without. But really a lot has changed in 10 years. This is a very fantastic photograph of the same couple standing in the same location, and I think we are seeing the effect of this. But in oncology world, actually a lot has changed. We've seen a belief that cancer is clonal, which means it's made out of only few cells, to saying that it's actually made out of different cells coexisting together. We used to diagnose everybody by cutting the biopsy into slides and looking at H&E, and we are now looking at doing some DNA-basis testing, very high-end, to add a molecular layer to the standard testing. We used to believe cancer is of an organ type. Whatever is from breast is from breast, but now we are finding that there are commonalities between breast and colon and lung, and actually you can give the treatment which is irrespective of where it has origin from. We used to believe, this is 10 years ago, that immunotherapy is actually an humbug and it is not going to see anything and it's just a multi-making scheme. These were articles coming out in newspaper. I don't think we published that, but there were articles coming out saying that, and now it's in the front cover of things like Time magazine. We used to believe that the only way of science was randomizing patients 100:100 and see where it works. And now we are finding that when we are talking about huge variability amongst humans, actually that may not be the case for proof of principle in every study. We used to believe that the cost of treatment is high. We now know the cost of treatment is extremely high, but we have started slightly changing about not only looking at cost, but is the cost affecting the functionality of daily living of a patient, called QALY. We used to believe molecular testing is important, but first time I tested one in 2005, it took me 2 months, and we found a center from London to Germany. Now it takes less than 7 days, and my guess is about 2,000 centers every nook and corner. We'll have one in every mall by the end of the decade. And we used to believe microbiomes, which is the gut bacilli and everything, and skin bacilli now are very bad things, and now we know that they are very critical to our immune response and may be important in cancer genesis and cancer protection. So with that kind of a difference in 10 years, let's look at what are the goals, what are the changes in practice of breast cancer in the last decade. I'll start with detection, and maybe I'll throw it at you, Arun. And in terms of detecting cancer, we've always had, and I know there was a session on mammogram versus MRI versus ultrasound, but this is a paper from a company in Delhi which has been kind of collaborated by various people across the world, where at least as a proof of principle, they took blood sample, segregated the plasma, and found the samples and were able to detect cancer before it actually became evident on the scan. Proof of principle, I know this is not reality yet, but do you believe that this science will see the light of day very soon?
Absolutely, Dr. Nitish. This is a very cutting-edge technology wherein it is still in its nascency, where it does require a lot of validation. But yes, early detection of cancer is going to be as simple as a simple blood test, maybe in a decade or so, with good validations happening around it. And this particular technology, called the circulatory tumor cells, does hold a very good promise in the future for early detection, not just for breast cancers, but also for many other tumors.
So let me also ask you a different question then. So there was a lot of news about something called Holy Grail and all of these. Where is the downside of this? If you can elaborate on why it is very important to know that everything you see is not real and you have to be careful about it.
Absolutely. So with the advancement of technologies, what we see in very simple terms is that it has very good sensitivity, but the specificity isn't as good as that. That's where the real challenge of validation comes in. Not all the tumors are the same, not all breast cancers are the same, and there are patient-specific host factors that play a role in having the stability of these molecules, these DNA molecules in the circulation. So the clinical picture is much more complex to make clinical judgments out of these. So I think unless we have a proper validation done,
it's difficult.
It's very difficult.
Vedant, I'll pass this mic to you, and I'll ask you a question as a doctor and then as not a doctor, as a layman. So you read a paper, Arun is a scientific person sitting in the lab, he understands the validation. I personally don't. I only read a paper and I try to make sense out of it, that it's useful or not. But actually as a layman can't even do that. So from a breast oncologist, surgeon point of view, who will be asked this question day in, day out, that doc, we've read a paper, and this is a valid paper, this is very scientific, done properly, they have written the methodology, and they have commented to say that this is the starting point. They have not said that you should do that in everybody, right? How do you use that information? And as a layman, as a person of the population at large, how do you tell others that be careful, but be hopeful at the same time?
So we were discussing just this during the lunchtime.
That's why I'm asking you that question.
So I made a point that time that unfortunately these days the study results are released to press first and are accessible to us later on, and with the hype associated. So we have to be a little careful. Of course, nothing to take away from the researchers and the studies that are being done. They are great and they have a lot of potential. Unfortunately, we have to deal with patients and laymen, as you said, explaining them that this is not the right time, not the prime time for this particular drug or this particular study to be applicable in routine practice. Very good to have liquid biopsies, very good to know there is a cancer cell when it actually has not shown in any of the investigations. Increases the anxiety of the patient, firstly. Secondly, we don't know how to treat it, and we don't even know how to follow it up.
Yeah, so you need algorithms.
So these are the problems. I'm sure they will get sorted out. And more important problems are going to be when you start testing everybody at a very young ages with their employment, with insurances and all those things coming up later in life.
That's great points. What I take away from both of you is the science has arrived. It's very interesting. It will change the world, but we've got to be careful and understand it, and if need be, take guidance, because everything you see may not be gold. So we'll start now with Vedant again, and then we'll come rightward to Vineet and Vinita. So breast cancer decade ago, I'm trying to emphasize on these two tests, which are molecular tests, because that's the topic of the day, and how that has helped you to diagnose a patient better. If you can give me a brief of what happened 10 years ago and what happens today.
So largely, if I remove this, then the immunohistochemistry that we were using to diagnose and classify the breast cancer has remained the same, largely. But what has now changed is, because these tests are now validated, we know that we can de-escalate treatment for certain patients, we can avoid chemotherapy for certain patients, and that is where these have pitched in. Oncotype DX, very long time, CanAssist also reasonably long time, and tested on good number of Indian patients. But to be honest, if we are using it as our first choice, we are still using Oncotype DX.
So I think what I'm trying to ask is, how has your diagnostic ability of a breast cancer patient who arrived into your clinic 10 years ago and today different?
But you are asking based on these tests?
No, I'm asking generally, and I'm giving a special emphasis to these tests because they are molecular.
So I don't think there has been much change in diagnosing them to begin with. What has changed is how we treat them, how we sequence the treatment. That has undergone a sea change. Many of the patients who would have undergone surgery first, maybe 10 years ago, are now going for
chemotherapy,
immunotherapy, and then coming on to surgeons.
And do you use precision medicine to decide
We do. So all these basic markers like estrogen receptor, progesterone receptor are also in themselves precision medicine. Based on that, we are deciding who goes for chemotherapy first and who goes for surgery first. Right now we are using Oncotype DX or such risk scoring tests after surgery. I am sure the time is going to come when we will be using it before surgery or before neoadjuvant therapy as well. Deciding what to do, whether to give chemotherapy at all or not.
I think Vineet has a point, but before that, Vineet, very quickly, as a medical oncologist, you used to see everybody come into the clinic almost must having chemotherapy. These two tests you're talking about decrease the probability of needing chemotherapy. Roughly how many patients do not end up needing chemotherapy, which 10 years ago would have ended up chemotherapy?
So absolutely. So if I think about the kind of textbooks we used to have 15 years back, they used to say that any tumor more than 1 centimeter should ideally get chemotherapy.
Which is almost 100%.
Which nowadays it sounds laughable actually, that practically, now what has happened is, so even if we talk about diagnosis, the way of diagnosis has changed. So if we talk about earlier, we used to diagnose, say it is breast cancer, and the treatment used to be decided on day one.
Yeah.
That this is the treatment which is going to be done. And what has happened now is that we now have that understanding that it's not one disease. It's a cluster of maybe many different, maybe 20 or 25 different kind of diseases which have to be treated differently. And if you look at the entire cohort across all the stages, I would say not more than half the patients will require chemotherapy. And I think it might actually be 30 or 40%, not more than that.
And also, those who require somehow need less chemotherapy because the precision part of the whole rigmarole.
It gives them a lot more options other than chemotherapy.
Vinita, I think you were trying to make a point.
I think the overall point is that there is tailoring of treatment.
Yeah, good word.
There is no one treatment which is given to all breast cancer patients. So for example, suppose we have 5 women with same age and same stage of breast cancer, their treatment might still be very different. And as far as these two tests are concerned, I would say, Nitish, they really excite me.
Okay, very good.
Yeah, because why not? A good number of women, if they can avoid chemotherapy and still get the good survival, good cure without chemotherapy, I think that's a big achievement for many of them.
Just for people who are not doctors in the forum here, these are two tests which look at the cancer DNA and cell slightly differently, more elaborately, and come back with a kind of a score suggesting what is the real risk of the cancer coming back. Nothing is precise, but they are fairly precise. And based on the risk, we can decide whether do we need chemotherapy to reduce the risk, or actually we don't. And in fact, sometimes it says risk may be high, but the chemotherapy may not benefit. So these are two examples. There are more out there. There are two examples of tests. So what Vinita was alluding to, that it's great to have confidence in a test done on the breast tissue that's taken out, which then tells us whether this patient's survival may be still as good with or without chemotherapy, therefore not giving chemotherapy, or tailorizing, therefore, the post-surgical therapy to the patient.
Another thing which really excites me is that, you know, earlier stage 4 breast cancer was always looked at with a lot of pessimism, you know. Now, good number of stage 4 patients will also survive for a long time, good quality of life without chemotherapy.
So
I think that's a great achievement.
Yes, so I think what we are all alluding to is then and now. I've been laughed at this photograph, but I actually do think that that is the starkness of treatment that has happened, at least in our field. We are now not the same oncologists that we were 10 years ago. We have a different ethos. We have a lot of commonalities. IHC is still common, and I'm not alluding to the commonality there, but there are a lot of differences in the whole perception, in the whole treatment, in the whole outcome, and that has become very important. Vineet, this question is more specifically for you. So this is a category of curative breast cancer patients where the breast and the lymph nodes have or have not been, they have been removed, and we analyze the basic three things: whether the female hormone receptor, estrogen receptor is positive, whether HER2 is positive, and progesterone receptors all are negative. And based on that, we used to divide how to treat patients. So can you give me insight into what these graphs are suggesting, that in all three categories we have actually made a big stride in the last 10 years?
So basically, see, again, this goes into the theme of precision oncology, which basically means that we figure out what kind of cancer a patient has and treat with whatever works for that patient, not just treat all patients with a basket kind of treatment. So we have got three main categories of breast cancer, and they have subcategories. And for each of them, there is a selective kind of therapy which we can give to that patient which improve their long-term outcome. So you can see that in the curves that these are the kind of long-term survival curves or long-term disease control curves.
This
and
one is sitting at 5 years, isn't it?
Yeah, and you can see the kind of outcome you can get nowadays if patient gets the kind of tailored therapy which is required by his tumor. You can see that these curves are flattening out around 70, 80, 90% nowadays. So this just shows the degree of cure you can get across stages and early stage if you apply the right therapy. And very important that if suppose you wanted to treat you can't just treat everybody with every therapy. The main thing is that you have to find the therapy which fits the benefit toxicity ratio in each particular patient so that you can get that best outcome in each particular patient.
Excellent, excellent. So this is example of what we have done. In the first one is you can not one tablet. You know, we very commonly heard of tamoxifen after surgery and after radiation, after chemo. Here we are using a second drug along with a drug like tamoxifen or AI, and we have added that drug called ribociclib here. There are 3-4 drugs in the class. In addition to that hormone therapy, because these patients were still high risk of disease coming back. And what we see that even as far as 3 to 4 to 5 years, there are more patients surviving because of the second oral drug being added. In the second class, in the HER2 positive, which is the extra aggression factor on most, on 1/3 cancer cells, if you add a combination of two drugs called Herceptin and pertuzumab, the tumors shrink rapidly, and the outcome of these patients of curability improves even after the surgery and everything else done. And very recently we saw immunotherapy, a lot of talk about immune system being modulated to start fighting cancer. And in the worst class, triple negative here, when we gave immunotherapy even before surgery, we saw better shrinkage, but we certainly saw better survival. Now, what is very important, and this is important for all of us and all of you there, one does not apply to all. So we do know immunotherapy does not work in hormone positive, especially not in HER2 positive, and we know that pertuzumab, trastuzumab will not work in triple negative. So it's very important to what Vinita was saying, tailorizing therapy of these patients. So let's talk about advanced stage. I'll come to Arun, you first, because you are involved with a lot of diagnostic processes, and I know you are involved with a lot of science behind it. But as a researcher, how have you seen the advanced stage breast cancer change over the last maybe 10 years?
Absolutely. So the biggest change that we see is that we have got a much better understanding of resistance mechanisms and much better understanding of the class of drugs to be used based on genomic profiling. Even if it is a hormone positive breast cancer in a metastatic setting or a late stage setting, the type of hormone therapy to be given can also be dictated by the molecular mutations or the groups that are there within the tumor. Likewise, we talked about the CDK4/6 inhibitors here. Again, resistance to CDK4/6 inhibitors are again, you can get the information from molecular therapy. So I think our overall understanding of the therapeutic modalities, resistance mechanisms, and mechanisms of actions has grossly increased.
So what Arun is speaking about is the ability to give knowledge to us how to use that, and that has improved. Vedant, as a surgeon, I know you treat non-metastatic patients predominantly, but as a surgeon oncologist, you keep getting these metastatic patients. 10 years ago and today, do you sometimes get surprised that these patients who you may not have expected would survive beyond a few months, a few years, are okay at year 5, year 10 and beyond sometimes?
Yes, and especially the HER2 positive group.
Yeah.
They go on for a long time, and sometimes we actually end up operating. We see 5-6 years survival, no disease anywhere, and local disease popping up again. I think those are the groups where we have to, as Vinita said, tailor the surgery and then give them a little more aggressive and possibly
so our practice is changing because
yes.
patients are doing better.
Yes.
Vinita, I know you have a point, but I also wanted to ask you, just like Vedant is talking about doing surgeries in metastatic patients, sometimes rarely because their journey is changing, are you finding that controlling low volume of disease with radiation at times is actually help them live better and longer?
So first I'll make my point. Vedant said that he's happy to see them. I will say that I'm happy to see them live with a good quality of life also.
Yeah.
Their quality of life is generally maintained, which gives us more happiness, And I agree with you, with Nitesh, that at times these patients who are metastatic, who have stage 4 cancers, are on systemic therapies, do benefit immensely with local radiation therapy without much side effects. There will be some side effects, but not very high side effects.
So there was a discussion a few years ago, I think, when one of Tata's conference, that pick up the patient right. A patient who's well controlled on easy therapy for longer is likely to benefit, and I think that's what you're trying to allude to.
We need to have a discussion in the tumor board and identify the correct patient. Not everyone will require it, but identify the correct set of patients. And sometimes they are able to maintain their disease control on the same drug for a longer time because of some addition of small radiation therapy here and there.
So Vineet, this is a very complex diagram of metastatic stage 4 late stage breast cancer patients who usually did not survive long enough. Can you just describe very briefly of the 4 categorization that is being shown here, because this is the crux of that tailorization, this is the crux of that precision.
Yeah, so actually it just shows how practice has changed. So if I go back some years, I will tell you, suppose we get a stage 4 cancer patient and patient is HER2 positive. At that time we used to not have very good news for the family. We used to say that we have some therapies, but the prognosis is, it's just okay, it's not that great. But nowadays when patient comes, what we tell them is that a study which was published in 2012 has already achieved survival more than 5 years on average. And now we are in 2023 and you can expect to live a very long and healthy life. So this is just some kind of approaches. The main reason is we have these new therapies which are based on specific genomic targets. So most of these tumors are driven by the HER2 gene. So we used to have a classical one simple drug which used to work on that gene, but now we have got many different types of targeted approaches also. You can use what is called ADCs. So these drugs, they enter the cancer cell specifically and only kill that cell. We have got bispecific antibodies which link two antibodies to achieve cellular killing. We have got tablets which block the growth pathway of the cell from inside, which allow the long-term disease control, and we have immunotherapy which allow the immune system to activate and kill the cancer.
I'll ask you another additional question, Vineet, because I know you were involved with clinical trial of some of these drugs, and I know you are a trialist at heart. So do you feel that clinical trials in the Indian setup, especially in these very expensive but very targeted agents, help the whole trial group, kind of 100 patients that you treated, live better and longer?
Yeah, absolutely. So I will tell you for sure that I have seen, if I have to count, there are at least 100 patients which would not be alive today, which I know if they had not joined a clinical trial. So we have, so good thing about the clinical trials in our context is that suppose we go back, say, 10 years, then the drugs which we have now, they were clinical trial drugs. And somebody which without a trial, they would have a short survival if they join a clinical trial.
Yeah.
They would have access to those drugs and get a very good outcome.
I think
if you talk about, sir, international trials right now, if you talk about recruitment in multi-country trials, nowadays China is number 2 or number 3 in all the trials, but India is moving up, I think. We should be joining more of these studies.
And what I was also alluding to, there was this term called the guinea pig effect, which 10 years ago, anybody going to trial felt they were going to be a guinea pig for somebody else's sake. But with the advent of this targeted therapy, precision oncology, immune modulation, we are now trying to not only give precision therapy to patients, but even the trial is based on what the patient needs most. So you will not put a triple negative patient on actually a HER2 trial and vice versa. So the trials are very cleverly designed to benefit more than they're used to. That doesn't mean that the trial will work for everybody. It is a trial. We don't have numbers. We don't have statistics on that. But its probability of using you just as a guinea pig is lower because it is more specific for the patient needs.
Yeah, absolutely. And I think the trial oversight in India has improved a lot.
Yes.
So nowadays, any patient in trial, there is a very robust system of reporting side effects, reporting unexpected findings. So patient safety, I think, is nowadays very, very good in clinical trials.
Okay. So I'll pass it back to Arun. Arun, these are 4, and I'm sure there are many more diagnostic tests in late-stage disease, patients who have had multiple lines of treatment, failed, and they're still trying to find some answer. And I know that on the ballpark, you could say this is a wasteful exercise because only 10 out of 100 really benefit, and this is our own actually Indian data. We've collected all across India some samples and come across 10 to 12% benefited. But really, what is this test trying to do? If you can describe briefly what called comprehensive genomic profiling, next generation sequencing, molecular testing, DNA testing, there are various names to that. What are we trying to do here?
Yeah. So essentially, cancer is a disease of the genome, if I could say so, because it's a mutation or a change in the sequence of the DNA that causes the cancer. Now, what we try to do in these tests is that we select a set of cancer-specific genes that have targets, that have prognostic effect, that have diagnostic value, and we sequence them. Now, when you sequence, say 10, 15 years ago, you couldn't do this sequencing so effectively because at a given time, you would sequence just say 100 or 500 or 600 bases or nucleotides. Today, we can sequence billions of nucleotides in a day or two's time, which is where the turnaround time that you had mentioned in the first slide from 2 months has now dropped down to less than a week. So these tests try to identify such genetic aberrations that are there in the tumor that can really help the clinician prognosticate, give targeted therapies, and make the clinical outcome make it better.
Excellent. I know I'll go very quickly to this, and Vedant, the question is to you. I know you have special interest in this. So essentially what we do is we take the DNA of the cancer cell, we look at all the normal associations, and we take out all the abnormal ones and all the abnormal ones are likely to be the one causing cancer, but then we analyze it through computerized algorithms and see what really causing what. This has led to a new concept called multiomics, where it's not just the abnormality of the DNA, but its interaction with its environment, its interaction with the protein expression, its interaction with the food we eat and the way we live. And actually this is going on now to putting an artificial intelligence layer on that and seeing if we can use multiple such patients' information to start predicting. And the first such paper came in lung cancer, whereby just putting all of this together, they could really tell whether immunotherapy in lung cancer could or could not work. And I'm sure we'll see this in breast cancer. And the reason I say this question to you, Vedant, because I know you're very informed and very interested in using artificial intelligence, some cutting edge computer and data, and you talk about this, we talk about this at the hospital, and how it will change the future of oncology.
So artificial intelligence ultimately has to be fed. If you don't feed it right, it won't help.
And I'll pause you there. Which country in the world can feed it right? There's only one. Only India.
Yes.
And I'll say that,
Yes.
I'll tell you why.
Yes.
China is huge population, but it's closed door. India is huge population, open door. I've written a paper in Policy Institute. US, the data is so stringent, you cannot put enough variabilities. AI is dependent on variability in the data set. India, for my guess is 5,000 tax-rebate people will be happy to give their data. But the point I'm trying to make is we are variable, we are north-south, we are east-west, we are rich-poor, we are fat-thin. The variability in India is so huge, and we all have telephones. So we are the only country in the world.
Absolutely. So a few years ago, IBM Watson came with a bang, and we were given a demo. We just tried to give it a scenario, or maybe a couple of scenarios where we knew how it is going to be treated. But it was wrong, and they were breast cancer scenarios, relatively common scenarios. So it was correct only for very common cancers and common scenarios. Uncommon scenarios of common cancers were also not correctly advised
you
by...
know that it was trained in only one institute.
Yes, exactly. So that was the problem. Unless we feed it in a very large population or through a very large population, as you said, with variability, I don't think we can use it. And ultimately, we are the ones who are going to finally judge and decide how to go about it. So AI is a great thing. I'm sure it will help us. It will process things faster for us, but we have to be very careful in utilizing the recommendations.
You're saying something? No.
AI is, I think, going to give us the next leap.
Yeah, it's inevitable in my mind. Inevitable in my mind, but the data will be an issue. We will have to understand it better. Vedant is absolutely spot on right. And I think if Arun and Vedant and us can work together, him finding all the molecular abnormalities and we seeing if we can add more value, but we'll have to get used to adding every patient information, which we are not doing or able to do at the moment. This is one more next step or leap in technology that is happening today. And this is possibly the last few slides I'm going to talk about. This is called ctDNA for MRD. We've operated on the patient. Post-surgery, we do a blood test and we sort out who's already cured by surgery and who actually still has DNA circulating in the blood, suggesting they must have chemotherapy. And this was the data on colon cancer, where when we did this, there was a separation of curve. And so the question is, first to Vedant, then to Vineet, that do you think it's not very far when in breast cancer, we will be using these kind of technologies to further see who does and does not need therapy and chemotherapy and so on and on?
Yes, I believe so. But our precision medicine in breast cancer is still way ahead as compared to colon.
Yeah, 3.
So we already have a lot of pointers, but I'm sure this will also add to it further.
Vineet?
Yeah, definitely. So it is actually, it ties in with the diagnosis, which
Yeah.
we talked about in the beginning. So there are 3 reasons why I think it is inevitable. Okay. So number 1 is, suppose we talk about common blood tests which we do like hepatitis B or HIV. At one time these tests did not exist. We had to do a liver biopsy to diagnose hepatitis B.
Good
So
point.
what happened is, over time the technology came, the test got cheaper, they got validated, and we were able to use it. The second important reason is that there is something called inverse Moore law, which says that cost of DNA sequencing declines by 90% every 4 years. So what is going to happen is, sooner or later, these tests will be so cheap
That we
that
don't-
like you are doing CBC, LFT, KFT, you will be able to do CTDA also. And when those tests are cheap, the research effort is there and we have the validation. There is no reason not to use these tests. I think they'll be used widely.
Excellent point. So I think with that, I want to just present a case before I close. This is an example of how we use molecular DNA testing to treat people differently. This was a patient who came with a suspect of lung cancer. We were in a bit of a dilemma because a bit of a presentation was like breast cancer. But long and short, we started on treatment for chemotherapy with lung cancer in mind. But when we did a basic immunohistochemistry, there was a strong suspicion of breast cancer. But we had already sent a liquid biopsy looking at the DNA of the patient from a lung cancer perspective. And because the testing is diffuse, it doesn't differentiate breast from lung from colon, it just picks up whatever is abnormal, it picked up a very unique, rare lung cancer protein in a breast cancer patient. So we were testing for breast cancer now, but because we had suspicion this was lung cancer, we sent it before we started therapy, which we often do, and we were very surprised that this patient had a lung cancer protein in a breast cancer patient who was triple negative breast cancer doing badly. We were in a bit of a cusp. I remember discussing with this patient with Dr. Raina in the corridor once, and I said, I'm in a cusp, and really what should I do? And we agreed to continue treatment for a while at least as breast cancer, because this is very unique to us. We saw case reports, but none in liquid biopsy ever done before. While we were treating for chemotherapy and immunotherapy, she actually continued to do badly. Her pain increased, and we took a plunge of faith and we gave her the tablet for lung cancer, seen in only about 3 to 5% of lung cancer patients, possibly only 10 case reports in the world of breast cancer so far. And she had a miraculous turnaround, and 8 months later, there's no disease on the scan. And all I'm trying to say, I'm not saying this is my miracle, I'm not saying this technology miracle. I'm saying the world is reaching to a point where precisely finding the abnormality in any cancer which has a good treatment may have a good solution. And this is hitting the jackpot kind of thing. If we find any of these abnormalities, we are very confident as medical oncologists and oncologists that we can actually treat these patients very effectively for long term with least toxicity. So my last slide, world is changing, oncology is changing faster, mainly pivoting around molecular oncology, and my belief is future is multiomics and AI. Molecular testing in early cancer has arrived. We are using it in breast cancer on a daily basis. I gave you some examples. There is an increasing data to support that the use of targeted therapy and immunotherapy is irrespective whether it's breast or lung or colon. Altogether, and looking to work with AI in the near future, it's time to actually adopt precision medicine. And with that, I'll have last words from each of you and then close. You want to start with Arun and end at Vineet.
Yeah. So a great conclusion slide. We are already in the era of molecular medicine and in the era of precision oncology. So definitely a lot of these technological advances is going to make the technology more affordable, more democratic, as well as give the best possible care for the patient.
Thank you.
So we talked about molecular medicine, molecular oncology, but as a surgeon also we are going into precision medicine. We are trying to offer more and more ladies breast conservation.
Yeah.
By way of reducing the tumor, by giving precise medicines. Also because we can use oncoplastic techniques and we can resect larger tumors and save the breast at the same time.
How much more percentage patient are you conserving breast as compared to a decade ago?
Definitely 10-15% more, definitely.
Wow. Okay.
And not only that, there are two components to breast surgery. One is the breast itself and the other is the armpit or axilla. So we have now moved on from removing all the nodes to removing only selective nodes, testing them and not removing the whole axilla, whole group of nodes, which reduces the post-operative complications, long-term morbidities of shoulder movement. Even if we have to remove all the nodes, we can still reduce the chances of lymphedema by utilizing a simple procedure.
Lymphovascular.
Yes, lymphovascular anastomosis. So these are the changes that have happened I would not say only 10 years. Sentinel node biopsy has been there for many, many years. Oncoplasty also. But the uptake of these procedures in our country has increased drastically.
Excellent point. Vineet?
I think I'm very lucky to be oncologist in this era. So oncology, it is a 5,000-year-old science. Even Egyptian mummies have been found with breast cancer.
Yes.
So somebody was treating them at that time also. But, I think medical oncology, now the difference is we are treating with understanding. It's not just give something to kill the cell. No. We figure out what the cell is doing, why the cell is growing, why is it spreading, and with that understanding, we are trying to kill the cell. And I think that is how we have been able to, I think just in my short career, I've seen so many incurable cases become curable because technology has reached there. So I think it is for medical oncologists like you and me, it's golden age. So very, very optimistic about the near
Diagnosing molecularly, treating precisely.
Absolutely.
Vinita?
So I also agree with Vineet that I feel very privileged to be an oncologist, and I also think that I am the oncologist at the right time. I'll tell you, I am a radiation oncologist. Earlier, radiation oncologists used to not have much respect, especially with surgeons and medical oncologists all around. Now there is a tumor board, and believe me, these tumor boards are far more democratic. I know there are some seniors who are sitting here, they might have a little objection that, earlier also the tumor boards were democratic. I think they are far more democratic. All of us have our own voice, and the outcomes are better because all of us are discussing the patients. And I want to digress when I give my final message. Somebody in the audience asked in the previous session that why our results of cancer outcomes in India are not as good as the international outcomes are, and what is government doing for it. See, I want to address that point here. There are several reasons for that. But one of the reasons is late detection. Since we are all from different corners of society, I want to give a message that AI will do its job, precision oncology will do its job. But our job is to make the society aware. Early detection is very important because there are several advantages. Early detection in early stages requires lesser treatment, lesser cost of treatment, lesser side effects, and better outcomes. So as a society, we have to accept that the cancer incidence is increasing, and let's not shy away from it. Let's remain aware and get ourselves adequately tested.
That's actually very well said. That's very well said. With that, thank you. My last message is please, always the last message, promote to stop tobacco use in the society. Thank you.
Can I please request the speakers to stay on stage for the certification? Thank you, Dr. Rohatgi and the panelists for the valuable inputs. May I request Mr. Oman Tharkan to hand over the certificates to the panelists. Mr. Oman Tharkan, General Manager Marketing, Malayalam Manorama Group. Thank you once again, Fortis team.
Can we have some question?
Yes.
Sure.
Thank you. So, does the WISE panel think that the time of randomized controlled trial in decision making for treatment is over, and we do not trust the level 1 hierarchy of evidence based on meta-analysis of large, well-conducted randomized trials?
So, sir, I think there is zero question that that is not the case, and that will not the case for a very foreseeable future. But there's a difference that has happened in the last decade. Till I was in training, I was taught only and only to believe a prospective randomized placebo-controlled trial. As I was leaving training, I was kind of started believing that for certain situations, the proof of principle is also in efficacy and response rates, which we used to see in phase 2 trials as well. as I'm seeing now, there is an impossibility with a variability actually to do a phase 3 randomized trial in truly a precision medicine situation because the variability of that combination is so high. So I don't think there'll ever be a situation where we will leave the randomized and the meta-analysis behind. We can't, because that's the basic core of belief that this is not my bias, but this is a scientific proof. But we are reaching a stage where single-arm proof of principles studies in a patient who's failed other therapies and has very little treatment option or no treatment option left can be used. That's at least my view.
So I think field of clinical trials is also evolving. So recently I had a good chance to sit in on a conference about the nature of new trials. So there are some adaptive clinical trial designs coming up which I think they are more suited for kind of precision approach.
Like basket trials.
Like basket and umbrella trials. So for example, they talked about a very interesting trial design where the trial starts with 15 arms and 1 month later they prune 5 of the arms by getting the early efficacy signal. So what they do is that because you have got a lot of populations, individuals which are very small in size, you have to figure out a way to create more effective trials which can answer the same question without being a massive like 5-year, 6-year effort. So I think work is going on in that direction.
I also want to make a small point there that I agree that the clinical trials are, the basic. We always have to follow that. But then there are rare situations. For example, the situation which you were presenting just now. So for that, we will never have a clinical trial. But we still have to find out the correct solution for the given patient.
Dr. Mehrotra? Yes, Dr. Anna.
I think the sea change in clinical trials of cancer occurred nearly 10 years ago when FDA changed its requirements because the costs were becoming too much and the time taken for the clinical trials was becoming too much. I think there was a total change in the policy about 10 years ago where they enabled small trials on the basis of which the disease-free survival was taken as the endpoint, not the overall survival. And that has brought about a total transformation in the clinical trial scenario in the last 10 years. They are happening more quickly with less budget and we are having the outcomes within 3 to 4 years instead of waiting for 10 to 15 years. I think that change is gradually coming to India also because we follow the FDA rules. And there will be further changes. And as Vinita said that for rare diseases, you can't have clinical trials.
But so I do agree that because we are right, therefore a lot more onus has come on to the head of the oncologist to decide to treat a patient on what basis. That change has happened also. Any other questions?
And it has to be an informed decision with the patient and the family.
Yeah. Any other questions? Okay. Thank you.
Moving on, in today's times, more and more people are opening to the integrative and holistic approach in saving lives, be it preventive or curative. So up next, we have our panel discussion on traditional, complementary, and integrative medicine. For that, I request Dr. Preeta Mehra, Dr. Sujata Mittal, Dr. Akhila, and Dr. Anurag Srivastava to please join us on stage. Dr. Preeta Mehra is a research officer in Central Council for Research in Homeopathy and the coordinator for Drug Providing Research Program. As an ardent and passionate physician, she was nominated as one of the nodal officers and Center of Integrative Oncology of India, Institute of Ayurveda. She also worked in the capacity of the editor for the Homeopathic Heritage and co-authored a book titled History of Medicine and Contribution of Hahnemann. She has a dozen research papers published in national and international journals. We have Dr. Sujata Mittal, a senior gynae oncologist. She did her MS from SMS Medical College, Jaipur, and was trained in oncology from Kidwai Institute, Bangalore. She is a certified holistic cancer coach, plant-based nutritionist, and a lifestyle medical expert. She integrates mind-body therapies for reversing cancer and is an expert in non-toxic immunotherapies for cancer treatment. She has been a faculty to various medical conferences and has written numerous papers. She has won many awards. Rajasthan Prestigious Women Award 2014 is one of those. She conducts online cancer reversal workshop for cancer sufferers across India, where epigenetics, nutrition, lifestyle modifications, and natural therapies are taught. She's currently based in Delhi. We also have Dr. B. Akhila. She's the research officer and in charge Siddha Clinical Research Unit under Ministry of Ayush, Government of India. She's PhD in Siddha. Her major work includes performing the task at the nodal officer and providing Siddha consultation in Integrative Cancer Care Unit at Center of Integrative Oncology. So, Dr. Srivastava, can I request you to take this over?
Good afternoon, ladies and gentlemen. So this is going to be an interesting session. Dr. Dhanraj, the Dean of the Ayurvedic Medical College, Patanjali, Haridwar, had to leave for some emergent meeting. So we have honorable panelists here. So the rationale of having this integrative medicine approach was the fact that we, what you call allopathy in lay language, or modern medicine, has witnessed some lacuna in the knowledge or experience. So, in spite of best care advised by senior experts like Dr. Raina and other learned oncologists, we still lose 20 to 30% of patients, especially triple negative young breast cancers. I lost two of my sisters of triple negative breast cancer. So we need to look into other branches of medicine, and therefore we need to learn from Ayurvedic, homeopathic, and other Unani, Siddha, and other branches of medicine to take help and to find out what is missing in our knowledge and how can we fulfill this lacuna. So that's why this session. So I start with requesting Madam to talk. Dr. Sujata, please. Thank you.
Good afternoon, everybody. Today, the things which I'm going to talk, I'm a gynec oncologist by profession. And as usual, as said by Sir, we have seen a lot of deaths. And I'm going to say the things which will change the perspective to how to manage the cancers. Because I have seen, as a gynec oncologist, I have seen that we are not giving the desired results, and most of the cancer patients, they die of malnutrition, anemia, and the infections. And when we give the chemotherapy, even the molecular targeted therapy, the side effects are no less. So the way we are going to see, allopathy sees the person as an organ. Brain mein mats hue, brain ko treat karo. Liver mein gaya to liver ko karo. What's happening to the body? We are not seeing that. I'll be this PPT I specially prepared for this, and I'll be going very fast because Shruti is repeatedly telling every chairperson that time is short. So this is the redefining the cancer treatment, the way we treat our patients. And just to let you know that our body has got the innate capacity to renew itself. Our whole body gets renewed within a span of 98% of the body gets renewed in a year. And this is what the capacity, and this is what the allopathy is doing. Now the NK cells are exploited. They are taken from the body, multiplied outside and given back in the body to treat the cancers. So why not have the innate capacity of the body to treat the disease itself? The basic factors, when we are talking about the lifestyle, Doctors say lifestyle modification, but we are not taught nutrition at all. As a doctor, as an allopathic doctor, till I studied, till I suffered, I didn't know what is the problem with my own body. So we are not taught nutrition, but the things start when we have got the poor diet, infections, toxins, and stress, along with the digestive imbalances and the way we are living. We are not moving. Today's person eat a lot. Till 2 or 3 or in the 4 in the night, people are eating and sleeping by 10, 11, especially the youth. And then we are saying कि body काम नहीं कर रहा, बहुत सारी problems हो रही हैं, obesity. So all these poor diet, infection, toxins, they lead to the nutritional deficiencies, hormonal imbalance, genetic abnormalities, sensitivities, allergies, and neurotransmission imbalances. And these then cause the genetic mutations. And allopathy only tests the genetic mutations and treat them. But the way forward is to look after, to see why they occurred. We are not finding the why cancer has occurred in particular body. And cancer is not a single entity. It is a convergence of multiple health factors coming in one's life at the same time. So these are the classic study. Just to nutshell, the last one picture I want to show, where they said the interior milieu is responsible for the genetic mutations. They did the trial where the cytoplasm was healthy and cytoplasm was abnormal and the genetic material in the nucleus was normal. And when this cell divided with the abnormal atmosphere of the cell, means cytoplasm having the oncometabolite interior milieu, that resulted in the cancer, and even the nucleus, genetic mutations occurred in the nucleus also. In 1988, classic study was done where the adopted children, because in America, 15, 16-year girls they are pregnant and they leave their children. So the adopted children, if the adopted children's parents, those who have adopted them, if they died of cancer, the children had the 500% increase the risk of the developing cancer. So it states that the environment and the lifestyle choices we made actually modify the genetic code of the offspring, and this branch is called the epigenetics. So nowadays a lot of focus is on the epigenetics, and it is the interior milieu. हमारी soil कैसी है? बीज पूरा खराब भी हो, पर अगर soil अच्छी है तो बीज उसको में आएगा और उसके जो रिजल्ट्स होंगे बेटर होंगे. So this is all about the epigenetics, the lifestyle modification, the diet, and everything is regarding the epigenetics. So the medical model, we know how the medical model works. The lifestyle model जो है, that works on whether this soil will favor the tumor progression, or it will help in stopping the tumor progression, or it will help in stopping the metastasis or the angiogenesis of the tumor. So another important aspect is, जैसा कि मैंने कहा कि हम सिर्फ organ देखते हैं, but body जो है, it is not only organ, it has got physical, mental, emotional, spiritual components, and when we are treating the patient, we have to look at every component of these things. And body is a chemical vessels. Thousands and crores of reactions are going on in the body even when we are sleeping. So if we put the garbage in, we as doctors never tell कि क्या खाओ. इतने cancer patients, especially the breast cancer patients, when I do the workshop, they say कि doctors बोलते कुछ भी खाओ. But if you put the pizza and burger in your body, then you will throw out the pizza and burger only out. So the garbage in any form, whether it is thoughts, your emotions, and whether you are spiritual or not, all these will matter. So today's mantra is detox. And so we have to, in a patient having a cancer, we need to go for the detox at every level, which means anti-accumulation as well as active elimination. This I have already told. So the physical detox is the diet, foods to be avoided, gut health. Gut health, our saints used to say all the diseases starts in gut. Now science is saying कि gut microbiota बहुत important है, और gut से ही बहुत सारी problems होती हैं. Most of the cancer they might start from the gut. So we need to look. जो पुरानी चीजें थी वो अब science समझ रही है. That is the way the things are going on. So the fasting, intermittent fasting, sleep, supplements, and cleaning the body through the different techniques. Diet is a recipe for the angiogenesis inhibition, apoptosis stimulation. It improves the quality of the life, it increases the longevity, and prevent recurrences. So it's something like this. You cannot run your body is so it's just like a expensive car. So अगर आपकी कार पेट्रोल पर चल रही है तो आप उसमें डीजल डालोगे तो एफिशिएंसी डिक्रीज ही होगी. तो सिमिलरली विद द बॉडी यू नीड टू सी कि आप इसमें क्या डाल रहे हो, कैसे थॉट्स डाल रहे हो, कैसे उसको जी रहे हो, आप उसमें कुछ फिजिकल एक्सरसाइज दे रहे हो कि नहीं दे रहे हो. एंड फॉर ऑल द डिस्टिंग्विश्ड पीपल आई पुट इन 3 books for the reference which are based on all the clinical trials, and these are written by the doctors only. Anti-cancer by Dr. David Servan, he suffered from the brain tumor. What's missing from the medicine? Saraya Stanek, she had multiple sclerosis. With diet and lifestyle modification, she cured it. And what your doctor doesn't know about the nutritional medicine may be killing you, Dr. Ray Strand. So these are by the doctors and with the all clinical trials and the proof. So in the food, I just want to tell everyone that all the man-made food is literally full of chemicals, preservatives, and it is full of the salt and sugar. So as a patient of breast cancer or any cancer, especially in the breast cancer, one need to choose the food which is whole, plant-based and organic. Even our water is polluted, and the fluoride and the chlorine in the water causes a fibrocystic disease, which might be the initial thing from where the CA breast can arise. So no peeling when you are using the organic food. There is no need for the peeling. Less of jaggery and no refined items like sugar and maida. No milk products. That is a very big thing. Now the milk is poison. It is loaded with the hormones. So every cancer patient, even day-to-day life, so as to prevent the cancer, we should stop taking the milk and dairy totally. That is a very big thing to say here, because it's a big industry. And no non-veg, and we need to eat the way animals. They don't cook their food, they take no oil, and they don't drink milk. As I told you, the milk is really poison. It contains, because it is demand and supply. According to the demand, the number of the type of the cattle, we don't have so much of the cattle. So they are using the reproductive technologies which we are using in our IVF labs for the cattle also. So they are given the growth hormone. Basically it is the growth hormone, FSH and LH. And this growth hormone is responsible for the insulin resistance. It is pro-inflammatory. It stops the programmed cell death. And the way the cattle is given the food, corn and soya, instead of grass, they are given the corn and soya, which causes the imbalances in omega-3s to omega-6 fatty acids. So there means, if allowed, I can talk for 3 hours on the milk alone. In America, 6-year girls are getting periods. In India, I've seen 9 to 10 years girls getting periods, and stoppage of the dairy immediately resolves so many problems. Breast enlargement, now the gynecomastia has come in such a big way. PCOD, endometriosis, fibroids, everything is day by day increasing because a lot of dairy is being consumed. These are the studies, because there are a lot of doctors, and doctors just believe on the evidences. So I've just put the study. So 50 for the treatment or for the prevention also, we need to incorporate more of the fruits and vegetables. 50 to 70% of the raw should be there, and all, as I told, minimize the oil. Per day, I'm asking the patient to have 1.5 to 2 tablespoons of the oil, and no refined oils at all. These are the ways, salads, because you cannot go on eating daily kheera, kakri, tomato, so you need to know how to make the salads. And some of the supplements in the form which really helps in fighting the cancer is the aloe vera. There's a beautiful paper by Ali Harvey, Anti-Cancer Potential of Aloes, and it is an antioxidant, anti-proliferative and immunostimulant. Similarly, the moringa, all the plants, we have got bounty of the plants in India. It is nutrient-dense plant. Moringa is a nutrient-dense plant, and it has got 10 times more vitamin A than your carrots, 25% more iron than the spinach. And it is, see, these things have to be taken on daily basis. It cannot be कि आज एक दिन खाया and then you expect the result within a day. So these are the wonderful plants, and our Indian gooseberry, amla, which contains the nature's highest amount of vitamin C, is really, we are giving high dose IV vitamin C. In corona, we have seen the results of the high dose IV vitamin C. So we incorporate vitamin C in high dose in diet only. Lot of other things, lot of other problems can also be sorted out. So in breast cancer, the foods which need to be avoided are breads, cookies, muffins, dairy, yogurt, cheese, packaged with additives, preservatives, dry fruits with the salts, proteins, coffee, meat, food, aluminium. Aluminium is one of the, it causes the Alzheimer, Parkinsonism, and plastic store wells. Plastic store wells, they leaches out the BPA, and BPA, once it is mixed in the food, it causes a resistance to so many of the chemotherapy drugs also. So in breast cancer, we need to set the, breast cancer means hyperestrogenism. आपका PCOD hyperestrogenism है, fibroids में hyperestrogenism है, gallstones है, estrogen imbalance हो रहा है आपके body में, और इसी कारण से आपको different especially the breast cancer हो रहा है. So we need to reset. So there are so many things, मतलब जो आप daily में, our kitchen is just like a kitchen cure cabinet. तो flax seeds and dandelion leaf and roots जो हैं, sulfur rich, for example, quercetin, pomegranates, lemon zest, and shatavari. They really do wonderful in cases of cancer breast. And do's and don'ts: avoid microwave, aluminium, non-stick. As I told earlier, don't let your engine work after 8 p.m. Eating throughout the day and stomach is working throughout the day, that doesn't help in working the body properly. Then the emotional detox, I will not explain this, because जैसा हम फील करेंगे वैसा ही हम बिहेव करेंगे. जब हमें गुस्सा आ रहा होता है या डिप्रेशन होता है तो हम खाते ज़्यादा हैं. तो दिस इज़ द वे इट ब्रिंग्स अबाउट द म्यूटेशंस. सो द आसनास एंड प्राणायाम and relaxation tools, along with the resolving the conflicts, which is a very important thing, and the stress management. Everyone, we need to adopt certain tools, like I have done for myself, inner engineering from Sadhguru and other things. Asanas, really, asana and pranayam really open up so many things in your life, and these should be the part and parcel of the day-to-day life. And spiritual detox, in the terms of the meditation, it elevates your consciousness. It answers so many questions. What is wrong with you? Where am I wrong? What I have done to have the cancer? Like these things it can answer. So bhakti, developing the concentration and the gratitude. All of us should be always in the gratitude mode कि मेरे पास आज मैं यहाँ बैठी हूँ, मैं यहाँ बोल रही हूँ, आप सब सुन रहे हैं. We have got the money to treat ourselves. कितने लोग हैं जिनके पास पैसा नहीं होता है? So like that, for every step, one should have the gratitude. And then the lot of studies are being done on the circadian rhythm. Between 12 a.m. to 6 a.m., melatonin and TNF factor, they are released in high amount. Melatonin is now used in multiple problems. For example, PCOD, mein, infertility, mein, in cancer also in integrative medicine, we are using the melatonin. So these are, पहले की लड़कियों की सारी साइकिल्स जो थी अमावस्या पूर्णमासी से सिंक रहती थी. Now girls, they don't, मतलब कोई, they're so haphazard and obese, उनकी कोई साइकिल सिंक नहीं है. Now we have forgotten कि सन और मून साइकिल से हमारी बॉडी के बायोरिदम्स पर क्या असर होता है. And medical as allopathy, we are not talking about that, but everything in the planet affects us. Just to tell you कि night shift में जो काम करते हैं, they are more prone to develop the aberrant epigenetic modification, for example, hypermethylation, which can lead to the active cell proliferation and hence the cancer. And we have forgotten to use the secret power of the certain sounds. Sounds, for example, Om, that changes the whole biochemistry of the cells in the body. आपके सारा body का जो rhythm है, वो balance में आता था. Om, certain sounds were used to place the stones on the top of the hills earlier. So we have forgotten that science totally. So these are the integrative therapies which are available. I am giving high dose IV vitamin C before chemotherapy so that the patient can tolerate the chemotherapies much better. They don't require the blood transfusion, they don't require growth stimulant factors which are normally given after the chemotherapy. And these are the hyperbaric oxygen, IV ozone, they are available and they are really helpful. So just to let you know that we have got a 3,500 references from 800 medical journals which is regarding the spontaneous remission project. You can go through this, how the people, otherwise the net is also full that how people have cured their cancers. So all these factors, gut health and all those were very important. Thank you.
Thank you, Dr. Sujata. And now I request Dr. Pritha Mehra to give her thoughts, please. Thank you.
Good evening, everyone. I'm really thankful to the week for giving me this platform. I believe I'm one of the youngest presenters over here and from the homeopathic background. So I thought I'll be giving a brief about the homeopathy and how this homeopathy is being helpful in cancer care. So my presentation goes like this. So giving a brief introduction, science of homeopathy, it is of recent origin from 1796 and the founder Dr. Christian Friedrich Samuel Hahnemann. The triggering factor for Dr. Hahnemann, he was also from the medical background and he was basically from the modern like allopathic medicine. But his approach, he thought it is very difficult and he was dissatisfied with the medical practice like that time of leeching and venisections and all that. So that's why he deferred and he started doing translation of medical books. So while translating one of the books, he found that it has mentioned about cinchona bark extract, which is being used for malaria-like symptoms, which was previously called as ague. And it was written that because of the bitter taste of this extract, it can cure those symptoms. So he thought there are a lot of things, which are bitter in taste. Then why does only this particular cinchona bark extract is being used for malaria-like symptoms or for curing malaria? So that's how he started experimenting on himself and he took the extract himself in certain doses and he found that he has developed those chills and rigor like symptoms. So that's how the advent of homeopathy with the principles of law of similar, that what it can produce, it can cure as well. And the law of single remedy, that for a particular disease condition, a single remedy is good enough. And again, there was some minimum doses. It was not a physiological doses which were used by him. So that was the basic laws, that similia similibus curantur, that is like cures like. The effect of peeling an onion, you all can relate with this. When you peel an onion, so what happens? A tear starts coming out and even the running nose can happen. So the onion which can, peeling of onion can cause this or cutting the onion can cause this. So Allium sativum or Allium group of medicines, they also produce such symptoms and can cure likewise. I'm just skipping few of the slides, not to make it lengthy and because we already had brainstorming sessions since morning. The concept of minimum dose, which was verified by Anschul's law, which says that small doses stimulate, medium doses paralyze, and larger doses kill. So in other words, the action of small and very large doses of same substance are opposite in nature.
Maybe you can just focus on...
Yes, sir. I'll come to that, sir. I'll come to that. So a cancer or a malignant growth is a result of decade of malformed cellular growth. We have brainstorming on all that, even going to the molecular levels and all. And curing a cancer means a bio-traveling in the past. So cancer treatment in modern medicine, we have already discussed so much. And when we, in one of the sessions, one of the speakers has also talked that there are certain limitations which come over. Like the patient has to wait for his turn to come for the treatment or even for the tests. So in that time, mostly, or during the treatment, when there are certain complications which come up, so at that point of time, they look out for various different ways to get some results or some relief from that. So what happens, the category of patients which approach the traditional medicine or the alternative system of medicine, when they are undergoing chemo and radiotherapy to alleviate the side effects, to prevent metastasis, and after completing the treatment to avoid the recurrence or relapse of the cases. And there are certain fresh cases when they are waiting for their treatment, for their turn to come for the treatment in the allopathic system or modern system of medicine. They say, okay, they have given us 3 months time that after your turn will come after 3 months. So till that time, we want to try on the alternative system of medicine. So this is the category of patients which approach us. And again, the treatment strategy, we all are aware about the preventive and promotive healthcare, and then also about the treatment aspects. Coming to homeopathy, it has become one of the second most practiced medicine in the world and in the European countries as per WHO records. So it is the second largest system of medicine which is practiced in over 80 countries across the world. There are certain, like again, as ma'am said, that the allopathy doctors, the modern medicine or the scientists over here, they look for the evidences. So it is so fast growing, homeopathic research is so fast growing that in the PubMed, PubMed database, if you just put a word homeopathy, so there are around 9,000, more than 9,000 articles which have been already published. And if you consider homeopathy cancer, then there are around 3,205 references which have come up in PubMed database. So there are around 50 preclinical studies from 1980 to 2020 which have shown favorable action of homeopathic medicine in cancer cases, cancer treatment. And coming to the council where I'm working as a research officer, the fundamental research through collaborative and extramural research schemes, we have collaborated with these institutions, few names which I have quoted here. And these preclinical studies references regarding this, again I have placed here. So we have found that sulfur, thuja, calcarea carb, these have also helped in inducing apoptosis in the mammary epithelial carcinoma cells, and it has an immunomodulatory effect as well. Coming to the clinical studies, again there are more than 50 such clinical studies which have been in collaboration or as add-on therapy. So homeopathy has been used as an add-on therapy for certain disease conditions, for certain cancer cases. And rather all these studies, if I go through all these, so these have been aimed at palliation or treatment of the complications due to cancer or the treatment procedures, whether it is radiotherapy, chemotherapy, like that. One of the studies which we were going to initiate with GTP Hospital, DSCI, it was about mucositis, the complication of radiotherapy. In that case, again, that add-on therapy, homeopathy was, protocol has already been approved by the ethical committee of that institute. So we are looking forward to conduct that study as well. Again, to quote few additive homeopathy in cancer patient, retrospective survival data from homeopathy outpatient unit. So the survival rate in these cases has also increased. Then the classical homeopathy in the treatment of cancer patients, a prospective observational study in 2 independent cohorts. Again, the outcome over here, it has shown that there is a statistically significant improvement in the first 3 months in FACT-G, FACIT specific, and after 12 months, a further increase was found. So fatigue decreased, no change in the anxiety and depression, and FACT-G remained constant in first 3 months. After 12 months, there was a slight increase. So this improved statistical improvement in 3 months, and then further there was a slight decline. So coming to like what we can decipher out of all these studies is that definitely it has helped in reducing the disease burden to some extent, and also in improving the quality of life of the patients. So homeopathic medicines for adverse effect of cancer treatment, there are again in Cochrane Library, if we see, there is a study that homeopathy medicine on adverse effects. So no serious adverse effects or interactions were reported attributable to the homeopathic medicines used. Certain skeptical people, they had a thing that if we use homeopathy along with the allopathic system or modern system of medicines, so there can be more of adverse effects. So, but this study has shown it otherwise. There is another study, is there a role for homeopathy in breast cancer surgery? So a first randomized clinical trial on treatment with Arnica montana to reduce post-operative seroma and bleeding in patients undergoing total mastectomy. This study was also done, and the result has shown that Arnica montana 1000 K, that is the power, the potency of the medicine, could reduce the post-operative blood loss and seroma production in women undergoing the unilateral total mastectomy. So there were other studies wherein Ruta graveolens and Rustoxicodendron. So these are all the plant-based medicines which we are talking about. So in one of the sessions, Dr. Anurag has talked about the use of herbal or the plant extracts. So similar, homeopathy also has the base is from the plants, and the dosage is about that minimum dose concept and the single remedy used for a particular disease condition. So there are a few of these studies, and the outcome is that individualized, this is about the homeopathic approach for the treatment of symptoms of estrogen withdrawal in breast cancer patients. This was a prospective observational study, and the outcome of this study was individualized homeopathic medicine was given and utilized 25 remedies, which was individualized. Okay, so one patient is given a particular remedy which is suitable for that patient. So it's not about only the symptoms, it is about the holistic approach which we look at and the individualization of the patient. So there pulsatilla, sepia and sulfur were used for more than 3 occasions for first prescription, and there was significant improvement in the mean symptom score, the effect of daily living scores, and there were a significant improvement in anxiety, depression and quality of life of these patients. So coming to the way ahead, what I felt was that the concept of integrative oncology, thanks again to the Ministry of Ayush, who has introduced this Center of Integrative Oncology in All India Institute of Ayurveda in Sarita Vihar. So I was appointed as one of, or nominated as one of the nodal officers from homeopathic background, and we were attending to the cancer patients who were coming in the OPD of All India Institute of Ayurveda, and they were being referred to the Center of Integrative Oncology, wherein myself, Dr. Akila, and a doctor from Unani medicine and one from Ayurvedic medicine, we used to sit together, discuss the cases, and accordingly we used to frame what line of treatment and how that patient is to be treated. So the concept of integrative oncology, despite of limitation, when used in addition to conventional therapy, homeopathic treatment may help to control symptoms of cancer, enhance patients' well-being, even may prevent metastasis and further recurrence. The Ayush system of medicine may also integrate looking at the strength areas of each other and overcoming these limitations. Thus a combined strategy so formulated may fight cancer for maximum benefit of the patient. So the toxic, to end with, the non-toxic curative compound remains undiscovered but not undermeant. So this is one of the quotations which I really liked, so I thought I should share this with you all. Thank you so much.
Thanks, Dr. Pritha. And now I invite Dr. Akila, who is a research officer in Siddha branch of Ayush, based at Safdarjung Hospital. Thank you, Dr. Akila, please.
So good evening, everyone. And first of all, I would like to thank Father God and the Week Connect for giving me this wonderful opportunity. And actually, they invited me as a special guest. And after coming here, Mr. Ramesh, he requested me to deliver some few words about Siddha system, what you are doing in cancer. So I am not with the PPT, I'll just give the outline information about Siddha system and what we are doing in the cancer. So coming to the Siddha system of medicine, already you all aware about Ayush system of medicine. It is A for Ayurveda, Y for Yoga, U for Unani, S for Siddha and H for Homeopathy. So we are from S and we are from Siddha. Siddha is originated from Tamil Nadu. And 18 Siddhas has contributed this medicine, and Agastya is the father of Siddha system of medicine. And we from Central Council for Research in Siddha, actually under Ministry of Ayush, there are 5 councils. For Ayurveda, one council is there, and for Siddha, Homeopathy and Unani, everyone is working under Ministry of Ayush. So we are working specifically in the research part. So coming to Siddha, so already I told we are originated from Tamil Nadu, and in North India we are providing a service since from 2016. Initially it was started in Ayurveda and Tibia College, which is located in Karol Bagh. And now in September 13, 2019, it was shifted to Safdarjung Hospital. And in India, the Safdarjung Hospital, it is the only hospital which is having all the system, Ayush system of medicine. It is having Ayurveda, Siddha, Homeopathy, Unani and Yoga. And coming to the cancer part, already Madam has told that Center of Integrative Oncology, it has been started in 2017, and Integrated Cancer Care Unit we have started in 2019. And Dr. Huda sir, he is the coordinator from the Center of Integrative Oncology. It is an All India Institute of Ayurveda. And right now we are about to start a breast cancer project also. We have finished our institutional review meeting also, and we are going to start in few weeks. I would like to mention this. We are going to give Nandi Melugu, it is a Siddha medicine, basically for the stage 1 and stage 2 breast cancer patients. And coming to Siddha system of medicine, I would like to say about the COVID also. When COVID is very new to this world, actually the traditional part, we can say we are telling about the artificial intelligence, we are telling about the current trends in technology, we are speaking about the current trends in the medicine, but still our body is the same. Body constitution, right from the formation of this world until now and in future, it is going to be the same. The body, coming to the body constitution part, it is made up of only 3 parts like Vata, Pitta, Kapha. We have to tell about Vata, Pitta, Kapha. Vata is the air component, Pitta is the fire component, and Kapha is the water component. So every human is made about these 3 components only. And according to what the food we are eating and what the lifestyle we are moving, this body constituent will be triggered. So according to that, we'll have the disease. In that way, cancer will come in Kapha part. Even while for COVID, we gave Kabasura Kodinir. Why I'm telling about the Kabasura Kodinir? Because we selected the Kabasura Kodinir. From the name, you can imagine that Kaba is since COVID, it is related to the respiratory tract infection. So Kabasura Kodinir was selected, and we gave in prevention part also, treatment part also, and from our council they did some randomized control trial also. We have published in peer review journal also. So coming to the cancer also, it is mainly basically it is from Kapha disorder only. So coming to the diagnosis part, along with the modern medicine and along with the modern technology, we also see pulse diagnosis. Mainly what pulse is affected, like Vata or Pitta or Kapha. And we see urine analysis also. In urine, we have to put some sesame oil. And according to the spreading of the oil, we can judge whether the patient is affected with Vata, Pitta or Kapha. Why I am insisting about Vata, Pitta, Kapha? Because according to this only, we are going to select the medicine. According to that, which taste is needed for that patient, with which herb or metal or minerals we have to select. And coming to the breast cancer, we are going to give Nandi Melugu. I already told, it is a combination of herb, metals and minerals. There is saying in a Siddha system of medicine, if a patient comes, first we have to see, if a plant is there, we have to go to the root part. We have to give the medicine based on the root part. And if it is not sufficient, then we have to go to the other part like leaves, fruits and so on. And if it is not solved with the plant, then we have to go to the metals and minerals. So coming to the life-threatening disease like cancer, it is not sufficient with the plant part. So I want to insist that obviously we have to go with the metal and mineral drugs. So Nandi Melugu, it is a combination of herbs, metal and minerals. So scientific world is concentrating in a single compound. But coming to the traditional system, we cannot be confined with single compound. We have many formulations. We have a synergistic effect. So why I am telling about metal and minerals in this stage, because we are preparing according to the protocol which is given in the literature as per the Siddhas already mentioned in the palm script. So according to the protocol, what these scientists has told, we have to titrate if it is a metal, maybe like arsenic or maybe mercury or any minerals, we are not going to powder and just to give as of. We are going to titrate with the Satru and the Mitru drugs. Satru, you obviously know it is a friendly drug. Mitru is a friendly drug and Satru is an opponent drug. When in case of mercury, if we are preparing a medicine, we have to titrate with the Satru. So it will enhance the potential of the drugs. And it has to be titrated with the Mitru drug, which will kill the ill effect of the drug. So it will come to a good formulation. So obviously I want to tell about the herbs, metallic and minerals also. So Nandi Melugu we are going to start, and everything institutional ethical committee is over. And in Safdarjung Hospital we are running a cancer OPD every Thursday we are running. So December 2021, 16 we had inaugurated the cancer OPD. So I would like to inform you all, because if the patient in integrative oncology, in cancer population, everyone will not be willing to take only allopathy also. If the patient, according to the age, if they are not willing for the chemotherapy, if they are not willing for the radiotherapy, and if they doesn't want the surgery, obviously they are coming to the traditional part. And in this breast cancer project also, we are taking the consent. We are going to take the consent from the patient. And if they are not willing for the surgery, chemotherapy, so that patients we are going to enroll. So I want to give the information so that you can spread this awareness so that many people will be benefited from Siddha system of medicine also. So thank you for giving me this stage. Thank you.
Thank you so much for that insightful discussion. I would request, so I want you to stay for your certificates, and Dr. Akhila, yours would be prepared later because we just invited you right now. I hope you understand that. So, yeah, please go ahead.
Yeah, hello.
Ma'am, I want to know your take about the plant protein, the soya protein, because it is known as the phytoestrogen, and its role as a plant protein and as a role in cancer cure. Soya protein. Your take on soya protein?
Yeah. See, the main problem with all food is that it is genetically modified. Okay. So organic soya, although the government of India says कि उन्होंने इसमें soya के अंदर genetically modified seeds नहीं है, but as per discussion with the farmers and have talked, they have got genetically modified seeds, and it is a phytoestrogen. So soya जो है breast cancer के लिए तो नहीं लेना है बिल्कुल भी. And there is a protein mania in allopathy. ठीक है, allopathy बहुत proteins and proteins create an acidic environment in the body. And we try to balance the holistic approach, in the integrative approach में we try to bring the balance, मतलब जो हमारा normal pH है 7.4 पर लाने की कोशिश करते हैं. So soya proteins I don't recommend. We don't recommend.
It's an absolute no.
Absolute no. Especially in breast cancer.
Okay, ma'am. My second question is the role of antibiotics to tackle with the free radicals. Anything you want to?
Role of antibiotics?
Role of antioxidants to tackle with the free radicals. Antioxidants. To erase the free radicals.
Yeah, antioxidants is highly recommended. Okay, because especially you are asking for breast cancer or for every cancer?
Yeah, breast cancer.
It is highly recommended. It is highly recommended. That is why the supplements, that is why we are asking.
In the form of supplements or in the form of food?
Both. And but see the demand in the, once we are having a cancer or anyone, the demand in the body increases. And once we are taking the allopathic treatment in the form of radiotherapy, chemotherapy, the generation of the free radicals is very high. So in order to contract, there are a lot of studies now available which says that the supplements and antioxidants. So just by taking food, it won't suffice. So in the form of supplements, they are highly needed.
Okay.
मैम अगर
Thank
आपकी
you.
गौशाला हो और अपनी गौशाला हो पर्सनल या किसी नोन की, जैसे ना जैसे कहीं वो गौशाला होती है इस्कॉन टेम्पल की वो सब, जिसमें वो लोग सिर्फ घास खिला रहे हैं और खली वगैरह दे रहे हैं, कोई और एस्ट्रोजन कोई इंजेक्शन नहीं लगा रहे, तो उसमें क्या आपत्ति है? वो दूध ठीक है कि नहीं?
सी मिल्क जो है ठीक है,
आपने मिल्क का बता के डरा दिया हम लोगों को.
It is a whole food itself. There's the other problem which is faced is that today we are not working so hard. उस प्रोटीन्स को पचाने के लिए आपको उतना पहले जो विमेन थी इतना काम करती थी, डिलीवरी के बाद 10 किलो घी खाने के लिए दिया जाता था. वो मना ही नहीं है, आप उतना काम करो ना, कोई प्रॉब्लम नहीं है. वंस यू टेक द मिल्क, आप फिर उतना काम भी करिए, बॉडी को उतना यूटिलाइज भी करिए. अदरवाइज द प्रोटीन्स, अगेन द एक्सेस ऑफ द प्रोटीन विल कॉज द एसिडिक एनवायरनमेंट इन द बॉडी. द मेन प्रॉब्लम जो आपने बताई वो तो अगर वो हट जाती है तो इट्स वेरी गुड, इट्स वेरी गुड. There's no problem, but then you should use the body also.
Antioxidants in cancer, over here. The story is really very complicated. One of the most famous trials in COPD, जहाँ लोगों को lung cancer हो जाता है after smoking for life. They thought giving antioxidants is a good idea. It's one of the first trials where they clearly saw intervention arm had more lung cancer than the non-intervention arm. And the logic was also actually quite simple later on. They find even for a cancerous cell to commit suicide, उसके लिए भी oxygen radical generate करने पड़ते हैं. And antioxidants cannot distinguish between things the body wants to kill versus others. So we need to be a bit careful on the antioxidant story. It's not a blunt force instrument. The body uses it as scalpel. And so one must be careful for large doses, at least in the area that I know well, that is lung cancer, where the biggest trial of antioxidants was clearly negative in the opposite direction.
There are a lot of trials also where the role of antioxidants have been proven to be beneficial. Of course, ऐसा नहीं है कि एक ही antioxidant सबके ऊपर fit हो जाता है. So similar thing happened with the high dose IV vitamin C. Mayo did the trials, and high dose IV vitamin C they gave the oral form 10 grams. Although the Linus Pauling ने जो trials किए थे वो IV वाले थे, and I'm giving patients all over are coming taking the high dose vitamin C before getting the chemotherapy from the prestigious corporate hospitals. So and they are मतलब मैंने बताया ना उनको स्टेम से कुछ भी ब्लड तक की नहीं. अगर हम एलोपैथिक डॉक्टर आई वाज इनिशियली टेलिंग कि नहीं आपको सारा बॉइल्ड खाना खाना है. दोज हु आर टेकिंग द डाइट कंसल्टेशन फॉर द डाइट दे आर टेकिंग स्मूदीज. पूरी कीमोथेरेपी फुल फ्लैजेड कीमोथेरेपी के बाद दे आर टेकिंग ऑल स्मूदीज एंड ऑल रॉ एंड दे आर डूइंग मच बेटर. सो व्हाट वी there are so many things in the trial also. We know how many things are done in the trials and how the holistic medicine is being suppressed in so many cases because it is a pharma. We know this thing very well now that is a nexus between the pharma companies, politicians and the media, the way things move. So there's no point in discussing this much.
I think Dr. Mittal, your presentation definitely has triggered a lot of thoughts and questions.
I'm so sorry.
We will have our tea break very soon. Please feel free to take this discussion further. But in the interest of time, right now I'm just going to request Mr. Atul Arora, General Manager Marketing, The Week, to hand over the certificates to the panelists. Dr. Sujata Mittal, thank you. And Dr. Preeti Mehra. Thank you. Thank you very much. Moving on, our next panel discussion is on issues of survivorship, quality of life, and care after the breast cancer. I request our panelists to join us on stage. Dr. Anita Dhar, Professor, Department of Surgical Disciplines, AIIMS, New Delhi. Ms. Renuka Prasad, Secretary, Indian Cancer Society, Honorary Secretary. Dr. Ravi Mehrotra, Director, Indian Cancer Genomic Atlas, Indian founder, Center for Health Innovation Policy Foundation, India. Giving a brief introduction of Dr. Anita, she's already been on a panelist earlier. She's a professor at Department of Surgery, AIIMS, New Delhi, and has over 32 years of extensive experience in breast-related surgery and is actively raising awareness related to self-breast examination. Dr. Renuka Prasad, an alumnus and life member of American Cancer Society. She has over 25 years of experience working in the social sector with the oldest cancer-related NGO in Delhi, Indian Cancer Society. She joined the NGO once her treatment of breast cancer was over. Currently, Honorary Secretary of the Indian Cancer Society, she looks at cancer awareness, screening navigation for patients, providing emotional support, raising funds for their medical aid, looking at their rehabilitation policy apart from many other responsibilities. She has organized and attended innumerable conferences, seminars in national and international fora. Dr. Ravi Mehrotra is one of the directors of India Cancer Genome Atlas and founder of the Center of Health Innovation and Policy. He holds adjunct professorships at the Emory, Brunel, and York universities. In addition to Armed Forces Medical College, he has trained at the Royal College of Pathology, London. And I request Dr. Ravi Mehrotra to take this on.
Thank you.
Thank you.
It is not an easy job to hold the audience at about 5 in the evening, and that too before a cup of tea. So we will try and make it as interesting, short, snappy, and interactive as possible. Scars of breast cancer in India. Talking about survivorship, ये एक बहुत ही मुश्किल सा सब्जेक्ट हम लोग को दिया गया है, बट मेरे समझ से सबसे अहम है, इसकी इम्पोर्टेंस सबसे ज़्यादा होनी चाहिए, क्योंकि हम लाख कह लें कि we can prevent all cancers, but breast cancer is not one which can be easily prevented except in a small number. जिसको हो जाता है उसकी जर्नी जो होती है, उसका जो आगे का रास्ता होता है, वो आसान नहीं होता है. उसमें किस तरीके से हम लोग योगदान कर सकते हैं, उनके ट्रीटमेंट, उनके फॉलोअप और आगे की ज़िंदगी के लिए ये सेशन उसके लिए रखा गया है. तो पहली बात तो मैं आभार व्यक्त करता हूँ वीक और अपने दोस्तों को जो कि इन्होंने आज हमको ये मौका दिया है for to conduct this session, which is I think one of the more important sessions, even though I say myself. We have Mrs. Renuka Prasad, जिससे अभी इंट्रोडक्शन हो चुका है, वो खुद एक ब्रेस्ट कैंसर सर्वाइवर हैं. तो इससे पहले हम और कोई सवाल जवाब करें, मैं उनसे रिक्वेस्ट करूँगा कि पहली बात तो अपनी जर्नी के बारे में बताइए और रोल ऑफ नॉन प्रॉफिट्स और नॉन गवर्नमेंटल ऑर्गेनाइजेशंस के बारे में बताइए, वो और उनका ऑर्गेनाइजेशन और उसके सिमिलर ऑर्गेनाइजेशंस कैसे हमारे इस सर्वाइवरशिप के स्टोरी में योगदान देते हैं.
पहले तो I must thank the week for inviting me here and having me here. I feel very happy to come to these kind of forum, basically to be able to convey something about the NGO with which I'm working and associated with for the last 25 years. And let me tell you that my coming into this NGO, ये बिल्कुल एक इत्तेफाक ही सा था, क्योंकि when I had breast cancer, जब मैंने अपना वो स्कार देखा ना, तो बस उसमें तो मैं बिल्कुल ही टूट गई.
मैं अपने आप को संभाल नहीं पाई। हालांकि मैंने पूरी सर्जरी वगैरह के दौरान कुछ घबराहट नहीं दिखाई, मगर उस वक़्त तो मेरे को समझ नहीं आ रही थी कि मेरा खाली स्थान जो दिख रहा है मेरे को शीशे में, ये किस तरह से भरेगा, किस तरह से मैं फिर एक औरत की तरह महसूस कर पाऊंगी। That was my biggest worry, and my doctor solved it by saying that somebody will visit you and tell you something about it. And I had a lady from Indian Cancer Society who was working in the R&R, doing voluntary service, and who came and met me and said, तुम इसी एक छोटी सी चीज़ से घबरा रही हो, इतनी भगवान ने तुम्हें ज़िंदगी दी है, आगे तुम्हें आगे भी जीना है, ये तो कुछ भी चीज़ नहीं है। उसने दरवाज़ा बंद करा, फटाफट अपना ब्लाउज़ खोला, ब्रा खोली और निकाल के प्रोस्थेसिस मेरे को दिखाया कि बेटे ये लगा लो और सब कुछ भला चंगा हो जाता है, सिर्फ तुम्हें ही पता चलेगा कि देयर इज अ स्कार विद यू, किसी को नहीं पता चलेगा। So that was the motivation to get to the NGO, and I'm really passionate from the bottom of my heart about helping other women also to come to terms with breast cancer, because it's a very devastating thing. It's something जो कि organ एक बाहर है आपके, जो दिखता है, नजर आता है. It is the epitome of womanhood for women. And without one breast and thinking only one is hanging there and there's a gaping hole at the other side is abhorrent. It is really bad. But of course, we've got over it. And so many of my colleagues in my own organization are all breast cancer survivors, or they've survived other cancers and are fighting fit along with me. So as they say that today we are going to be talking about the scars of breast cancer. So from every wound there is a scar, and every scar tells a story, and a story that says, I survived. So I see that scar every day, and I feel happy that I have it, because it's showing me that I have survived, I'm alive and kicking, and seen my family grow, seen my 2 young children at that time, not settled, today settled. I have grandchildren. I'm a happy and a very contented person.
Well said.
So, thank you so much for this. This brings a lot of, emotions back, but I'm happy with whatever I went through. Maybe I was a chosen one to come and do this work to help out other women around. How much I've helped, I really can't say, but I, within me, have a sense of satisfaction.
Thank you so much, Renuka ji. Lived experience, and for us who have not had that trauma, it is difficult to imagine, but you expressed your words very, very clearly. And I'm sure हमारे audience में ऐसे बहुत से लोग होंगे who can relate to it very, in a very intimate fashion. And this is the kind of thing and kind of hope that we hope this particular session will be able to discuss a little more. Thank you so much. Next is Dr. Anita Dhar from the AIIMS Breast Cancer Unit, a professor and director. Would you like to talk about, in your experience dealing with so many hundreds, thousands of women over the last so many years in your practice, how have they handled issues of survivorship? What are the main taboos or main blockages that you have found, and how they have overcome them?
I'll start with a simple experience. Once I entered my OPD and I saw one of our staff. She has been a day sister who has worked for many years in the ward and seen few cases with us, and she was sitting in OPD and almost in tears when I opened the door, and she's sitting in the OPD room and she started crying. Being an experienced staff inside the hospital who has seen and experienced and seen these cases when at a very close quarter, she said, मैंने कल मेमो कराया and गड़बड़ है, कुछ है, and I have been crying the whole night. अभी कुछ नहीं है, दिस इज एन इमेज इन हर हैंड, और कुछ भी नहीं पता उसको. द स्टेट ऑफ माइंड वॉज पैथेटिक. शी वॉज एट द लोवेस्ट ऑफ हर. शी इज वेरी ब्रेव, very active otherwise. And I sent her to the department. I said, look, there's nothing. It's just an image in your hand. And abhi tak to report bhi nahi aayi hai. हाँ वो तो है, but then मैं क्या करूँ? मेरे को तो पक्का लग रहा है कि कुछ गड़बड़ है. So in next half an hour, I actually put her on priority and I requested one of my colleagues, kindly have a look at her. मैमो नहीं था, कुछ फील किया था उसने. So फटाफट मैमोग्राम करवाया, वापस आई. It was, my OPD was still running. Now she's just laughing. She is only laughing. So it was like from that Roni wali सूरत से now ulta, happiness and laughter. She said, सब ठीक है. So this is a mindset of a person who has seen such cases from a very close quarter and experienced them. And what about people who already have it on them and they run through, as I said, from image itself, when they are exposed to a mammogram and some doubt has been raised without a biopsy, they have a bad time from that biopsy time to the report. होगा नहीं होगा, उसके बाद क्या होगा? Having heard many stories that उसके बाद कीमोथेरेपी मिलती है, फिर बाल भी जड़ते हैं, फिर क्या करूं, कैसे जीऊं? They are not thinking about per se about death immediately, but immediately is chemotherapy, उसके bad effects, surgery, and ultimately end point ये होता है. So as I put it, whenever the cancer word comes to anybody's thought, it's put as equal to death. This is the common society thought. The word goes is equal to death. अब तो खत्म कहानी, अब तो और कुछ नहीं होगा. We know now, we have been listening the whole day now, that things have progressed and we're talking about बहुत ही lowest level पे, molecular level पे आजकल management की बात कर रहे हैं. तो death तो immediately नहीं है, but survivorship है, and उस survivorship में बहुत pain भी है. कई लोगों के पास तो कुछ पैसे भी नहीं होते हैं घर से अस्पताल तक आने के लिए. कई लोगों के साथ साथी नहीं होते हैं to accompany them and be sharing their pain and finishing their complete treatment. आधे लोग छोड़ के चले जाते हैं, ट्रीटमेंट भी नहीं पूरा कराना चाहते. Then the monetary part, it's again a pain. I know of another patient, she comes from Faridabad. She is a single mother now, husband has died like few years back, and she has a son who is mentally retarded, and she has to take care of her also, him also, and come to hospital for regular checkups, for radiotherapy and all. I can see that pain. Money is a big issue. We don't have many organizations in the society who raise funds for such people. There are certain small number of government organizations where the approach itself is so difficult and they have few drawbacks, certifications and all. Not many people have certificates of very poor nature, though now the government has come up with PMJ cards and all. It's a big relief. I can see people now getting a lot of interventions done based on those.
So basically the
yes, it's
Ayushman
helping a
Bharat
lot.
and PMJY have helped.
It's helping a lot. But at the same time, there is another parallel group. They don't have these cards. They are surviving at their own level with a very... So we should have some fundraising for such patients.
So it is basically the middle class who don't have those cards.
Yes.
But who are not
But
really,
they are not very much
not very affluent.
monetarily happy.
It's the one that is just above the poverty.
Correct.
You know, school teachers.
एक BPL होता है, एक APL होता है. So APL is the problem.
So fundraising is very important. That can be, if through this forum we can talk about developing some sort of a fundraiser and all of us coming together for such a happening.
Thank you, Anita ji. Now what we would like to do, as a panel we decided that we would like to get questions from the audience. Ideally, we would love to hear from people who have lived with cancer, have beaten it, and now are leading a good life as a winner of cancer, if I may say so. So I would request, yes, mic de denge, please. And I will try and get the panel to opine on what you ask. And if we don't...
So a breast cancer survivor. And I also ignored myself in the beginning and a little spoiled my case when I came to the hospital. But now, it is now more than 25 years I am survived. But we are all talking about the physical things, scar on the body, and the financial thing. One thing I would like to talk about financial thing, the slab for poverty given by the government, so many schemes are very unrealistic with reference to today's scenario. If we say if somebody earns less than 8,000 rupees per month is a poor person. But these days even a sweeper earns more than 8,000 rupees. So it should be raised. So it is very unrealistic. So most of the people cannot take advantage of these schemes. I would like to talk about the scar on the psyche of the woman. She not only thinks of the physical scar, which can be hidden with the use of bras and prostheses, and the society wouldn't come to know of it. But the people who come to know of it look at her at a bechari, iska kya hoga? And then she would always think that whether my husband says or not, but there must be some change of attitude in his mind. Even if he tries his level best to console her, that the relationship remains the same. And outwardly they may not express it, but it is somewhere deep down in her heart is always there. And then if a woman is young, still wants to have children, and she is always worried whether she would have baby or not later on. If she is unmarried, she thinks whether she would get married or not. If she has a daughter, she is worried, what about my daughter? What would happen to her? Who would marry her? And all these issues are also there that leaves a big scar on her psyche, you know. And I have an experience, the patient of Dr. Anurag Srivastava and Dr. Anita Dhar. She, long back, I think 15 years back, the girl, when she was only 6 years old, she had cancer on her this shoulder. And when she grew up, that side of her breast never developed when she became teenager. And when she was 22, 23 years old, she developed breast cancer on the same side where there was no breast at all. She had only one breast. It never developed. And then she always had to keep herself covered. She couldn't use jeans and frocks and dresses like that. So she was very upset with her life. She got treated at the age of 6, 7, and now she was 23, around 23. Then she came to me. She used to come to me, call me her mother and all that, you know. And when the treatment was over, and when we gave her bras and prostheses from Indian Cancer Society, she was very happy. She started getting Western dresses and all that. But then she was worried about her marriage. She started working, but happily enough, she met a boy. He accepted everything. He came to us. He talked to us. We said it's all okay. Now she has got a daughter. Her daughter is also now 7 years old. So she is very happy. So such stories also happen.
So this is the kind of real-world experience we are looking forward to hearing. Thank you so much.
Then there are, you know, cognitive issues. Memory loss हो जाता है बीच-बीच में. उसको करना है वर्क स्किल
वो तो एक मेरा होता है, तभी मेरे को कागज में लिखना पड़ता है,
भूल जाता है,
बिल्कुल लिखना पड़ता है, मैं भूल
जब
जाती
आप काम पे जाते हो आपका वर्क जो वो भी सफर करता है, you know, in office also you are not as efficient as you were before that, you know, and so many issues are there. वो ये कहते हैं ना कि जैसे अमृता प्रीतम ने कहा कि जिनके पास फिजिकली सब कुछ होता है उनके हाथ से बाहर नहीं होते, उनके दिल की जमीन पर हाथ से होते हैं. तो ऐसा है.
Thank you so much. That is a very good note to end on. I'm sure we have other folks who would like to express their opinion briefly. I would request you to be kindly as short as possible. If there are no questions, can we go to the second slide, please? Next. So this is a chronic problem. Attrition या loss to follow up after treatment due to high out of pocket. India has among the highest out of pocket expenditures.
Like if I live in South Delhi, I should have full-fledged facility in and around my area, complete, I should say. But if I live in some remote area of Bihar or somewhere, I don't have a facility there. I have to move out to a main city. So which is that main city? I keep on interacting with patients. Now that AIIMS Patna has come up, I keep on asking them, why are you not going there? Why are you still coming to Delhi? They said, what difference will it make? Now, problems are much more if we go to AIIMS Patna. We have to move out of our place, which is XYZ kilometers away from AIIMS Patna, and come to city, Patna. Then find a place to live and survive. Now what they do, they sit in the train and come to Delhi, where they already have some relative and a place to live. They just have to walk in that place and come to the hospital, which is an easier and better proposition rather than their own state, which is maybe 300 kilometers away.
But unfortunately, not everybody has that facility
Now,
to go.
what happens with that? If 50 people come from a far-off place where some sort of a facility is already existing, but they are pushing away cases who were in and around AIIMS here, the crowd increases. So gradually people realize that धक्के खाने पड़ रहे हैं, daily wages, lot of relatives, son, daughter, father, whatever is, whoso is accompanying person, they may be working in a private sector where every day is accounted. The daily wages are accounted for, they have to give signatures. It's not a government organization. At the end of the month, they will get a salary. So every day, every hour matters for them. Where will the money come for the treatment? And if they are not supported, funded by someone, and the hospital is not supporting, all these complicate the treatment.
It actually lands up in catastrophic financial toxicity.
So they manage to come for a few months, but after some time,
after 2 to 3 months, the money finishes.
They may manage to get the initial part of the treatment, but then they realize that, okay, main part is done, and ab to ho gaya. They ignore the instructions given by the service providers, and
they land up in the same soup. Yeah, thank you so much. It's very unfortunate, but that's a fact of life. Can we have the next question, please? Excellent question. How to curb it?
So we all belong to this system. So I am a firm believer, if I am here, if my surroundings are taken care and I manage to help somebody around me, these small units cumulatively will improve the society. So it's not coming on the dice and giving a bhashan. So every one of us can be of some sort of a help in and around us. Let's not close the eyes कि उसकी प्रॉब्लम है, मेरा तो कॉलेज जाना है, मेरे को तो दफ्तर जाना है. We will be sorted out. So let's come forth and help that. सिर्फ अपने ही दायरे में अगर हम help करना शुरू करें, if you are capable of, I'm not telling it to everyone, if you have a capacity to do that, please come forth and help.
यही मैं आपको बताती हूँ.
All these small units together, this is part of the society.
So, बूंद बूंदे से बने सागर, right?
So आपके helpers, for example, अगर आपके घर में कोई आ रहा है, don't ignore. Come forth and help them. Maybe through your association with someone and all, you can do some networking and put them on the track.
Thank you. So ये कहना कि ये सिर्फ सरकार करेगी, उससे शायद काम नहीं बनेगा.
नहीं, आप सही कह रहे हैं जो आपने पहले कहा था about the NGOs. The NGOs are supposed to do a lot of work related with this. थोड़ा सा survivorship problem वो solve कर सकते हैं. Support groups बनते हैं. Support groups मिलते भी हैं और online भी बातें करते हैं. डॉक्टर साहब खुद ही हमारे ग्रुप्स को एड्रेस कर रहे हैं और भी डॉक्टर्स को हम बुलाते रहते हैं, क्योंकि डॉक्टर साहब तो सिर्फ ब्रेस्ट कैंसर के बारे में उनको जानकारी देंगे, और भी जो प्रॉब्लम, मानसिक प्रॉब्लम्स उनको आ रही हैं, सेक्सुअल डिसफंक्शन जो उनका हो रहा है, जो ऑल दी अदर प्रॉब्लम्स दैट दे आर फेसिंग, they are able to solve it, because we do try and get them online, and online today is a very common thing for them. Even the classes, school classes for the children are being run, so every family at least has one phone between themselves to be able to listen and come to the support group meeting and ask questions. And we've seen now how these support groups are going, especially our breast cancer ones. Rekha Gulabani here from Indian Cancer Society has one on a WhatsApp group. So on the WhatsApp, they're asking each other questions, and some she answers, and some they themselves are able to answer each other. They are able to help each other. So if they are able to help each other and come to terms, if not through a medical intervention, at least from the intervention of another companion, another friend who has been through similar problems, they are relieved a little.
And at times the peer-to-peer conversations are so much more practical and listened to rather than a doctor to a patient.
Absolutely.
And they can identify with the other individual, and hopefully tailor-made solutions may be there which they can apply to their own situation.
So
next question is basically looking at psychoeducation. आपने कहा body image, behavioral adaptation. So what can be done to improve and strengthen? एक तो आपने support groups की बात करी है.
So see, the other thing is that that will have to be a localized thing. That when you are doing other kind of work for their mental health, you know, for things for them to be able to improve their various other facilities. They have, especially the MBC patients, the metastatic breast cancer patients, they've lost interest. They have no hope in life ahead. So the aim is to try and ignite that life within them. So we organize makeovers with good fashion people out there, organize things like maybe a fashion show or just a complete makeup being done for them, and they enjoy it. They are happy to be able to spend that time in fun. So you have therapies there like laughter therapy. For that, at least half an hour, 45 minutes to an hour, when they're going through the therapy, they've forgotten what they were going through, and they are happy. And we've seen today the emphasis that has been laid on happiness. मन की खुशी, अंदर की खुशी बहुत बहुत जरूरी है.
हालांकि मुश्किल होता है. जब आदमी बिल्कुल ही टूटा हुआ होता है, डूबा हुआ होता है, बहुत मुश्किल होता है. बट अगर लोग साथ में करेंगे तो ऑटोमेटिक एक दूसरे से एक तरीके से एनर्जी का ट्रांसफर होता है.
डिप्रेशन भी थोड़ा दूर होता है. ठीक है.
जी जी, आपने पीयर नेविगेशन की बात करी. जी जी बिल्कुल. अनफॉर्चुनेटली जी, अब बिल्कुल सही कह रहे हैं. तो ये सब सर्वाइवरशिप के छोटे छोटे नुस्खे हैं जो कि अनफॉर्चुनेटली देश के बड़े शहरों में तो मिलते हैं. अगर आप थोड़ा इंटीरियर में जाएंगे तो इसकी मात्रा कम हो जाती है. तो हम लोग चाहेंगे ये डेमोक्रेटाइज हो. और जगह भी आई एम श्योर ICS के और ब्रांचेस हैं, बट और भी बहुत से ऑर्गेनाइजेशन हैं जो काम कर रहे हैं. जी जी, they are your best ambassadors.
Best ambassadors, best ambassadors.
Word of mouth publicity से उससे अच्छी नहीं हो सकती है. बिल्कुल. तो इसी तरीके की सक्सेस स्टोरीज मैं चाहता हूं और लोगों को भी मालूम पड़े. जी, थैंक यू. नेक्स्ट प्लीज. Can I have the next question, please? हम लोग स्टिग्मा की बात कर रहे थे. रेणुका जी, आपने बताया और डॉक्टर ने बताया कि किस तरीके से कल्चरल और सोशल स्टिग्मा होता है, डॉक्टर अनीता ने बताया था। आपने फेमिलियल डिस्टेंसिंग की बात करी, स्पाउस से इश्यूज की बात करी, सेक्सुअल डिसफंक्शन या रियल या इमेजिन दोनों ही चीज़ें हो सकती हैं, और सोशल आइसोलेशन। एक अक्सर दिक्कत आती है स्पेशली लेडीज़ हु आर मे बी इन द 40 and 50 हु हैव अ गर्ल चाइल्ड कि भाई अब मेरी लड़की से कौन शादी करेगा। इसके लिए हम लोग क्या कर सकते हैं, क्या इस बारे में कोई बताएगा मुझको?
इस बारे में तो क्या बताएंगे, मगर वही बेसिक बात है कि नुक्कड़ नाटक करें, दिखाएं, बच्चों के थ्रू दिखाएं। स्कूल के बच्चे होते हैं जो कि ये नुक्कड़ नाटक करके झुग्गी झोंपड़ीज एरियाज में जाते हैं, वहाँ वो ढोल डाम बजा बजा के इकट्ठे करते हैं लोगों को और उनको बताते हैं ऐसे सोशल इश्यूज के बारे में। वो कुछ पोर्ट्रे करते हैं कि कैसे ये स्टिग्मेटाइजेशन निकल जाना चाहिए। ये सब पुरानी बातें हैं, अब नए तौर तरीके अपनाओ। जो हो गया सो हो गया, मगर ये ज़रूरी नहीं है कि इनको हुआ है तो इनकी बच्ची को भी होगा, कोई ऐसी बात नहीं है। तो ये सब चीज़ों से इसी तरह से ये लोग कर सकते हैं। मगर वो पहले तो पंडित जी को मोटिवेट करो उनको, फिर पहले तो उन्हीं को ही समझाओ।
नहीं, आप गुरुद्वारे में जाके शादी करो ना, वहाँ पंडित जी का कोई सवाल नहीं होता, ना डेट निकालनी ना कुछ निकालना है। और ऐसे चीजें दिखाएंगे फिल्मों वाले तो लोगों को समझ आएगी। नुक्कड़ नाटक से तो एक छोटे से एरिया में हो।
सोशल मीडिया
इज वेरी इंपॉर्टेंट।
वही थोड़ी है और
आपस में
नो, there are many actors still there. They are not only 4 or 5 who can do this job. I think we have very good actors now on the OTT platform also we can see. So I think they should come forward.
Thank you so much. I hope instead of making money from gutka, they can do this. Yes.
See, we do have programs. We do have programs, but they are.
Ma'am, I am saying it. You all senior doctors come on screen on daily basis around.
Daily basis.
It's like an ad. Madam, वो tobacco के लिए if they can come.
Daily basis पे कर सकते हैं कुछ. Yes, ma'am. Let's raise funds for that. जो ये advertisement पूरा time run करते हैं TV channels के ऊपर, they pay channels. Similarly, we can have short films and pay the channels and run them.
Actually,
things are possible. We can have short films, a reminder. 2 news के बाद एक छोटी film दिखाई जाए.
Can I suggest something actually? See,
Mr. Ramesh.
Yeah. Solutions, the problem is there are a lot of drug companies in this country actually. They are making a lot of money here. Nobody is trying to do this job. They have money actually to promote at least awareness. You tell me any of the drugs
do they want to? That is the question.
They don't. That's what I'm trying to do. There, I think the doctors, professional like you, should tell them, okay, if you don't do it, we are not interested. To at least take your drug. Now, see.
Can you give a mic there, please?
So that's what I have to say, I think.
No, I agree in an ideal world, but unfortunately we don't live in an ideal world. But yes, things are changing. Hopefully they will improve with time. Maybe sooner, hopefully sooner rather than later. Yes, sir. बताइए.
मैडम के मैं विचार से बिल्कुल सहमत हूँ और ये संभव हो सकता है.
क्या?
कि जितने भी सैटेलाइट चैनल हैं उनको अपनी पर्सनल प्रमोशन एक्टिविटी के लिए 2 मिनट मिलता है. अगर वो हमको 30 सेकंड देते हैं तो हमारा ये काम हो जाएगा. इसके लिए मैं काम करने के लिए मैडम के साथ तैयार हूं. और भी कोई तैयार है तो हाथ खड़ा करे.
वेरी गुड.
बिकॉज आई एम अ मीडिया पर्सन, आई एम वर्किंग ऑल मीडिया हाउसेज, तो आई नो इट्स अ 10 + 2 मिनट.
इस सेशन के बाद हमसे मिलिएगा.
बिल्कुल सर, थैंक यू.
नेक्स्ट क्वेश्चन प्लीज, इफ एनी. अगर और कोई किसी को सवाल पूछना है या कोई कमेंट बताना है तो बता दीजिए.
मैं एक सजेशन करना चाहूँगी कि मीडियाज में जितने भी, सॉरी आई एम स्पीकिंग अगेन एंड अगेन बिकॉज आई एम गेटिंग आइडियाज, क्योंकि सारा जो मीडियाज है वो बहुत नेगेटिव है. जो बुरा होता है वो ही दिखाते रहते हैं, जो अच्छा होता है वो कोई नहीं दिखाता.
बैड न्यूज सेल्स.
हाँ, तो ये उसी में क्यों दिखाते हैं? अगर हमारे पास, हम जब हॉस्पिटल जाते हैं, मुझे पता है कि अगर वहाँ 1000 पेशेंट्स आते हैं तो उसके अंदर 800 हस्बैंड्स अच्छे ही होते हैं. वो जब 20 बुरे होते हैं, उनके उसके हस्बैंड को छोड़ गया, उसको तलाक दे गया, अब वो उसको इल ट्रीट करता है, वो स्टोरीज हम सुनाते रहते हैं क्योंकि हम उसकी कहानी सुन के दुखी होते हैं. और जिसका हस्बैंड सपोर्ट कर रहा है उसकी हम बात नहीं सुनते.
आप बिल्कुल सही कह रहे हैं, वही चीज बार बार बोली जाती है.
वेरी ट्रू. ये तो बिल्कुल
ओनली नेगेटिव थिंग्स वी आर पिकिंग अप. हम उन पॉजिटिव लोगों की स्टोरीज क्यों नहीं सुनाते?
पॉजिटिव नोट हुआ कि बहुत सपोर्ट मिला, बहुत आराम से जिंदगी कटी, उसमें नई
लोग
बात
सुनना
क्या है?
नहीं चाहते.
वो तो होना ही चाहिए.
तो हमें कैंसर की सक्सेस स्टोरी सुनानी चाहिए ना, ताकि लोग मोटिवेट हो के इलाज कराओ.
I think that's a very valid point. Is there any other question? Then we, or else we can wind up.
Yeah, I think it's going pretty.
Right. Thank you so much. We are holding back for the next session, I guess.
Yes.
Thank you so much for your very kind attention.
Thank you so much.
It's been a
Thank you so
pleasure.
much.
You stay because I think are you for the.
Renuka ji, 1 minute.
Yes, ma'am. हाँ, you received आपके लिए certificate if you can say. हाँ, आपका हो गया. So I'll request Mr. Anuj Mathur, Senior Manager the WE, to hand over the certificate of appreciation to Ms. Renuka Prasad. Ma'am, something I have to tell you personally. Your story brought emotions to me because just last year I lost my Masi to breast cancer.
I think there's hardly a family that's not been touched.
Yeah, so when you were saying even scars bring, those memories come back, I was also very emotional. So it's very touched. Thank you for your contribution. Now we move on to our last panel discussion, which is on the way forward, and I request Professor Anurag Srivastava, Chief of Breast and Endocrine Services, NIMS, Jaipur, Professor Anurag Agarwal, Dean Biosciences and Health Research, Ashoka University, Dr. Shekhar Kashyap, former Head of Department of Cardiology Research and Referral Hospital, Army, New Delhi, and Professor Chintamani, in charge Department of Breast and Endocrine, Safdarjung Hospital. So you can please be seated. I'll just give introduction of Dr. Kailash Shekhar Kashyap. Dr. Colonel Shekhar Kashyap is a clinician, interventional cardiologist, and an academician with over 40 years of experience. He has served as professor of cardiology and medicine in the universities across India. His current preoccupation is to help propagate easily implementable, evidence-based, therapeutic, and behavioral interventions for prevention and reversal of diseases at the intersection of their genesis at the root causes at molecular and cellular levels. These include tobacco, alcohol, and nutrition-related lifestyle modifications at household and community levels. An alumnus of the prestigious Armed Forces Medical College, Pune, All India Institute of Medical Sciences, New Delhi, and University of Rouen, France. So now I would request Professor Chintamani to take on. Just way forward. So, I mean, actually anyone can. It's not necessary. It's a...
Okay. I have few slides. So. Thank you. Fag end of the day, and I'm sure you had a great time. The last session was very exciting. And you were talking about making a film. We are making a film. And you're welcome to watch it when once it is done. And that film is about actually a cancer. I don't call them survivors, I call them conquerors. So it is actually a conqueror story. So that much for the film that you were talking about. और बाकी आप लोग जो पूछ रहे थे कि ये कैसे उनको हम मोटिवेट करें कि वो भाग ना पाएँ, तो एक चीज़ हम कॉमनली करते हैं. मेरी ओपीडी के दिन जो ब्रेस्ट क्लिनिक होता है, उस दिन जो पुराने पेशेंट्स होते हैं उनको और नए पेशेंट्स को एक साथ हम बुलाते हैं. So they talk to each other. There's no better support than somebody who has already survived it and has conquered it to give that kind of an advice. Now, I am expected to sum it up and probably talk about the way forward. The way forward is, there are just too many things that we can talk about. So I think I'll start with Colonel Kashyap as to how does he look at it and how does he think we should be moving forward, and what are his views on all that he heard today, and what does he see? Is there any light at the end of the tunnel, and hopefully not of a running train?
Good evening, everybody. I'm sure you all must be wondering what is a cardiologist doing over here. And it may appear that these two fields are vastly removed, but it is not so. To give you a background, that most of the risk factors which lead to genesis of cancer, cardiovascular diseases, diabetes, and other NCDs are common. Only thing is they announce themselves at different stages in life. So much so that almost 20 years ago, 2004 to be precise, American Cancer Society, American Diabetes Association, and American Heart Association came together and issued a collaborative scientific statement for combined risk factor modification, early screening, early detection, and treatment. But it is sad that it has remained just there. All societies like to have their own fiefdoms and their own programs, and it continues to be so. On the other hand, the entire medical profession, publication, paraphernalia, trialists, lay press, they love reductive approach. One molecule, one procedure, one drug, which can be the wonder drug or wonder procedure, but it is not so. Well, quite some time passed, and about 8 years ago, 2017 to 18, a landmark trial was published in New England Journal of Medicine called CANTOS trial, where a chimeric antibody, canakinumab, was studied to reduce residual inflammation, because we know that inflammation is at the root cause or intermediate cause of all these non-communicable diseases, including heart disease and cancer. Now, where all these patients were adequately addressed with other treatments, all those who had, I know I'm talking to lay people also, there's a test which measures inflammation. Guided by that, they gave this medicine to those who still had some residual inflammation in them, and after 4 years, there was reduction in cardiovascular events. However, on further follow-up, it was found that they had dramatic reduction in development of lung cancer also. So what this told, this was a proof of concept study, the second one, which showed that at the molecular level, the problem is the same, the triggers are same, the pathways are same. It is just that some people may have cardiovascular disease early in life, or cancer later in life, or diabetes earlier in life, and so forth and so forth. Problem is the same, the triggers are same, the pathways are same. To give you a everyday quotidian example, how things get compartmentalized. I know I'm talking about eminent cancer physicians, surgeons, and radiotherapists. I'm giving WHO statistics. Cancer kills, this is about India, 1 million people, tobacco kills 1 million people in India every year. And this is 10% of all deaths. But most people equate tobacco with cancer. A lesser realized fact is that 50% of all these deaths are due to cardiovascular diseases. Less than 10% are due to cancer.
True.
But tobacco control, smoking control is almost hijacked by the cancer people, leaving vast number of deaths and destruction unaddressed. Well, the news appears to be good, because in last 15 years, all the Nobel Prizes have gone into molecular mechanisms, molecular signaling pathways, including natural processes like fasting inducing autophagy and all that, which has been largely ignored by not only the lay press, but also the mainstream, I would use the word mainstream medical literature, which includes New England Journal of Medicine, Lancet, etc. But you will find them in Nature, Science, and Cell. They are peer-reviewed, very high-impact journals. So much so, I'm a regular subscriber of New England Journal of Medicine for the last 40 years. The first article on fasting was published only in 2017, after Nobel Prize had gone to Dr. Oshumi of Japan for autophagy. It has dramatic results in cancer control at all stages, not only prevention, amelioration, but as an adjunct to chemotherapy. Now, the literature is flowing in, so I wanted to just set the ball rolling that lifestyle is a very loosely used, all-encompassing word. Now, we are talking about molecular mechanisms. When you fast, it is not only an anti-obesity thing. Fasting sets off generation of those metabolic pathways and molecular signaling pathways which generate apoptosis-inducing senescent cells removal pathways, which lead to prevention of cancer, amelioration of cancer, and as a very potent adjunct to chemotherapy or radiotherapy also.
Thank you. Point well made. And as you rightly said, I'm glad you mentioned cancer is also a chronic disease. And many a times we just ignore by looking at it. It's just as bad or as good as diabetes or cardiac problems. So in the process, maybe you would be surprised that some patients with cancers live longer than patients with diabetic problems. So it is actually a state of mind. And the state of mind drives home, drives the treatment and the outcome in cancer cases. Somebody asked a very important point about antioxidants. First of all, you got to define what are these antioxidants. And the best known antioxidant is good water. So these are such vague lifestyle things that we talk about, as you rightly mentioned, that you will either stop living or you'll start living. So if you live well and if you're happy about what you're doing, you can live as long as you would wish to. Now, there would be a few more points, and I believe Dr. Anurag has some slides to show. Would you like to share those slides now, sir? We'll conclude it after that.
Next slide दिखा दीजिए इसकी. Next slide लगा दीजिए. हाँ, okay. So this is the light. There is light after the darkness at the end of the cave. So I requested a brilliant scientist. She is a nuclear medicine chemist, nuclear radiopharmaceutical chemist. She is professor of nuclear medicine in Department of Nuclear Medicine, Postgraduate Institute, Chandigarh. So she was my student in AIIMS. So we did some very interesting studies together. And one such a study was about tamoxifen being tagged to a radioisotope. So it occurred to us that we give tamoxifen to control the estrogen receptor positive cells. And tamoxifen has to be given for 5 years. Now the data shows that it has to be given for 10 years. Why? So we wondered why we have to give for that long. Chemotherapy finishes in 6 to 8 months or so. Radiotherapy 3 to 5 weeks. But why we have to give tamoxifen for that long period? So we found from the literature that it works like cytostatic. जैसे एक आपको कभी यूरिनरी ट्रैक्ट इन्फेक्शन होता है यूटीआई, तो सल्फा ड्रग्स देते हैं या एक सेप्ट्रान एक ड्रग होती है वो देते हैं, तो वो काफ़ी लंबी समय तक देना पड़ता है, कभी 6 months, 3 to 6 months. क्यों? क्योंकि वो भी बैक्टीरियोस्टैटिक है, वो बैक्टीरिया को मारती नहीं है, वो बैक्टीरिया की ग्रोथ को कम कर देती है बस. तो उसी तरह से टमॉक्सिफेन भी साइटोस्टैटिक है. इट डज नॉट किल द सेल्स, कैंसर सेल्स, इट जस्ट कीप्स देयर माइटोसिस, देयर ग्रोथ एट बे, कंट्रोल करके रखती है, उसको बढ़ने नहीं देती. तो इसलिए उसको 5 साल तक देना पड़ता है. अभी डेटा आ रहा है 10 साल तक देना पड़ेगा. तो वी थॉट कि अगर उसको हम लोग किसी रेडियो फार्म से आइसोटोप से टैग कर दें विच विल किल, तो पहले हम लोगों ने उसको टैग करा चूहे में, एनिमल में एक्सपेरिमेंट किया एम्स में. उसको पहले गामा रे एमिटर से करा और उसको देखा कि टमॉक्सिफेन ईस्ट्रोजन पॉजिटिव ट्यूमर सेल्स ग्रो करे एनिमल में, और फिर टमॉक्सिफेन टैग टू अ गामा रे एमिटर. तो इट वेंट थ्रू आउट द बॉडी, इंट्रावीनसली इंजेक्शन दिया उसको शरीर में, तो पूरे शरीर में जहां भी ईस्ट्रोजन पॉजिटिव सेल्स थे उनको जाके उसने टैग करा और उसको गामा कैमरा से हम लोगों ने पिकअप कर लिया, क्योंकि जैसे टेक्नीशियम से ऐड कर दिया था हम लोगों ने. हैविंग शोन दैट, देन वी टैग्ड इट विद ल्यूटीशियम. Lutetium emits the gamma rays plus the beta particles. So beta particles have the capacity to kill the cells. तो tamoxifen गई और उसमें lutetium एक ऐसा आइसोटोप अटैच था जो कि सेल को मार देता है बाई रेडियो एक्टिविटी, जैसे रेडियोथेरेपी होता है, जैसे रेडियो आयोडीन थेरेपी करते हैं थायराइड कैंसर में. तो दैट वाज द फर्स्ट प्रूफ ऑफ कंसेप्ट दैट वी कैन टैग tamoxifen टू a रेडियो आइसोटोप फर्स्ट टू डू द स्कैनिंग ऑफ द बॉडी कि कहाँ पे ट्यूमर सेल्स स्प्रेड हुए हैं, मेटास्टेसिस कहाँ है, एंड हैविंग प्रूव इन दैट देन वी कुड kill those estrogen receptor positive cells by tagging tamoxifen to a gamma emitter, beta emitter like lutetium for example. So Dr. Jaya Shukla was the research scholar in that study, and now she's the professor in Chandigarh. So she has sent some of the for her research work. So I requested her to come here, but she could not come because she had some meeting. So this is how it has been shown here that there is a cell and you can attach some molecule to it, and this will go to the body and this will go to a cancer cell and can have the ability to kill. This is like surgical strike. जैसे आप रडार में देख लेते हैं कहाँ पे दुश्मन है और उसको अटैक कर ले, like that surgical strike. So I'll just skip all these, and there are many molecules which are specific to cancers. And one such molecule is called integrin, and there again they have tagged different isotopes to focus. This also shows angiogenesis. So tumor angiogenesis means जैसे कि आप पौधे को ग्रो करते हैं, बीज को ग्रो करते हैं, तो 3-4 दिन बाद देखते हैं उसकी जड़ निकल आती है. तो उसी तरह अगर कैंसर कहीं पे एक जगह स्थिर हुआ, एक सेल से बना, ये थ्योरी है कि एक सेल से बनता है, फिर वो ग्रो करता है. वो करिए एक पिन हेड साइज, छोटा सा करीब 1 मिलीमीटर दाना होगा, तब तक तो वो बिना वेसल के ग्रो कर सकता है. अगर उससे ज़्यादा बढ़ना है उसको, इट हैज़ टू डेवलप इट्स रूट्स, उसको जड़ निकलनी पड़ेंगी, न्यू ब्लड वेसल्स बन जाती हैं, उसको न्यू ब्लड वेसल फॉर्मेशन या एंजियोजेनेसिस कहते हैं. तो उसी का एक मॉलिक्यूल है इंटीग्रिन. उसको लोगों ने देखा है कि अगर एंजियोजेनेसिस हो रही है, इसके माने कि ट्यूमर ग्रो कर रहा है मोर देन 2 मिलीमीटर. अगर मैलिग्नेंट ट्यूमर को ग्रो करना है तो उसको अपनी जड़ पैदा करनी पड़ेगी, उसका खाना पानी बनाने के लिए अपनी रसद सप्लाई करनी पड़ेगी सिंपल भाषा में. तो एंजियोजेनेसिस इज एन एसेंशियल कंपोनेंट ऑफ ऑल मैलिग्नेंट ट्यूमर्स, इन्वेजिव मैलिग्नेंट ट्यूमर्स. इन साइटू ट्यूमर्स में नहीं होता एंजियोजेनेसिस. सो डिफरेंट स्टडीज हैव शोन. एक साइंटिस्ट थे ओटो वॉन वॉरबर्ग, 1931 में उनको नोबेल प्राइज इसलिए मिला कि उन्होंने दिखाया कि कैंसर सेल सिर्फ ग्लूकोज खाते हैं, कैंसर सेल सिर्फ ग्लूकोज का भक्षण करते हैं. अगर ग्लूकोज शरीर में नहीं होगा तो कैंसर सेल ग्रो नहीं करेगा. तो इसीलिए जो फास्टिंग का डॉक्टर कश्यप बता रहे हैं, और भी जो स्टडीज़ हुई हैं, फास्टिंग का वो रोल है कि फास्टिंग में आपका ग्लूकोज लेवल कम हो जाएगा, इंसुलिन भी कम हो जाएगा. इंसुलिन इज एथरोजेनिक एंड कार्सिनोजेनिक, हार्ट डिजीज भी पैदा करता है, ब्लड वेसल की भी, और कार्सिनोजेनिक भी है इंसुलिन. तो डायबिटिक पेशेंट्स आर मोर प्रोन टू कैंसर. थ्रू आउट द वर्ल्ड, large number of studies, follow-up studies have shown that diabetics are more prone to have breast cancer and some other cancers. So this may be one reason, because the glucose level high है और cells जो cancer cell बन रहे हैं उनको खूब खाना पानी मिल रहा है, वो grow कर रहे हैं, मोटे हो रहे हैं. तो अगर ग्लूकोज नहीं देंगे तो कैंसर सेल मर जाएंगे. तो इसकी बेसिस पे पेट स्कैन होता है. पेट स्कैन में आप ग्लूकोज को एक आइसोटोप F18 होता है, फ्लोरीन 18 से अटैच कर देते हैं, उससे पूरे शरीर में देते हैं. और ये पिक्चर आप देख रहे हैं, तो इसमें ये पेट स्कैन में जहाँ जहाँ पे ग्लूकोज ज़्यादा खा रहे हैं सेल्स, वो पॉजिटिव आ जाते हैं. तो पेट स्कैन से पता चल जाता है कि कहाँ पे कैंसर सेल्स हैं. तो इसी पे और वर्क हो रहा है. तो दिस इज अ न्यू एरिया, एंड पीपल आर नाउ वर्किंग on not only demonstrating where cancer cells are, but also killing those cells by special attaching, like this one protein, fibroblast activation protein एक है, और उस पर भी लोगों ने टैग करके देखा है. डॉक्टर जया शुक्ला फ्रॉम चंडीगढ़ ऑल्सो वर्क. तो शी हैज अटैच लुटीशियम. लुटीशियम जो बीच वाला ये आप देख रहे हैं पिक्चर, लुटीशियम एक ऐसा आइसोटोप है जिससे कि बीटा एमिशन होता है, जिससे कि सेल्स मर जाते हैं. तो उससे हम ये भी देख सकते हैं पूरे शरीर में कहाँ ट्यूमर फैला हुआ है पिक्चर देख के, और फिर उन सेल्स को वो मार भी देगा. तो एक ही दवा, एक ही बाण से 2 चिड़ियाँ मर जाएंगी. तो ये संक्षिप्त में, दिस इज वन एरिया वेयर वी आर गोइंग फॉरवर्ड, एंड सो आई विल स्टॉप हियर. थैंक यू.
It sounds brilliant. Your thoughts, your take on?
First of all, thanks to all of you for patiently being here at the end of the day. So I'll speak very briefly on my session and the way forward, which is about disruptive things. I'll also continue forward the thought by Dr. Kashyap. There's a lot of similarity to various diseases, and the way forward in all of them is going to be through regular measurements. When these measurements become deranged, whether they be inflammatory measurements or activity or metabolic, these are the foundational things in which cancer rises. There's a very famous statement, we're all dying just at different rates. Very similarly, you can even say we're all developing cancer just at different rates. Many people have shown the emergence of cancerous cells occurs all the time. It is a combination of your immunity, luck, and a variety of other factors which could include substrates like glucose levels and food for them, ability to take root, that determine whether we get cancer, the disease, or do those cancerous cells simply end. So how will diagnosis become better in the future? One could argue the most important thing will be to prevent the problem from occurring before it comes stage for diagnosis. That will occur by identification of modifiable risk factors that you can manage. Unfortunately, one of those things is going to be lifestyle and activities, some of the hardest things in this world to modify, but continuous feedback is going to be critical. And a lot of people will start using continuous health data acquisition by wearable devices in helping them. Something as simple as changing in their metabolic programming would be run through continuous glucose monitors. Today we think of CGMs for people with diabetes on insulin to better manage it. Tomorrow, CGMs will become routine, so people get to know what is their metabolic profile as they go forwards. Then comes the possibilities of diagnosis. How early can you diagnose? You can diagnose so early that only the DNA of the tumor or a cell of the tumor is floating around in the blood. That's how early you can go. And we saw some examples of that today. If you wait for the tumor to become of the size that it is detectable by any means that is anatomic, which means it looks at radiodensity, it looks at something else, but plots it on an image of the body, then you are certainly looking at millimeter levels. A millimeter of tumor contains a large number of cells, so you're already beyond a particular stage. Importantly, there will never be a perfect test, because the fate of a lesion is never completely decided. You may find circulating DNA in the blood, you may not necessarily have a firm diagnosis. You will still need human decision making, and that decision making we need to continuously seek to improve. As we stand today, many tests have false positives and false negatives. There is a severe lack of understanding on what this means. And I often give this very simple example to people, and perhaps it will help some of you in the room. If you created a test that was 99% sensitive and 99% specific, you would say, my God, I have a great test. You knew 1% of the people in a village have that disease. Let's call it breast cancer, let's call it anything. You went out and tested everybody. What is the probability of a positive being false? Most people intuitively say 1%. They'll say, I have a test that is 99% sensitive, 99% specific. I tested everybody, somebody is positive. The chance is only 1% I'm wrong. Mathematics tells you the answer is 50%. How? The 1% out of 100 will get picked up, but of the other 99, one false positive will come. So 2 positives will come when only 1% actually had the disease, which means as we deploy these tests to more and more people for no clear clinical indication beyond desire to know, we will end up with that many more false positives. There are only 2 solutions. Come up with 100% specific tests. My colleagues here know how hard that is. Even if you were to fix the other part, the test itself, there will be technical problems that will lead to false positivity. PCRs are 100% specific when done properly. But contamination is a problem that PCR can become positive. But in any case, we're going to have to deal with this as well. So as I look toward disruptive technologies, mostly coming out of molecular, it was wonderful to hear you talk about the fact that the medicine of future may not be appearing in the New England Journal, but actually in Nature and Science, or these days Nature Medicine and Science Translational Medicine. So all of these journals are starting to intersect. Those of you who want to see the future will have to move towards more science journals, less medicine journals. Again, it's a sensitivity specificity. As you go towards the science journals, you will see lots of stuff that never actually ends up coming to medicine. But if you only read the medicine journals, you will miss the big new thing when it started to come out. These are choices we'll all have to make, depending on what is it that we do. I wish you the best and a great progress. I do think all things are curable and controllable, but keeping our aspirations and our expectations rational would be important. Until then, good health is good health. The same things you would do for other good health will also be good for breast cancer. Thank you all.
So you heard the way forward, and you can actually see it like a dizzy dream. You may think so many things would happen. But believe you me, when we started talking about cancer way back in 90s or 80s, when we were training, it looked like a disease impossible. But today we talk to a cancer patient, especially a breast cancer patient, and many a times when they ask me, will I be cured? My answer is yes, of course. And you're only as good as you want to be. I mean, for the survivors and conquerors, do not look for answers from outside. Most answers come from within. And there was a beautiful study published when Colonel was mentioning about autophagy. It was something similar, but we did a write-up on tricking a cancer cell into dying or committing suicide, apoptosis to be induced. And there's so many ways to do it, including meditation, yoga, and we have always kind of ignored these corners. We have always put them in the third space, something we cannot quantify, can't measure. And it is very similar to people asking you a very, very valid and very regular question. Why do you believe in God? Have you seen God? So your answer is, I haven't seen God, but I believe. So that would not satisfy a scientist, because the scientist is going to say, I would only believe what I see. But then your counter question could be, do you see electrons? You'll say, no, but you believe in electricity. So therefore things happen with or without you, and they happen in spite of us. But a lot of progress has been made in the management of diseases, including cancer. You are familiar with the old stories of people dying of tuberculosis, dying of malaria, cholera, pandemics of plague, etc. You don't hear of them. I am sure the future belongs to those who believe in the beauty of their dreams. As Roosevelt said, if you really believe it's going to be fine, the responsibility lies in the present, because future is born out of the present. The beautiful thing about today is, yesterday it was today, yesterday, tomorrow it will be today, tomorrow. So it is today and the present moment that you live in. And the present moment is positive. There's no reason to feel negative about it. And when you're talking about creating or spreading that message to those who are affected by cancer, or those who have their relatives or close ones affected by cancer, the only message to be given is it's just another disease, and diabetes is as bad. So no one is trying to say, there's a patient of papillary cancer thyroid who came and is a medical student I operated 5 years ago. Now he's doing post-graduation. So when he was a second-year medical school student, you can understand, he's just joined medicine. He has dreams, and suddenly he's diagnosed with papillary cancer thyroid. So I told him what? Cancer shouldn't have happened to anybody. But if there is one cancer that can happen, is this, because the survival is 20, 25, 30 years. He said, are you sure, sir? Yes, most patients live forever. So it's like giving that hope. In any case, somebody was talking about the prediction with artificial intelligence, and I was saying the same thing at that time. Nobody should write a horoscope. When patients come and ask me, how long will she live? The answer is, how long will you live? Can you tell me? You had COVID and very, very fit people just dropped dead. So do not write horoscopes. Do not think too much into it. It is a disease. It's a problem which can be fixed. We are understanding the problem better. They talked about some aspects of it. I'm sure there are many loose ends. We are getting there. And Prof. Agarwal was mentioning about specificity. We are trying our best to be 100%. But I'm sure it will still be a lacuna somewhere. Because did you ever think what teaches a cancer cell into changing its behavior? I published an article in 2004 based on a very interesting story which I'll share with you. I had a postgraduate, his cousin was an air hostess in Indigo flights which had just started that time, and she was very young. She had a lump in the breast. It was diagnosed to be cancer. And he said, can we conserve the breast? That time he used to say, don't take that risk because the local recurrence can kill her. So we went ahead and she wanted a mastectomy. I said, maybe I can make an effort. She said, no mastectomy. So each time I'll go and put her on neoadjuvant chemotherapy, I'll tell her, don't worry, you'll lose some hair, but the hair that come back would be prettier than the ones you have now. You may feel a little low now, but it'll get better soon. But each time she came back and told me, I never had any vomitings. I had no loss of hair. I said, maybe next time. She had 6 cycles with minimal loss of hair, minimal toxicity, but very little response. So toxicity is a predictor of response. We followed her up, she developed a cancer on the other side. Same story. We observed it over a period of time. We looked at all our cases, and this boy comes and tells me, sir, I've seen it in many patients. Those who have toxicity, they do better. So whenever the pain comes, it's a sign of life and it's a sign of healing. So don't take it negatively. And we looked at, can it be there for the cancer cell be tricked into thinking that, it should die. So there's so many things happening simultaneously. But when I looked at it, the bottom line I found was, if you're happy, that's the best antioxidant. If you're joyful, the difference between happiness and joy is, one is physical, the other is spiritual. If you're spiritually happy, most things get healed on its own. Don't you ever look at it, looking at our body? This is a Shiv Sutra, very interesting, where Parvati is asking Shiva. That's a CME where only 2 people are there. One is speaking, the other is listening. He had no audience like this, so he had to talk to her only. And probably she had to listen to him. So she asked him a question, what is moksha? So he was giving certain examples. So he said, when you see a just newborn baby, born just now, look at her, look at the baby. Aren't you in a state of awe? What is it? Look at the sky in the middle of the night, you're sleeping in the forest. The stars that you see, the galaxy looks so big. Go and stand in front of the ocean, you see it's so huge. That's moksha. When you suddenly realize how tiny I am. So in the process, please understand, moksha is in how you feel about it inside. Everything, this body itself is a miracle. So when you look at this body, we open it up every day, and I open up and I'm in a state of trance. How can anything be so perfect? How can it be so good that everything is backing up the other? So how does the cancer learn that this fellow is now taking Adria-based chemotherapy? Let me develop resistance. This is called acquired chemoresistance. Who teaches the cancer cell? Who taught COVID virus to develop, mutate and go into other cells? So there is very little we know. And from whatever little we know, we are just scratching the mountain. We try to share with you. And the end of the day, I would like to share with you that most of it was our ignorance that is leading to some light at the end of the tunnel. Little bit. We know very little. There's a bigger question to be answered. A happier, joyful person who's meditating regularly, taking vegetarian food, has been found to do better than others. People still get cancer, mind you, but by and large. The moment you see an animal dead on your plate, it sends a signal, and it has been proven beyond doubt. There are substances released when the animal is slaughtered. They are in the circulation. These are carcinogens. So therefore, if you eat and live like a, I met a very, very old yogi in the Himalayas long back, and I asked, he's 140, they say. I couldn't believe it, but that's what everybody says. He's been there when the Britishers came, maybe. So I asked him, how do you live? He says, I eat nothing which is fried or made. I just pluck it from the tree and eat. That's how he's lived long enough. Well, whatever I have spoken may also be all gibberish. But end of the day, there's one thing I would share with you. All that you heard in the day is little bit that we know about it. All of it is not clear, but by and large, things that are known, a happier body does not get cancer. And if it gets it, it fixes it. Everybody sitting in this room has some cancer. Do you know, after 80, when people died and they did a post-mortem, 80% had cancer prostate. It was never detected. And similarly in the women, 85% had DCIS, ductal carcinoma in situ. You screen and you find ductal carcinoma in situ, this lady will go through the same drill of surgery, etc., etc. So, information is a double-edged sword. It's how you take it, who provides it, otherwise it can be a killer. Now, I think before we close, a huge round of applause for all the faculty and all of you. I think that's a very tired applause, so you can clap harder. Clapping is a yogasana. I went to Patanjali for a couple of orations. They taught me this. So they said you keep clapping whenever in doubt. So I do it whenever I'm in doubt. Now, it's good thing to clap. Feels nice. Well, how do we close it? First of all, you clap hard. I'm grateful. Clap even harder for the man behind the show who's made a lot of effort, Mr. Ramesh. I appreciate. Please stand up to get recognized. He, out of nowhere, last year when he called up, he organized it. He started beats for it. So for all those whose heart beats for breast cancer, they deserve that kind of an applause. Secondly, he organized it by getting hold of all the best people. In spite of limited resources and also lots of challenges, probably it was a very, very informative, very successful show. I think we can clap for you once again. All the faculty that was picked up, we wanted to have an integrative approach. When people get up and say, allopathy does this, allopathy does that, homeopathy doesn't do it, Ayurvedic, this is all, you can understand all. It's not acceptable. There's no one way to answer any problem. There are 100 ways to reach Rome as long as you reach there and you reach alive. So there's no question of talking about one being superior to the other. They are all complementary. Everything is. The Siddha girl, she's there working in Safdarjung, they're doing a good job. If they make my patient better, I'm happy. And somebody talked about RCTs or randomized control trials. You must have heard of the parachute trials, as we say. You cannot do randomized control trials for everything. You can't drop 50 people with parachutes, 50 without parachutes to find out how many will die. How many will die? No, more than 50, because some would die of fright also. With the parachute also some people will die. So it's not possible. There is no randomized control trial for laparoscopic cholecystectomy, which is a gold standard. No randomized control trial ever got a Nobel Prize. Most of these discoveries the people stumbled upon, but to trained mind. Apples were always falling. Newton thought of gravity. But it's not that apples were not falling before. So all I'm trying to say is, this is the best way to conduct research, but for everything, it's not possible to do an RCT. So we need to incorporate all the therapies. That's why we wanted it to be an integrative approach. And we wanted to include their inputs so that we can make it better for the patient. I've done trial on curcumin. I've done trial on bhang, cannabis for stage 4 cancer. It works well. It's there in the pharmacopoeia. It's in the American registry for treating cancer patients. So there are many avenues available. So we tried to sum it up for all of you. I hope you found it useful, and I hope you enjoyed it as much as we thought we enjoyed it. And Shruti did a fantastic job of sitting through all the sessions. And a big round of applause. She's the one who conducted the session. And she made it special by taking care of the buffer part, and many a times you overshot the time, and you were very kind to allow people to get on with the sessions. At the end of the day, we appreciate your presence, and we were delighted in the last session, especially when the conquerors came up and gave ideas. I could see the lady with the lymphedema using the same arm. If you keep using it, lymphedema would disappear. It's the positive thought that makes it happen. Thank you all very much. Thank you, gentlemen. Have a great evening. Hope to see you soon. The movie is on. We have made some clips. If you're interested, our YouTube channel, my YouTube channel, would have lots of these videos on survivors, their lectures, the survivor talking, survivor singing, we do survivorship programs. I've changed the name to Conquerors. That's why probably you won't, when you Google survivors, you won't find. Google Cancer Conquerors and you'll find it. Thank you all very much. God bless you all. Good night.
Thank you. Just request Mr. S. Ramesh to hand over the certificate to Dr. Kashyap. Mr. S. Ramesh, Event Editor, The Week Connect. Thank you. And thank you everyone once again. With this, we conclude this seminar.